Oncology and Bone Marrow Transplant. Our second chairperson, Dr. Deepesh Lad, Associate Professor in the Department of Clinical Hematology, PGI Chandigarh. In this session, we have 3 talks. The first talk is sponsored by the MCure and second topic is being sponsored by Novartis.
Thank you, Manaswini. A very good morning to all of you for the last day of the Pgi-Hem-Onc Fest 2023. For the stem cell transplant update, the first talk is going to be given by Dr. Nishant Jindal. And I'm happy to introduce Nishant. He's been my mentee. And we have had both similar career trajectories, starting with the induction at KEM Hospital. Then we got consolidation at PGI Chandigarh. Then I gave him the conditioning regimen while his DM training at PGI, and then he got transplanted at Tata. So he's engrafted now at Tata, and the long-term follow-up is the mentee is doing better than the mentor. So Nishant will speak on choosing conditioning regimens in acute leukemia. Over to you, Nishant.
Thank you, sir. So I've engrafted, but I have still not achieved full chimerism. So it's a true honor for me to be standing in front of all of you at Bhargav Auditorium. For those of us who have trained at PGI, it's really overwhelming to be standing on this dais, and more so because, you know, the session is being chaired by 2 of my mentors, Dr. Deepesh and of course Naveen sir. So I've been asked to talk about choosing conditioning regimens in acute leukemia transplants. I'd like to thank Aryan sir for giving me this opportunity at the last minute. So going on to conditioning regimens in acute leukemia transplants. So I'll be discussing these, I'll first discuss the basic premise. I'll try to define intensity, how it's been defined in acute leukemia transplants. We'll be discussing some clinical studies in acute leukemia. I'll present some data from our center at ACTREC. And then I'll just talk about how we decide conditioning at ACTREC and the newer approaches. So what are we trying to achieve with the conditioning regimens? The first and the foremost is to provide sufficient immunosuppression to ensure engraftment. There is the need to provide stem cell niche in the host marrow for the new stem cells, although this is controversial. There's something called like a graft versus hematopoiesis effect. So even with a very low dose of conditioning, low intense conditioning, you can still achieve good engraftment if you have T cells in the graft, and to eradicate the hematological malignancy in case of acute leukemia or malignant transplants. So again, this is a combination of not just the chemotherapy conditioning, but a combination of chemotherapy plus the graft versus leukemia effect. So to achieve this, there are 3 components. One is the lymphodepletion, which you achieve by giving either low-dose TBI or purine analogs, myeloablation to create space and to eradicate the residual malignancy, which basically uses an alkylator or a high-dose TBI, and sometimes you combine these with disease-specific drugs to achieve long-term disease control. So let's look at how it's evolved. So in 81, Sir Donald Thomas presented his outcomes with TBI-Psi. In 83, George Santos came up with this BU-Psi, a chemo regimen, because TBI was not feasible at all centers, and this was a TBI-free regimen. Then there were trials of TBI at higher doses, 15.5 compared to 12, and then there were multiple trials which looked at BU-Psi versus Psi TBI. And during this time, around the second half of 1990s, we started to understand that what is working in transplants. So this is a paper from 1990, a blood paper, where they found that the risk of relapse was higher in patients who did not have GVHD. It was lower with acute GVHD, further lower with acute and chronic GVHD. In patients who underwent transplants with identical twins, the relapses were higher, and the T-cell depleted grafts had higher relapses. Later in 95, 97, there was published literature on DLI where you further understood that this graft versus leukemia effect is possibly more important than anything else in achieving long-term cure after allogenic transplant. And not all diseases are equally sensitive, so we know that CML is exquisitely sensitive to graft versus leukemia effect, AML slightly less so, and ALL further lesser. With this understanding, there was a trend towards non-myeloablative reduced intensity conditioning. 96 fludarabine was introduced, 98 EBMT authors, they published NMA regimen combining Buflu-2 with ATG, and they found stable engraftment after an initial period of mixed chimerism. In 2009, EBMT defined it, and then we have had these large randomized trials comparing conditioning intensity in AML and ALL. So EBMT tried to define conditioning in 2009. So myeloablative is basically when you don't expect autologous recovery. In RIC, you still expect an autologous recovery, but it's delayed. So it basically lowers down the dose of alkylators, and there are certain thresholds for each of these alkylating drugs or TBI when you call it MAC versus RIC. And non-myeloablative is basically the counts don't go down to zero. You have autologous recovery. You have a period of maybe 3 months of maybe mixed chimerism, and subsequently the graft versus leukemia and hematopoiesis takes over. So with this understanding, there's been a trend towards less intense. You rely more on GVL. The toxicity is lower, but the relapses, one can argue, go up if you come down on the intensity. However, this system of classification has its limitations. I think the first and foremost is that RIC is a big spectrum where you have all sorts of conditioning regimen, and you cannot categorize them together. The second is that you don't look at the immunosuppressive component of the chemotherapy regimen when you talk about conditioning intensity. And this is an interesting study from EBMT where they try to define it using something called a TCI score, where they gave weighted scores to each of these conditioning regimens. The important thing to note is that they were able to kind of identify a group, which is the intermediate conditioning intensity, which had both conventional MAC and conventional RIC, and they found that the TRM was kind of in between MAC and RIC. So you cannot club all regimens in RIC together. There's there's work that needs to be done to identify and define intensity better. So now we will just go through a few studies that have been published in ALL comparing different regimens. So this was from the pediatric group that was published in 2003, small study of 43 pediatric patients where they compared BuSci versus TBI-Sci, and they found that the outcomes were better with TBI. This is a more recent study, a huge forum trial where the plan was to randomize 1,000 patients, but on an interim analysis, there was definite benefit with TBI, and so the study was closed. They included 417 patients of pediatric ALL, and they compared TBI etoposide with either flu, thiotepa, busulfan or triosulfan. The cumulative incidence of relapse was lower with TBI, the TRM was lower with TBI, and OS was definitely better with TBI. There's a caveat that TRM was, unexpectedly low with TBI. 2% was the TRM in this study, which we don't really see in acute leukemia transplants, and this is the Kaplan-Meier, which is showing better survival in the TBI arm. Next was BuSci. This was a more recent adult study where they compared BuSci with TBI. They used IV busulfan, so this is important. So all these other studies have used oral busulfan. This was the first that used IV busulfan, and they used a lower dose of TBI. Instead of 12, they used 9, and they found that the outcomes was absolutely comparable in terms of overall survival, relapse-free survival, incidence of relapse, and incidence of TRM. There was also an attempt towards improving the myeloablative conditioning where they compared TBI-Sci with TBI etoposide, and in both these studies they found that probably the risk of relapse was slightly lower in patients who received TBI etoposide as compared to TBI-Sci. In ALL, there are very limited studies which have looked at RIC versus myeloablative conditioning. I think this is the largest retrospective study from EBMT group where they compared RIC versus MAC in patients who had undergone transplant and were more than 45 years of age. In this study, the RIC regimens included either low-dose TBI, flu-bu, and flu-mil. The NRM was slightly better in RIC as expected. The relapse was slightly higher. But the overall survival was more or less similar. This again, like most studies, did not have any information on MRD in ALL, which I think is something we need to look at. So if we look at evidence in ALL, there is evidence that myeloablative conditioning is probably better, although there's no randomized trial. Among myeloablative conditioning regimens, TBI seems to be better, at least from the pediatric data. From one adult randomized study, TBI appears to be similar to what we see with BuSci. In myeloablative versus RIC, there's EBMT retrospective analysis which says that the overall survival is similar but no prospective studies. And there are no RIC studies which have compared different RIC regimens in ALL. I think that there's more literature in AML, there are more randomized controlled trials in AML. It started with TBI, different doses of TBI, 12 versus 15.75. This was published in 1990, where they found that the risk of relapse goes up and the TRM goes up if you, TRM goes down if you, when you compare 12 versus 15.5, but the overall survival remains similar. That's how the TBI dose of 12 gray was established as the standard of care. Subsequently, after busulfan was introduced, there were multiple trials which compared BuSci versus Psi TBI in AML, ALL, CML. And this is a study where they looked at the outcomes of these 4 RCTs. I'll just focus on the patients who had AML. There were some 172 patients who were randomized in these trials, and they found that there was a non-significantly lower relapse-free survival with busulfan cyclophosphamide. However, we should understand that this was a study that was done way back in 1990s and 2000, and that time they had used oral busulfan without any monitoring of the drug levels. There's a retrospective analysis of IV busulfan versus Psi TBI where they did not find a significant difference in the outcomes when they compared BuSci versus TBI. Again, like in ALL, they've tried to optimize the chemo conditioning regimen. They've compared busulfan versus fludarabine, busulfan versus BuSci versus flu-bu, where they found that the TRM was slightly lower with flu-bu, but the overall survival was similar. Now, more importantly, this reduced intensity versus myeloablative conditioning in acute myeloid leukemia. This is a study from the German group where they compared flu TBI 8 gray versus Psi TBI 12 gray, and they did not find any difference in the NRM or the relapses or the overall survival. This was an interesting study where they looked at patients of AML and CR1 who had a matched sibling donor or a matched unrelated donor. Patients who were more than 50 years of age, they went on to receive reduced intensity conditioning. Patients who were less than 50 years of age, they went on to receive myeloablative conditioning. With reduced intensity conditioning, they used a PBSE graft, and they found that there was no difference in the overall survival in the 2 arms. Caveat being that the GVHT prophylaxis was obviously different in both arms, and the survival was more or less similar. So this is the large BMT-CTN study that looked at this AML-MDS patients, and they compared RIC versus MAC. There they definitely found that the difference was significant. The relapses were much higher in the reduced intensity conditioning arm, and the overall survival was lower. But this study included both patients with AML and with MDS, and the difference was seen only in AML patients. It wasn't seen in the MDS patients. Second, I think they used probably an inferior regimen. It was compared against flu-bu-2, and there were just 20% of the patients who had received flu-mel. So with this caveat, it does show that there was probably better survival in patients who underwent reduced intensity conditioning transplants. In the same year, EBMT published a randomized trial of patients who were diagnosed with MDS or secondary AML, and they found that the difference, there was no difference in the outcomes, but this study included only patients with MDS and secondary AML, and it was predominantly MDS. Less than 10% patients in each arm had AML. So I think there is data that MDS you can definitely do away with RIC. In AML, you still need to think whether myeloablative can be given. There are multiple retrospective studies which have looked at the same. However, the CIBMTR analysis is something which is very interesting. So what they have done is they have not compared RIC with MAC. They have compared different conditioning regimens, and they found that flu-mel possibly had better outcomes with compared to bu-flu or BuSci, 2 days of busulfan, with probably a higher NRM, lower relapse, and better survival. And the authors concluded that there is an optimal relapse-free survival. Bu-4-Psi, flu-bu-4, and flu-mel is comparable. So probably bu-Psi, flu-mel, and flu-bu-4 are comparable, but bu-flu-2 in AML possibly is inferior. So then there's been studies about coming down on the toxicity. There's been a study, a randomized trial of flu trio versus flu bu, 2 days, and they found, this was a non-inferiority study where they wanted to see whether it was inferior or not, but they found that flu trio was probably superior in terms of relapse-free survival and the cumulative incidence of relapse. However, there are not many studies that have looked at MRD. There was a retrospective analysis from the BMT-CTN study where they found that patients who had MRD positivity, they probably benefited from MAC. In MRD negative patients, there was no difference between MAC and RIC, and similar outcomes were seen in the retrospective EBMT analysis. The caveat being that MRD definitions that were used are different in different studies, and there's no consensus on that. So in AML, if we talk about myeloablative, BU-SI outcomes probably slightly inferior to Cy-TBI, but that is data from oral busulfan. What we know with IV busulfan, the outcomes are similar. Flu-Bu possibly safer in older patients. If you look at RIC versus MAC, outcomes possibly better with MAC in AML, although the results are conflicting. It may not hold true for MRD negative disease. In outcomes in MDS are similar with RIC and MAC in both randomized studies. Reduced intensity conditioning, triosulfan-based regimens possibly superior, flu-mel outcomes better than RIC Bu-Flu, and this is retrospective data. So I'll just go through a few slides about our experience. So we've had patients of ALL, 82 patients where we did matched sibling or matched unrelated transplants, and we did not find any difference between TBSI, flu-mel in patients who underwent transplant in CR1, in CR2, MRD negative or MRD positive patients. So in our experience, there's not much difference in any of these subgroups in ALL. In AML, we used flu-mel, flu-trio, flu-bu, a few patients, and flu-Cy-TBI, and we did not find any difference in survival outcomes with full intensity versus reduced intensity in patients who had DRI high or DRI low. What stood out was in both ALL and AML, patients who live on for more than 100 days, who do not succumb to transplant-related mortality, patients who develop chronic GVHD have better outcomes, and this is true for ALL also. So we've also recently looked at our data for flu-mel versus flu-trio, where we found that the mucositis rates were definitely higher with flu-mel, but the relapses and TRM were similar, and there was no difference in the outcomes in terms of overall survival. So what we use most commonly is TBSI in patients with ALL. In AML, we use more of flu-mel. We need to look at the patient factors, disease factors, susceptibility to GVL, remission status, DRI, and the HLA disparity. I've not talked about haploidentical transplants because I think it's a different talk altogether, but in HLA identical transplants, you need to look at the patient factors. If the patient is fit for MAC, you can look at the DRI. In patients with CML, probably you wouldn't go for a myeloablative even if the patient is fit. In other patients, you can choose a RIC regimen depending on the organ dysfunction and tolerance. In those who are not fit for MAC, possibly RIC is better, and this is what is being done across the world. In ALL, MAC is still preferred. Maybe 75% of the patients with ALL undergo MAC, and TBI-based regimens are favored over chemo-based regimens. In AML, probably the distribution is more equal. 50% patients received MAC and 50% RIC, and they used more of chemotherapy-based regimens as opposed to TBI-based regimens. What I think is something that can be done in the future is, one is to customize intensity based on your MRD, based on DRI, based on patient factors, stratifying randomized trial using these parameters, reduce toxicity regimens like triosulfan, thiotepa, TMLI as compared to TBI. There's been some literature on disease-specific drugs, like venetoclax has been combined with AML conditioning.
Can we just summarize?
I'm done, sir.
Yeah.
So regimen intensity is a spectrum. It's important, but it's not everything. When there is any doubt in terms of patient fitness, we would believe that it's best to avoid myeloablative regimens. In young fit patients with ALL, TBSI if feasible. In young fit patients with AML, flu-mel is our favored regimens. In patients with comorbidities, a RIC regimen according to patient and disease factors. And I think strategies to augment GVL hold most promise in the future. Thank you.
Thank you, Nishant, for comprehensively covering the entire topic. This is a really good summary of the entire data on this topic. So we can allow a few questions. Yes.
Idea on use of ETG to reduce the GVHD. In Indian setting, this is a wonderful talk which you have done. So there are two things which we feel as a group at Fortis and the Light Centers at 7 centers is that the rate of readmissions post-transplant, the use of conditioning regime in such a way which reduces the rate of readmissions post-transplant, and second, the GVHD. So use of ATG in your group, has it been tried? Because now for almost 2 years we have been using everything with ATG, Psi-TBI, Flu-TBI ATG, Flu-Trio ATG, and ATG is 2.5, which seems to have brought down the GVHD rates to a single digit, like 5-6%. What's your thought on to that? And of course, you can contribute from Naveen's.
Yeah, sure. So, say in our experience, we use ATG in patients who undergo either mismatched related transplants or unrelated transplants. We don't use ATG in match-related transplants. So I would not know whether there's a much difference, but with ATG, I think a separate set of problems do come in. Even if you bring down the GVHD, especially chronic GVHD, it will come down, but I think the infections become a problem. So we don't use it.
I don't do transplants, so that's the disclaimer. The question that for the TBI patients with ALL, do you see reduced intensity of extramedullary relapses?
So sir, we actually looked at relapses in our patients with ALL and AML, extramedullary relapses. So one thing is that GVL is not as effective in terms of extramedullary relapses as compared to medullary relapses. But from the limited analysis that we had done, there was no difference when we compared TBI versus non-TBI regimens. But then the extramedullary relapses, the numbers are so small, at least in our, because there's maybe 90 ALL transplants. So I don't think we can really, but in the literature that I had looked up, there's no mention of more extramedullary relapses just because you did not give TBI.
So last question.
Rajinder Bajwa from Columbus, Ohio. I'm a transplanter. Just a comment. I liked one of the last bullet points you had, that how to increase GVL effect. In ALL and AML settings, in the pediatric settings, there are now data which have shown that if you don't do methotrexate in a matched sibling donor setting and just do, like Psi-TBI or whatever your conditioning regimen is, but just do calcineurin inhibitors, then the risk of relapse is lower in patients when you just do a single calcineurin inhibitor for GVHD prophylaxis as compared to the methotrexate and CNI arm. So I don't know if in the Indian setting, especially this is more applicable when in patients with refractory leukemias, where you really don't know what to do. And you've been able to take the patients for transplant who have just become MRD negative by XYZ measures. So how to exploit the GVL effect to your best advantage so that that patient, even in first transplant setting, you can then say, okay, this has done wonders. And we've started using that regimen at our center with good results. Just wanted to comment, and if you have thoughts, we would love to hear that.
So I think we have to go to the next talk, but I think that's, we have not used only cyclosporin, but in patients who've developed severe mucositis and that we can't give methotrexate, when we compare that cohort with the cyclosporin methotrexate cohort, I don't think we found any difference in the relapse, but of course they are small numbers. The other way of possibly augmenting the GVL would be to taper and stop the cyclosporin early, even when you're giving cyclosporin methotrexate. That would be my thought on it. I think we'll need to, yes sir. We'll need to then go on to the next talk.
Yes, sorry, it's an interesting point. So what we have started doing is you give calcineurin inhibitors till engraftment and then start tapering.
Yes.
So by the end of, say, day plus 28 or day plus 30, you are actually off. And, but this is in high-risk leukemia settings because in the young adults, sometimes it's very hard to even to get them to be MRD negative because you only take them to transplant when they are MRD negative. And it's very hard to take them to a state where they are MRD negative by CAR-T, Blina, inotuzumab, you name it. And so what we do in those cases is don't give methotrexate. This is matched sibling setting.
Yes.
Matched sibling setting, take them to transplant, no methotrexate, and taper immunosuppression as soon as they've been grafted.
Sure.
Within 2 weeks. And we've done a few patients and they had no GVHD. I would have loved if they get GVHD, but so far, no relapses. So,
Sure, sir.
thank you.
Can we
Rahul,
sir,
just quickly, one.
So there are 3 subsets who are able to achieve, who are able to receive cyclosporine and methotrexate. They did well. One subgroup didn't receive cyclosporine and methotrexate because of various reasons. They all died. Another subset who received only cyclosporine and methotrexate, not able to receive, they go on to develop a GVHD. So in Indian setting, when we are using a 12 grade with fludarabine, there's a high risk of GVHD. So, so in your setting, the scenarios which you are telling is, in our setting, all people die because of the GVHD. So we have got these groups of people, and not in 1 or 2, but like 10 each in these subgroups.
Sure, Rahul, we can discuss
we can
that in
discuss
the
this later.
break.
Thank you, Nishant, for a wonderful talk. The next speaker, we have Dr. Joseph John, who is the professor and head of hematology at Christian Medical College, Ludhiana, Punjab. And he needs no introduction to this audience. He is a deep thinker in this field of transplantation in India. And he's also a philosopher par excellence and a speaker par excellence. And he'll be speaking on chronic steroid refractory GVHD. Over to you, Dr. Joseph John.
Thank you for that introduction. And from this exciting discussions of conditioning, we go through the GVHD. And that's my disclaimer because this is a sponsored talk. My presentation will be covering, this audience is not alien to what GVHD is and the problems. I'm only giving some recaps on various risk stratifications, some definitions, because that's where I also stumble upon to define refractoriness in GVHD and to make the clause. So I will try and make some clarification there and some treatment options in chronic GVHD and to elaborate on ruxolitinib in the last 5 minutes. This is an article written by Paul J. Martin on how I treat steroid refractory acute graft-versus-host disease. And he has a lot of publications in compared to GVHD if you look at the PubMed. But what struck me is that, truth to be told, I do not know how to treat steroid refractory acute GVHD. And that's the situation for most of us. It's not an easy situation for us. So the question is why we risk stratify is because assigning risk stratification to patients will enable us to improve the health outcomes in terms of intervention, prognostication, and then prioritization and what is to be given, and resource allocation is the important part. So we continue in our pursuit for this predict and prognosticate and trying to get the too cold or too just right is the issue. Now that is the holy grail in transplant. We talked about transplantation as a glamorous part in the morning, and what it makes unglamorous or most difficult is 2 things I would say. The prediction of the quality of life of a transplanter is, one is MDR infections and second is GVHD. Of them I would put GVHD as the most predictor for poor quality of life among the transplanters. In the spectrum of GVHD, we see that acute and the chronic, they overlap each other. And that definition, I think it's a recap for everybody. It is not a watershed line at day 100 now. You can have GVHD of chronic coming early and then overlap comes in. And that sometimes becomes extremely tough to manage when you have acute and chronic GVHD overlapping there. So that's the definitions for us to classify it adequately. and that is the subcategorization. So 100 days, it could be overlap, it could be classic chronic GVHD, it's this classic acute GVHD, and then there is this overlap. And for the acute, you must see that is a persistent, recurrent, and late onset varieties. Distribution of acute GVHD it happens usually in the GIT and the skin, and liver is slightly lesser, and GIT becomes one of the most toughest things to manage. There are various classifications we understand, from Glucksberg to MAGIC classification. Each classification is trying to examine the prediction, the survival, TRM, but none are trying to guide the therapy as of now. Chronic GVHD classification, to some extent it will help us in guiding the therapy. MAGIC came up with 2 biomarkers which could be used, and look at MAGIC algorithm probability to look at this and say how badly the crypts are damaged, or can you predict the pathophysiology happening inside the gut by looking at the biomarkers. Of course, these are going to add value to us, but that's a holy grail which is still we are exploring. Chronic GVHD is not time bound, and it happens in about 20 to 40% of the patients. Now that's something which we have to hard truth, which we need to understand and handle it. And of course the conditioning regimens can predispose to somebody having a chronic GVHD or not, and for that matter acute. Chronic comes a little late, and of course I would say many of us hard pressed on time. Chronic GVHD is handled suboptimally, I must confess myself. And there are various classifications in terms of Seattle, CAVM to NIH classification. Earlier was limited, extensive. Now we look at the 10 organs and look at global scoring, mild, moderate, severe, and that gives us a handle on how much and how intensified we need to treat. Of course, the mouth, skin, and liver becomes the commonest on the top. Now, joints and fascia are something which we are seeing more often, especially with RIC transplants which we are doing. And that is something which we need to address, and it is more and more being recognized as GVHD. And of course, we must understand as the transplant survival improves, we are going to handle more of chronic GVHD as well. So mild, moderate, and severe are the classifications which is sent by NIH 2005, and from there, based upon one organ or more scoring, we say we want to intensify the steroids at a higher dose, add on another one, or continue with the CNI which he is on. So the truth to be told to this situation is moderate and severe, about 50 to 80% of our patients are of the 40% patients who are going to get chronic GVHD. Moderate would be about 50 to 80%. And therefore, we need to have a tool to look at that. Pathophysiology, the possible propositions of why it happens, we're still unraveling that in terms of it is a T-mediated, B direct, or only T, or T and B combined with a lot of fibrosis and macrophages there. We still haven't got the full handle on it, but various studies are happening along the way, finding out the exact mechanistic way of having chronic GVHD. So approach to chronic GVHD, number one, categorize the organ involved, confirm the diagnosis by diagnostic finding, distinctive finding, or a biopsy if you can do, and calculate the score, mild, moderate, severe, and treat. So that's step 1, 2, 3, 4. But it gets complicated. When we have to do this in terms in an OPD, we would need at least 10 to 20 minutes to be spent on a particular patient. So unless you have a good resident who is interested in it, a project going on, or a transplant nurse or a physician assistant, these things can get difficult in the OPD, because all the chronic GVHD is going to be managed in the OPD. And certain differences were there when the 2005 was modified in 2014. I wouldn't go into that, but essentially joint and fascia got added, and the precise body surface area was a tough thing because it was like a burn score calculation that has been removed. So essentially, in terms of steroid refractory GVHD, we have the steroid refractory acute GVHD, we all understand and we've been following that. Whereas in steroid refractory chronic GVHD, one of the definitions is to use 0.5 mg per kg for every day, or 1 mg per kg alternate day for 30 days at a time. It's a time-defined definition which has been given for steroid refractory chronic GVHD, and it progression after 2 weeks on prednisolone. Similar to the acute GVHD, progression after 2 days or no response after 7 days, it is lack of response after 4 to 6 weeks. Active, moderate to severe GVHD as per the NIS criteria requiring a higher dose of steroids. Now these are different studies which I've used, but definitely if we were to analyze it ourselves, we need to stick to one of them and based on that analyze that. So the overall response is based upon complete, partial and stable. It's important especially if you want to analyze it subsequently. Essentially now we are coming to a group of patients who are steroid refractory, and what next is the question. And if you look at any guidelines after steroids, and if it has fulfilled the criteria of chronic GVHD, the play field is wide open, and from ECP to various drugs and ruxolitinib, it has been mentioned, and there is no second line defined as of now in terms of guidelines saying that this has to be given. That is the space where ruxolitinib I am trying to explain to you based on the paper which came in NEJM. So 50% of the patients who develop chronic GVHD can become refractory. That means if we had 100 patients transplanted, 40 of them may get chronic GVHD, of them 50% of them may get steroid refractory GVHD, but for example then it is about 10 to 20% of all patients may require a second line for chronic GVHD. That's the assumption and the conclusion we would make from this. So there is an unmet need here, and the goals in these situations is, one, we need to take off the steroids because steroids are going to be harmful. We cannot give it for long term. So that is goal number one, plus prevent the long-term toxicity and reverse the side effects and improve the survival as a hard endpoint. So to reiterate the point that inadequate response to steroid increases mortality, and therefore more argument towards usage of ruxolitinib at an early stage. Now the question is, should we consider 2 drugs along with steroids because we know 50% of them are going to get resistant? Those are answers we do not know. There are people looking at, instead of steroids alone, should we add 1 more based upon the severity of the acute or chronic GVHD? Long story short, if we have to give steroids for a longer time, they are going to have higher mortality. And the cause of death, one of the major causes of death post-transplant after 100 days or before 100 days is one of them is steroids to be given. That's what the playing field I mentioned. Once it is steroid refractory, all of them, how we are cycling this in our practice is, first is severity, cost. We are deciding the second, after the steroids, we are deciding based on the cost, and if 2 costs are the same, then we decide based on that. ECP, if you have the ECP, people are bringing in ECP upfront, maybe alongside the steroids also. But these are all studies which we do not have 100% answers there. So if you look at the options we have in chronic GVHD, if you see that it is a huge variety of drugs, and of course ruxolitinib is taking more stage there with reasonably good and oral medication which is there, which can be given. So REACH2, for those who have not gone through this study in detail, I'm sure most of the transplant center would have gone through this in their journal clubs. Ruxolitinib versus best available treatment, and it is shown a failure-free survival which is better in favor of ruxolitinib. And in terms of side effects, ruxolitinib fared reasonably better than the best available therapy because of the steroid which is continued there in the other or other immunosuppressive agents which were brought in. Only one thing which is, in this study they mentioned that the CMV infections were lesser or the same as compared to the available therapy, but in practice I see slightly more preponderance to CMV infections in Jakavi patients, on Jakavi patients. In terms of overall response, this is something fantastic. In terms of 50% of the patients can get responded if they are steroid refractory is a very good thing to understand, and to have that drug as a second line is a big reassurance for any transplanter. When they looked at all the subgroup analysis, whether it is age-related or otherwise, prior GVHD, all the other confounders, when they had taken, the ruxolitinib had a trending towards it, and many of the parameters were clearly on favoring the ruxolitinib arm in terms of the overall response rate. When it came to the transplant-related history, whether it is myeloablative, non-myeloablative, reduced intensity, ruxolitinib has a favor towards that. It is almost like when you give factor VIII, you have FIBA available or you have 7A available, you have the sense of confidence that even if the patient develops inhibitors, you can give something. It's the same feeling we have when you have a GVHD patient and when you have steroid refractoriness is there, and at least we have a backup plan which can be given. Same thing is demonstrated higher organ responses. It is not organ specific. Earlier we used to say that if liver is predominantly involved, use the particular drug. If gut is involved, use vedolizumab. Jakavi or ruxolitinib seems to be good across the board. And it is not organ specific. Again, a forest plot reporting the same. And of course, the steroid consumption is definitely coming down. And that's a primary aim if you want to give a steroid sparing second line drug, and that the box and whisker chart is showing that. Cytopenias were more common in the ruxolitinib because anemia and thrombocytopenia, we need to have dose adjustment in that situation. CMV infection in this study was less, but seems to be that our setup, it is more, maybe because the CMV incidence, the prevalence of CMV in our setup is much higher. Reactivation seems to be much more. So in summary, ruxolitinib seems to give a better overall response rate. Significant freedom from survival is better, and higher response rate regardless of the organ involved. Thank you so much.
Thank you, sir, for that excellent presentation. We can take some questions.
Thank you, that was great overview. We all know that peripheral blood stem cells as a stem cell source cause chronic GVHD. I'd like to know what is the trend in India at least, because despite knowing that PBSCs can cause chronic GVHD, in the Western world, people still prefer to use that because I think it is easier. Though in the pediatric setting, we always use bone marrow. So wanted to know your thoughts.
Yeah, good question. We debated this much times. So two reasons why we use PBSC over bone marrow is, one is because of an earlier engraftment. And for our setup, even a 3-day delay in the engraftment can be detrimental because of infection, especially MRDs are very high. And so that's one. And second is, as you said, it's a convenience issue. And plus, some of the regimens which you're using in thalassemia or other situations, PBSC is preferred for mostly convenience, especially malignancy, we want to use PBSC. Aplastic anemia also, the Western world is using bone marrow as a preferred choice, but we are sticking to PBSC for an earlier engraftment, and many of our patients present late. So we are also exploring the possibility that an early presentation of aplastic, at least start using marrow. That's center to center preference which is happening.
Yes, sir. Dr. Supar.
You stuck to your time, that's great. PBSC in Asian countries, I won't talk of India only, but if you look at the data, Pan-Asian data, there have been comparison of PBSC and bone marrow and non-malignant diseases, particularly aplastic anemia, and in terms of GVHD, the outcome has been shown to be similar with better overall survival with PBSC graft. So the biology in the Caucasian population and the Asian Indian population is a bit different, I suppose.
Yeah, you're right. Bellor had also published this data about 70% overall survival.
I think this would be a very good topic to research under our ISPMT working groups, and it would be a good starting point.
Yeah, I just have one comment, Joseph, on the ruxolitinib. While the data looks promising, but it's not according to all the organs. If you look at the bar charts in the lung and the liver, there is no difference. So while ruxolitinib may be good for some of the organs for chronic GVHD, it's not good for all. And in my opinion, lung is not,
Difficult, yeah.
I mean, ruxolitinib in lung GVHD, I'm not sure whether it really is the right drug. So we certainly need to explore other drugs for at least lung GVHD. Liver can be controlled by many, and you may not require ruxolitinib. In some of them, of course, ruxolitinib is good.
Thank you for bringing that up.
Yes, sir. You can take the mic, sir.
I agree with that thought, I think. In pediatrics, we don't see much chronic lung GVHD, but we do see chronic GVHD. And only last month, I have a patient who has refractory chronic GVHD of the lungs, so much so that despite everything, including Ruxo, ECP, Rezurock, and you name whatever, this child is probably going to go to lung transplant. So I don't know whether you guys use MSCs or do you have access to MSCs?
We do have access to certain centers are using that. Some private sectors are actually promoting that. I don't know, are you using that in NACTREC?
So we've not used it, but Vellore did a study with the mesenchymal stem cells. I don't think that was a very positive study. So I think the jury is still out whether it makes a major difference in all sorts of GVHD, whether it's acute or chronic. But yeah, I mean, it's just when you don't have many options, then you would try whichever you would. Perhaps if you bring them early on, it may be better. But of course, without prospective studies, we can't say that. No?
Thank you.
Thank you. Thank you very much, Joseph. I have the honor to introduce the next speaker, Dr. Sriparna Chakraborty. He is the director of the Institute of Cellular Therapy and Transplant Research Center, the Manashi Chakraborty Foundation, and is the head of the Department of BMT and Hematology, Dharamshila Narayan Hospital. Sir has been a mentor to few of us, especially me and Dr. Pankaj, and I don't think anyone better than him can talk on the past, present, and future of allogenic transplant. Over to you, sir.
Thank you, Naveen, and thanks to Pankaj if he's here. Very happy birthday to Pankaj, even if it's not here. So, don't push me, huh? Maybe this is the last time I'm standing over here for all you know. So, I would start where I left 10 years back, or maybe 12 years back when I came over here in 2011 for Hematocon. I had presented the first 10 patients of haploidentical transplantation, which we did with PTCY. And as you can see over here, the numbers of haplotransplants have increased in the CIBMTR data. That's precisely because of PTCY. I'm not going to go into the details of that because all of you now know it by heart, but what you need to know is just a footnote, is that it's not one fine morning someone came and gave PTCY and it all started working. It was 3 decades of research, started by George Santos and then by the Japanese group. Hisanori Mayumi recently wrote a review on this 3 decades of experience, and it's beautifully captured in the Frontiers. So I would encourage everyone to go through this to understand PTCY better. And what we see in the US right now is for haplotransplants, it's all PTCY. And the data in the last decade shows that in a standard AML CR1, around 40 to 50% of patients are alive and well after PTCY-based haplotransplants. But when you look at the other 50% of the patients who died, you would see that in the first 100 days, most of the deaths are because of either regimen-related toxicity, GVHD, or infection. And beyond 100 days, 50% of the patients are dying because of relapse. In other words, if a patient is alive beyond 100 days, there is a 50% chance that the patient might die of relapse. So that's a very unfulfilling outcome, I would say. ISBMT registry data, which Naveen shared with me last week, shows that haplotransplant have massively increased in India. over the last decade since I made this presentation in 2011. And I would refer to this paper from Christian Medical College, Vellore, where Biju published the data on 250 patients over 10 years, where unfortunately he mentions that 45% of the patients die within the first 100 days because of infection or other causes, and this has remained unchanged in his words over the last 10 years. And that is the Achilles heel of haploidentical transplantation in our country. So in 2010 to 2013, our experience was not very different because we had high mortality, but due to alloreactivity which we experienced in younger patients with haplotransplants. So this led us to question that whether we can do things differently or not. And in this process, we looked at the co-stimulation pathway. Now for those, the younger guys who are sitting over here, you need to understand that T-cell activation is not a one-off process. The recognition of antigen by the T-cell MHC-TCR interaction is not enough to cause T-cell activation. You need a second pathway or a second signal, which is the co-stimulation pathway, which is the CD80-86 receptors on APCs would interact with CD28 on T-cells to cause co-stimulation and lead to T-cell activation. And once T-cells are activated, there is a whole cascade of positive and negative inhibitory signals which will cause T-cell homeostasis at the end. Otherwise, we would be in a constant state of T-cell activation. Now, this was captured as long back as in 1996 by Gribben and Guinan, when they blocked CD80-86 in an in vitro unidirectional MLR assay and showed that when you are blocking CD80-86, you are achieving energy to that particular antigen, and you maintain third-party responsiveness. And with this beautiful demonstration, they did a clinical study which was published at the same time Frank Weversa published the T-cell depleted transplants. They showed that they actually controlled GVHD with blocking 80-86 and CNI methotrexate in haploidentical transplants. But for reasons which I cannot discuss over here right now because of lack of time, it never was taken further, this particular approach. So when we were faced with this dilemma, what to do ahead, we looked at the co-stimulation pathway. And this CD28 and 80-86 interaction could be blocked by CTLA-4 Ig, which is abatacept. Now, if you do this, you block the primary T-cell activation. Now, what happens to these T-cells? These T-cells don't die. They are anergic. They are anergic to that particular antigen in the context in which you are giving. If you are giving them without a context, it causes, T-cell energy which is not going to lead to tolerance. So it's very important to understand the context. Now, even after this is blocked, there would be a group of T-cells and memory T-cells, particularly CD8, which are called co-stimulation resistant T-cells. So these T-cells need to be handled. And the way to handle them with HOT was to combine it with PTCY. So you give abatacept on day 0 or day -1, and then you give PTCY on day +3. So the proliferation of cells which were not blocked by abatacept would be taken care of by PTCY. And we combine this with sirolimus in non-malignant diseases and with CNI, short course of CNI in malignant diseases. And with this data was presented in 2017 BMT Tandem meeting. And I'm very surprised to see, I just would mention because Dr. Bajwa is here from US, I believe he's here. So there is a recent study I saw published, something called a CAST protocol with PTCY, CNI, and abatacept. They're claiming as they have innovated this protocol. Wholly US, isn't it? So this protocol was in force since 2015. And when we published our data at that time, we showed that in the first anaplastic anemia patients, the outcome was significantly superior to those not using abatacept. And this has been shown in a multi-center data subsequently published in TCT journal. Now, this is the data published last year, presented last year by Dr. Sarita Jaiswal at TCT meeting, where in the 42 patients with long-term follow-up, now the follow-up goes to 9 years now. On 42 patients, we had very low incidence of acute and chronic GVHD, resulting in 90% event-free survival. So with this background, when we look at that around the same time, the US BMT-CTN did a study, phase 2 randomized, where they used abatacept with CNI methotrexate, led by Leslie Keane, in unrelated donor transplant, and what they showed was that in 7 out of 8 unrelated donor transplants, there was marked reduction in severe GVHD when they added abatacept, and this led, for the first time, a drug was approved by FDA for GVHD prophylaxis. So mind you, none of the other drugs you use were ever, approved for GVHD prophylaxis. So the thing what I'm going to discuss today, what I raised yesterday was, can we dissociate GVHD from GVL? And that is the Achilles heel of transplant. And if we can do it successfully, we can keep allogenic transplant alive, otherwise not. So when we used abatacept in the non-malignant diseases, what we found very peculiarly was that the NK cells which were recovering in the early stage were very mature NK cells, and which is very contrary to whatever was seen before that in terms of straightforward transplant without anything or without PTCY, where immature NK cells come first. And when we look back, we saw that abatacept was rejected in solid organ transplants because NK cells caused rejection of the graft, whether it's a marrow graft or whether it's a solid organ graft. And because abatacept was believed not to touch the NK cells, and in fact, abatacept was shown in some animal studies, in a study from China, that it increases NK cell cytotoxicity against tumors. So based on this hypothesis and our experience of using CD56 enriched DLI or NK cell infusion on day +7 of haplotransplants, we introduced abatacept on day 0 and then day 7 with DLI on day 7, day 21, and day 35. This is called abatacept prime DLI infusion, and our first data was published in 2018 in BBMT on 30 patients, where we achieved an overall survival of 80% with less than 10% NRM acute GVHD. Now, what we observed in that study in terms of the immune reconstitution was that patients, those who proliferated mature NK cells early on, had much less relapse than those who did not. And we also observed as a proof of principle that CD86 was upregulated on NK cells, which was not known hitherto. And here I would introduce two salient features of NK cells before I show you the next outcome. NK cells are inherited as haplotypes, okay? The KIR receptors are inherited as haplotypes, haplotype A and haplotype B. Haplotype B has got numerous activating KIR receptors. A has got only one, that's 2DS4. And when NK cells mature, they mature or get licensed through expression of KIR receptors. So when we compared our data of DLI alone post-haplo, which you people know possibly was published in 2016 when we used DLI on day +21, 35, and 60. We compared that with the abatacept DLI, and we found that GVHD and progression-free survival was superior in the abatacept DLI group. Now, when we did a subgroup analysis based on the donor characteristics in the abatacept DLI group, we found that those who received transplant from haplotype B donor and the patients who expressed KIR high NK cells on day plus 30 had a disease-free survival of almost 88% compared to 58% in those who did not. And the other thing that we noticed was that patients, those who relapsed within the first 100 to 150 days. There was barely any relapse beyond day 150, and we questioned that why are we not seeing late relapses? What's the reason for that? Because that's a very universal phenomenon. So that made us look into the adaptive NK cells or the memory NK cells. Now, classically, NK cells are not supposed to have memory because they are innate immune, a part of the innate immune system. But exposure to CMV gives rise to a subset of NK cells which have high expression of NKG2C receptor and a low expression of NKG2A with certain epigenetic changes which makes them very suitable for ADCC, cytokine, and cytotoxic effects. And what is the beauty of these adaptive NK cells is that they are sustained. And the second thing, and the most important thing, is that TREGs suppress the conventional NK cells, but they do not suppress the adaptive NK cells. And based on these, background, we did a study on ANK in our haplogroup, and what we found was that, look, as you all know, that majority of our patients and donors are CMV seropositive. So that's a prerequisite for having adaptive NK cells. And that's a benefit we have in terms of generating adaptive NK cells, and CMV reactivation per se did not have any direct impact on adaptive NK cells as it is seen in the West. But what was markedly significant was that the incidence of relapse was markedly reduced in patients who proliferated NK cells early on, adaptive NK cells, and those who did not relapse had transplant from donors who had higher NK cells. And these ANK cells persisted. We followed them up for 3 years and more, and they had persistence of these adaptive NK cells true to the hypothesis. And this caught attention of the Jeffrey Miller group, and Sichoki wrote an editorial on our paper. So the next thing we did was we tried to understand that why some donors are having very low adaptive NK cells despite being CMV positive. And we realized that the gene which expresses NKG2C called the KLRC2 gene can be there in a deleted phenotype, a deleted genotype, which results in low NKG2C or adaptive NK cells. So when we looked at our cohort of malignant transplants, 136 of them, in terms of expression of KLRC2 genotype, whether they're deleted or whether they're wild type, we found that those who had a wild type genotype had much less non-relapse mortality, primarily due to lack of GVHD. And those who got transplanted from donors with high ANK cells had much lower incidence of relapse than the other way around. And when you combine the both, that is, if you get transplant from a donor who has got a KLRC2 wild type genotype and has got high number of ANK cells, the survival was 96.8% disease-free survival. And we then stratified the donors depending on their KLRC2 genotype and ANK expression, and what we found, this is sort of wrongly labeled, we found that those who were deleted genotype had depressed or downregulated regulatory pathway and upregulated T-cell activation pathway, and those who were wild type had it the other way around. And obviously their ANK pathway, ADCC pathways were upregulated.
And
this
please
was
gather in the...
by Dr. Sarita Jaiswal, and this is the hypothesis based on which we claim that a GVL via NK cells which can be obtained by abeta-DLI by suppressing GVHD through T-cell energy, but it depends on the choice of donor. So in our sort of transplants, we are very careful in choosing donors, and our current choice of donors is based on what I showed you just now. And we took this further to understand the mechanistic pathway of how GVL and GVHD is being dissociated. And what this is very preliminary, I will show you the data, it's almost complete, but what we showed was that if we were incubating NK cells with IL-2 or IL-15 and abatacept, there was a marked increase in cytotoxicity, and when the abata-DLI patients were followed up, those who did not relapse, they showed a marked increase in NK cell cytotoxicity against K562 cell line in a progressive manner. And based on this, Dr. Sarita presented in EBMT this year that we developed the concept of ABANI-15, which is abatacept and IL-15 prime DLI. And we used it in myeloma patient post autograft. Those patients who were not in CR, were transplanted, did not achieve CR on day 30, and they received 3 doses of ABANI-15, and majority of them achieved MRD negative CR. So finally, those who are interested in understanding this better, we have written a review in Frontiers. They can follow that. And finally, if we have to keep allogeneic transplant alive, we have to reduce the toxicities to less than 10% and improve the outcome to over 3/4, not 40% or 50%. Then we will be brushed away by the genetic engineers. So thank you all for listening, and I will end over here. Bye.
Thank you, sir, for excellent work that you've been doing for the last decade or more, and showing that the future could be what you've presented, if we really want the results to be better. I only wish that more centers can do it, because I don't think there is too much of the exotic science in which a lot of funds needs to be given, So, that this is something which India can easily do.
So what I would encourage everyone, centers who are interested in using this protocol, we are running a clinical CTRI enlisted clinical trial, to contact us and make it into a multi-center study.
Yes, I think that is something which, we should really look at, Yes, sir.
Can I ask a question?
Yeah, sure.
Yeah. So this was regarding the availability of abatacept. At least for other indications, we have been trying to procure abatacept. It's hardly ever available in India. That's one. Second thing is, if the concept point is co-stimulation blockade, then other agents like ipilimumab, which would target the same, and maybe checkpoint inhibitors, what is the evidence base for use of these in the same paradigm?
Ipilimumab is not co-stimulation, it actually blocks CTLA-4. Here it's blocking 8086. So it's blocking the activation pathway, whereas ipilimumab is unleashing the activation pathway. CTLA-4 binds to 8086 and prevents T cell activation. So you are taking that inhibitory thing away by ipilimumab. Abatacept is just to the contrary.
So availability of abatacept?
Availability is a big issue, once we get into a multi-center mode, we can press BMS for this particular thing.
Thank you.
So right now what you have to do is, it was available in India. It was being used by the rheumatologist for rheumatoid arthritis, but for some reason it went off, and now you can, individual patient import license can be taken, or institute license for importing can be done. But as Sir just said, that if it becomes a bigger trial, we can actually request the parent company to bring it back. It was in India earlier. Yes, sir.
Hi. Gautam Vortakar from MD Anderson. Fantastic talk. Really appreciate the science behind it also. I learned a lot. The question is, can you also think of allogeneic off-the-shelf NK infusions post-transplant? There's some data, right, to suggest that NK infusions post-transplant, can be a strategy to prevent relapses.
See, in a half-matched setting, we have the advantage of having a ready donor for giving NK cells. So that's what we do actually. We are actually doing the Abani-15 and allogenic as well. So we do two steps. One is we collect the PBSC and give the transplant. On day 7, we are doing a second lymphopheresis, collecting the thing, isolating NK cells in 3 aliquots and treating them with Abani-15 protocol and giving it to patients. Now, whether this can be an off-the-shelf thing is, I'm very open to it, but it would be more applicable, I would say, in an autologous setting where you need to boost the, the immune-mediated GVL effect. Yeah.
One more, can I ask?
Sure, of course. We have
one more
few
question.
minutes.
It's a little, in a different way. I'm an AML doctor, so one of the thoughts was that many of the patients, at least maybe in the Indian setting, and even outside also, that infections kill many of our patients very early on, right? And many of them, they don't make it to transplant. The question is that with the lower intensity regimens, azacitidine, venetoclax and all, now can we even think about a scenario where we can potentially do relatively away with the high intensity regimens, get them to a reasonably good remission, right, and then take them to a haploidentical transplant where the count recovery is much quicker also. You don't have an extended period of cytopenia, and maybe use some of these, additional mechanisms to prevent relapses.
Yeah, absolutely. I mean, that's the ultimate goal of allogenic transplantation, to reduce the regimen-related toxicity. I mean, Nishant beautifully presented the regimens, and we need to understand that when I mentioned that our target is to have less than 10% NRM, one of the arms has to be reduction in regimen-related toxicity. Absolutely agree.
Wonderful. I think just wanted to know, have you done a cost-benefit ratio analysis of your regime in the Indian context? How much benefit individual person gets over and above, and how much is the spending in the setting? And second part is, how many times he has to get readmitted post-transplant? Because many of times we just consider the cost of the transplant and not the entire transplant cost. So if you can just throw a light on that.
Yeah, absolutely. You see, when we are transplanting a patient, whether it's for thalassemia or for a malignant disease, the aim is to cure, okay? So what is the best possible option for a cure is what we are going to provide. If you are asking the additional cost of abatacept, the additional cost of abatacept in a 10-year thal transplant is in the range of another lakh or so, which is not a humongous cost. And because there is absence of GVHD, there is a market cost benefit because obviously we did a calculation based on our previous patients where, I mean, the health economics calculation is complex, but at the end of the day, there is a huge benefit if you can reduce GVHD, huge benefit.
So Rahul, the abatacept actually is not as expensive as many other drugs that we give. I can't remember the cost which comes to our institute because we import it through an institute license. I can't get it, but I know for sure that it was not that expensive. I think the DLI, anyways, when you collect stem cells, you collect enough, you can make the DLIs and keep it. That's the way we do it. So I think I'm not very sure that the cost would be more than, say, what we would do for a T-depleted transplant with the Milteney, where, you do the alpha-beta depletion. That itself is also at least 10 or 12 lakhs or whatever. So, someone has to do the cost analysis, but abatacept per se is not that expensive amongst many other drugs that, are being used.
When you raise the question of DLI, you see, when we are using DLI, okay,
yes, sir.
When we are using DLI as we have used in our previous publications, and even when we are using Abata DLI, When we are using Avatar DLI, we are using from the parent collection.
Yes.
We are freezing the parent collection in aliquots and we are using them.
Yes.
But when we are doing the Abani 15, we are doing a neat
sure.
collection.
Yes, that's what we do at least for is preserving
I
DLI,
mean,
and that's we do routinely.
In fact, the advantage of G-mobilized DLI is that there is less GVHD with G-mobilized DLI that we have shown earlier.
So, as the chairperson, I take the liberty of the last question, sir, before we end this beautiful session. So, when we analyzed our haplo data, and hopefully we'll publish it in the next few months, among the donor or patient characteristics, we found that if the patient is BW6, which means that there is no ligand for the tier 3DL1, they did much better. Now, would you have any thoughts on why it could have, why it may happen, and whether you would think of whether that really is true, that, those who are BW6 patient, irrespective of what you do, their outcomes were better?
Two things over here. When the Italian groups have looked at the different, NK ligand mismatches, whether it's C2 and KIR2DL1 or C1 and KIR2DL23 or the 3DL1 BW4 BW6, they found that C2 was the best, followed by this. And what you are saying is what I would champion, that look at our own population.
Yes.
Each population would be genotypically and phenotypically responding differently than the Caucasian population. So your data would be very important in the Indian context. Now, when we analyzed our data in terms of, because we did an entire immunogenetic profile on all the donor patient pairs, we looked at everything, the HLA-ABC mismatch, the class 1, class 2 mismatches, the B leader peptides, the different and calorie activity models, everything we did, and what stood out was what I showed you.
Sure.
Now, what we did not find beneficial in this particular protocol, see, you are doing in a different protocol, okay? So you are, so whatever the characteristic we say that is beneficial is in context of that protocol.
Absolutely.
So in our protocol, we are finding this. That doesn't mean that in your protocol you will find this beneficial. It's not universal. So what you are saying is that in a classic PTCY haplotransplant in Indian population, a mismatch in KIR 3DL1 ligand is beneficial. So that's excellent. But we did not find that in when we are using T-cell co-stimulation blockade and DLI, where we are possibly engaging a lot more of adaptive NK cells, which work independent of alloreact, NK cell mismatch, NK ligand mismatch. That's another characteristic of ANKs.
Sure. Thank you very much. It was really an excellent session, and all the three speakers did a great job. Thank you, sir.
Thank you, chairpersons, for chairing the session. Thank you, speakers, for the insightful presentation. We are truly grateful for sharing your valuable insights. We are happy to announce that some of the selected abstract presentation will be gifted a free copy of our PGI textbook. Kindly check your eligibility at the registration desk. All the faculty members who have not collected their kits are requested to collect them from the registration desk. There is a parallel session on ALL going on in APC. Those who are interested can attend the session. Moving to our next topic, I would like to invite our chairperson, Dr. Gautam Goyal from Apollo. Due to some unavoidable reasons, Dr. Suvir Singh is not able to attend. I request Dr. Deepesh Lad to chair the CLL session. This session is being sponsored by AstraZeneca.
Session. So, welcome to this CLL update. And our first speaker for the day, for this CLL update is Dr. Rahul Bhargav. And he'll be talking on exploring frontline CLL treatment with BTK inhibitors. Introducing Dr. Bhargav, we don't have his introduction. So he's a prolific hematologist and is there all over the country. He is currently the director of hemat-oncology at Fortis Hospital, Gurgaon. But he's traveling all over India for his outreach initiatives.
Thank you.
Over to you, Dr. Bhargav.
Thank you. Thank you, organizers, and thank you, Pankaj sir, for giving an opportunity to present our thoughts. I hope everybody understands Hindi. I tend to speak more Hindi rather than English. So if everybody is comfortable, then if answer to that is yes, is perfect. Okay, so country में बहुत सारी चीजें बदल गई एंड CLL बड़ा आसान था जब बोलते थे कि इलाज नहीं करना, तो सबसे आसान काम था कि इलाज नहीं करना तो घर भेज देते थे एंड दैट वाज द सिंपलेस्ट थिंग टू हैपन. उसके बाद क्लोरम्ब्यूसिल था और BR था. FCR बहुत सारे लोग ले नहीं पाते थे, BR देते थे एंड लाइफ वाज इजी. 3-4 साल बाद रिलैप्स करता था, क्लोरम्ब्यूसिल खाता था एंड देन ही यूज्ड टू डिसअपियर. ही यूज्ड टू चेंज द हॉस्पिटल एंड प्रोबेबली कम टू PGI चंडीगढ़ फॉर ऑल वी नो, और गो टू एम्स इन सिटिंग इन दिल्ली. So things have remarkably changed and now newer therapies have started coming in and the country itself has changed because उनको लंबा जीने की आदत पड़ गई. So when we got an independence we were dying at 35. आज हम 75-80 तक जिएंगे और CLL डायग्नोस करेंगे. जब 2006 में DM में गए तो लोगों ने कहा CLL इस देश में नहीं होता, तो we also believe that CLL नहीं होता क्योंकि हम उसने जिंदगी जीते नहीं थे. So now we are living longer and there now multiple parameters which has to use. So we are not like the western world where simplest model है कि उसका इंश्योरेंस है या इंश्योरेंस नहीं है. मैक्सिकन है तो वो बाहर चला जाएगा और उसका इंश्योरेंस है तो वो अंदर आ जाएगा. सो हमारे पास सारे वॉक्स ऑफ लाइफ को हमें ट्रीट करना है एंड दैट मेक्स आवर लाइफ मोर डिफिकल्ट. प्रॉबेबली AI वुड हैव हेल्प्ड अस. इंडियन डिपेंडेंट AI और इंडियन डिपेंडेंट चैट GPT वुड हेल्प अस कि उसके पास पैसा है कि नहीं, पहला सवाल ये पूछो. फिर उसके बाद पूछो उसके केयर गिवर्स हैं कि नहीं, उसके पास ओरल गोली खा पाएगा कि नहीं खा पाएगा एंड वी विल ब्रिंग द फंड्स दैट विल डिसाइड कि हमारे को ट्रीटमेंट कैसे करना है. सो यही थॉट्स है जो अगले 13 मिनट में अपने को डिस्कस करना है. वी हैव 2 इंडियाज विद इन इंडिया इटसेल्फ. सो बहुत सिंपल था. FCR, BR, क्लोरम्ब्यूसिल, रिटुक्सिमैब. Chemo-free regimes थी ibrutinib, acalabrutinib, venetoclax, obinutuzumab and various combination. And thanks to Google and thanks to people prolifically spelling out that now there's a chemo-free regime for everything. हमें कीमो-फ्री रेजिम चाहिए, हमारे को कीमो नहीं चाहिए. सो कीमो फ्री रेजिम का मतलब था उसको लाइफ लॉन्ग दवाई खानी पड़ती थी. उसको ये बताना पड़ता था कि कीमो फ्री रेजिम, क्योंकि देश में अभी भी एक डर बना हुआ है कीमो को लेके. कीमो बोलने के साथ ही वो आपसे बाहर भाग जाता है क्योंकि उसको लगता है भी बाल गिर गए. तो हमारे को लगता है कि सारी हेमेटोलॉजिस्ट को सस्टेन कैंपेन रन करना चाहिए कि कीमो इतनी खराब नहीं होती, बिकॉज दैट ऑल्सो अफेक्ट्स योर डिसीजन, वॉट यू डिसीजन विच यू टेक. बिकॉज आप उसको FCR समझाओगे 45 ईयर्स ओल्ड को जो 13 क्यू है और म्यूटेटेड है, तो वो कहेगा नहीं सर मुझे कीमो फ्री रेजिम चाहिए. And that's what the debate continues to go on. So let's look at the data, what happens. Time limited versus time unlimited. मतलब fixed duration combinations आने लग गए. Thanks to myeloma जिन्होंने कहा दिखाया कि पहली बार कि अच्छा मास्टर ट्रायल ने कि आप फिक्स ड्यूरेशन दे सकते हो. और देश में सिर्फ लोगों को इंडेफिनेटिव थेरेपी कोई पसंद नहीं आती. मतलब दे डोंट वांट इंडेफिनेटिव थेरेपी बिकॉज अगर हम किसी भी कंपनी से पूछें कि कितने % कंप्लायंस रेट थी, तो आपको पता चलेगा कि 1 साल में 70% लोग ड्रॉप आउट कर जाते हैं दवाई को, फिर वो छोड़ देते हैं, थोड़े दिन में घूम के आते हैं. अगर ये कोई ट्रायल कर सकता है 1 साल के बाद में क्या रेट होता है तो अपने को और डेटा कंपाइल हो जाता है. पर टाइम लिमिटेड में FCR और BR है, वेन इब्रूटिनिब, वेन ऑब्निटुजिमैब एंड ट्रिपल कॉम्बिनेशंस व्हिच आर कमिंग अप. टाइम अनलिमिटेड में इब्रूटिनिब, एकालाब्रुटिनिब एंड कॉम्बिनेशन विद ऑबिन. सबसे आसान काम पड़ गया क्योंकि बहुत सारे हेमेटोलॉजिस्ट ऑन्कोलॉजिस्ट देश में हो गए, तो सबसे आसान काम है कि ओरल दवाई लिख दो, एकालाब्रुटिनिब या इब्रूटिनिब. इब्रूटिनिब दे दो, इब्रूटिनिब से साइड इफेक्ट तो एकालाब्रुटिनिब दे दो और उसको लाइफ लॉन्ग चलते रहने दो. बट लाइफ लॉन्ग के भी अपनी कॉम्प्लिकेशंस हैं व्हिच वी विल सी डाउन द लाइन. सो कीमोथेरेपी FCR का डेटा बहुत अच्छा था. 10% लोगों में ही ये परफेक्ट सबसेट मिलता था, मतलब ये सबसेट जिसमें यंग पेशेंट हो, विदाउट सिग्निफिकेंट कोमॉर्बिडिटीज हो, और उसका माइंडसेट हो ट्रीटमेंट के लिए, और उसके पास थोड़े बहुत पैसे हो, जो 5 से 6 लाख रुपए में ट्रीटमेंट करवाने के लिए तैयार हो। मतलब फोर्टिस जैसे अस्पताल में भी FCR 5-6 लाख रुपए में हो जाता है, तो PGI में शायद और सस्ते में हो जाता होगा। और डिलीशन 17p और TP53 म्यूटेशन ना हो, क्योंकि अब लैब्स होने लगे। आज से 10 साल पहले शायद बहुत सारे लोग ना TP53 चेक करवाते थे ना फिश करवाते थे। आज एटलीस्ट 90% लोगों को CLL का जो हमारे पास कंसल्ट्स आते हैं उसमें एटलीस्ट फिश टेस्ट और TP53 होता है और IGHV म्यूटेशन और अनम्यूटेटेड स्टेटस होता है, जिससे इजी हो जाता है। सो दीज पेशेंट कुड बी फंक्शनली क्योर्ड ऑफ देयर CLL। सो अगर एक सबसेट है, ऑल टू ऑल माय कोलीग्स एंड माय फ्रेंड्स, इंडिया में हमारे को एक ही यूनिसन में वॉइस में बोलना चाहिए, अगर उसको कोमॉर्बिड कंडीशन नहीं है और 17p नहीं है तो उसको FCR देना चाहिए। कि CLL ट्रायल ने, जर्मन ट्रायल ने दिखाया कि 10 साल के बाद भी कर्व जो था वो फ्लैट था, इट वाज नॉट ड्रॉपिंग डाउन विद द रेस्ट ऑफ द पीपल। सो CLL में FCR क्योर्स दिस सबसेट ऑफ पीपल। बेंडामास्टिन रिटुक्सिमैब के साथ में 33 मंथ्स का PFS था, FCR में 51.9 का था जब रैंडमाइज्ड ट्रायल हुई। पर 3 साल, मतलब 33 मंथ्स का भी मतलब होता है कि 3 साल तक वो बिना थेरेपी के चल सकता है। मतलब 3 साल पे 6 महीने दवाई दी और 3 साल तक वो ठीक रहा और उसके बाद वो रिलैप्स कर गया। इट मींस इट्स आल्सो अ काइंड ऑफ अ डेफिनेटिव थेरेपी। सो some subsets you can still use BR in those patients you don't want to give a prolonged therapy. तो हम prolonged therapy के अगेंस्ट नहीं है, बट prolonged therapy के भी अपने oral chemo free regimes के अपने अपने दुष्प्रभाव है। सो वेरिएबल्स क्या आते हैं? फिट वर्सेस अनफिट, हाई रिस्क वर्सेस नॉन हाई रिस्क, मनी वर्सेस नो मनी, म्यूटेटेड वर्सेस अनम्यूटेटेड। इसमें एक कैवेट में बार बार हर मीटिंग में ये बोलता हूं कि हमारे को कंक्लूसिवली सेंट्रल इंस्टीट्यूट्स को ये प्रूव करना है कि जो जेनरिक मेडिकेशन है दे आर एज गुड एज द वेस्टर्न मेडिसिन। कि जो इब्रूटिनिब जेनरिक है और एकालिब्रूटिनिब जो जेनरिक है उसके रिस्पॉन्स रेट्स उतने ही अच्छे हैं 7 साल प्रोग्रेशन फ्री सर्वाइवल के जितने ओरिजिनल के थे, क्योंकि हम ये प्रिज्यूम करके चल रहे हैं कि हम इनको ये दवाई देंगे और ये प्रोग्रेस नहीं करेंगे। सो हमारे को ये प्रूव करना आवश्यक है। दोज हु कैन अफोर्ड न्यूअर ड्रग्स, इब्रूटिनिब 20,000 रुपए की आती है, एकालिब्रूटिनिब अगेन 20,000 रुपए की आती है, वेनेटोक्लैक्स अभी देश में नहीं मिलती है। अगर 100 मिलीग्राम की टैबलेट हो तो 70,000 की आती है, और अगर 400 मिलीग्राम की टैबलेट हो तो 3 लाख की पर मंथ की कॉस्ट पड़ती है। और ऑप्निटुजिमैब अभी भी 10 से 11 लाख रुपए की पड़ती है, और इसमें स्कीम मिल जाती है तो 10 से 11 लाख में 6 महीने का ट्रीटमेंट हो जाता है। सो BTK इनहिबिटर्स में क्वेश्चन ये था कि अगर मैं BR के बाद इब्रूटिनिब देता हूं तो कोई फर्क पड़ता है क्या? मतलब बहुत सारे आर्ग्यूमेंट्स होते हैं कि सर पहली बार से इब्रूटिनिब स्टार्ट कर दीजिए, तो हमारा आर्ग्यूमेंट होता है कि व्हाई नॉट गिव BR एंड वेट फॉर 3 इयर्स, जब रिलैप्स करेगा तो दे देंगे। तो ये डेटा दिखाता है कि 7 ईयर प्रोग्रेशन फ्री सर्वाइवल वाज स्लाइटली इंफीरियर इन अ रिलैप्स रिफ्रैक्टरी सेटिंग, 55% वर्सेस 84%। पर ये 55% अगर हम सबसेट को डिफाइन करते हैं कि जो 2 और 3 लाइन रिफ्रैक्टरी थे वर्सेस 1 लाइन रिफ्रैक्टरी था, 1 लाइन में फिर भी वो 70% था, पर 2 और 3 लाइन रिफ्रैक्टरी में दैट ड्रॉप डाउन टू 55%। द मोर द नंबर ऑफ थेरेपीज पीपल आर रिफ्रैक्टरी एंड देन यू यूज इब्रूटिनिब, द आउटकम इज लेसर। सो अगर एक थेरेपी के बाद, अगर आप BR के बाद आप सोचते हो कि मैं इसको डेफिनेटिव थेरेपी 3 साल की दूं और उसके बाद इब्रूटिनिब दे दूं, तो वो भी एक गलत स्ट्रैटेजी नहीं होगी, क्योंकि आप फिर भी उसको इब्रूटिनिब या एकालिब्रूटिनिब से सैल्वेज कर सकते हैं। प्रूविंग इब्रूटिनिब वाज सुपीरियर। इब्रूटिनिब ने हर जगह पे क्लोराम्ब्यूसिल के साथ में ये दिखा दिया कि इब्रूटिनिब सुपीरियर है, क्योंकि उसकी आर्म ही बहुत वीक थी। मतलब स्टैंडर्ड ट्रायल जैसे US में होती है जिसमें आर्म बॉडी वीक हो, दूसरे को आप स्ट्रॉन्ग दिखा दो, तो ऐसा हो गई होगा। सो नोटेबली प्रोग्रेशन फ्री सर्वाइवल एट 6.5 years was 61% with ibrutinib monotherapy, and that's why this thing was given. The important thing क्या है, इसमें 6% लोगों को atrial fibrillation रहता है। हिंदुस्तान में इसके रेट शायद 10 से 15% होंगे। हमारे खुद के सेटिंग में जो VPCs आ जाते हैं, सुप्रावेंट्रिकुलर टैकीकार्डिया हो जाते हैं, जिसको हम कहते थे नॉर्मल है, एज होगी, हाइपरटेंशन है, तो ये हम कोमॉर्बिडिटीज के साथ काफी लोग हैं। हमारे पास हाइपरटेंशन, डायबिटीज के वर्ल्ड में सबसे ज्यादा पेशेंट्स हैं। 4% पेशेंट डेवलप्स मेजर हैमरेज। हमारी सेटिंग में 15 पेशेंट्स में मेजर हैमरेज नहीं हुआ, बट 50 मंथ्स के बाद भी, 58 मंथ्स के बाद भी डायरिया, कॉफ, फैटीग एंड मस्कुलोस्केलेटल सिस्टम डज नॉट लीव देम बिहाइंड, वो कंटिन्यूसली चलती रहते हैं। एंड रेट ऑफ हाइपरटेंशन रिमेन कंसिस्टेंट, मतलब हाइपरटेंशन होता है किसी को, उसको 2 या 3 दवाइयां यूज करनी पड़ती हैं। बट क्या इसकी वजह से हम एकालिब्रूटिनिब या इब्रूटिनिब यूज ना करें? द क्वेश्चन इज लेफ्ट टू द ज्यूरी। हमारे को लगता है कि अगर हाइपरटेंशन अनकंट्रोल हो रहा है तो हमको हटाना पड़ता है। तो कुछ लोगों में हमारे को हाइपरटेंशन की वजह से दवाई को कम करना पड़ा या हटाना पड़ा। अलायंस नेटवर्क ने यह दिखाया कि IR ओवर FCR वाज अनम्यूटेटेड IGHV म्यूटेशन में इब्रूटिनिब रिटुक्सिमैब वाज सुपीरियर। बट एक चीज इंपॉर्टेंट थी, म्यूटेटेड IGHV में FCR और IR ऑलमोस्ट सेम थे. सो इसने कंसिस्टेंटली बताता गया कि म्यूटेटेड IGHV म्यूटेशन में, म्यूटेटेड IGHV में आपको FCR स्टिल रिमेन्स द ड्रग ऑफ चॉइस. इल्यूमिनेट ट्रायल ने इब्रूटेनिब प्लस ऑब्निटुजिमैब के लिए कॉम्बिनेशन यूज किया, क्योंकि इब्रूटेनिब से CR नहीं होते थे, स्टेबल डिजीज होती थी. BTK इनहिबिटर्स के साथ में CR नहीं आता था. पेशेंट बोलता था सर मेरा WBC अभी भी बढ़ा हुआ है. उसको 1 साल से 1.5 साल लगता था WBC को नीचे लाने में. सो उन्होंने कहा ऑब्निटुजिमैब के साथ में क्या मैं सर्वाइवल को इंक्रीज कर सकता हूं. PFS was not reached in patient with IO versus 19 months for chlorambucil plus obinutuzumab, and 30 months PFS was 79% for IO. And overall response was also higher for INO plus ibrutinib plus obinutuzumab was 88%, and complete response were also increased by virtue of adding obinutuzumab. Obinutuzumab की total cost 8 से 9 लाख रुपए आती है. फर्स्ट टाइम में आपको चिल्ड्रन रिएक्शंस होते हैं, 2 दिन तक बुखार आता है. 5 पेशेंट हमने लास्ट में मंथ में दिए ऑब्निटुजिमैब में, जिसमें 2 से 3 दिन तक बुखार रहता है. स्टेरॉइड देते हैं तो वो चला जाता है. ट्यूमर लाइसिस को देखना जरूरी होता है. एकालेब्रुटिनिब ने सुपीरियरिटी प्रूव करी अपनी इब्रुटिनिब पे, क्योंकि उसने दिखाया कि साइड इफेक्ट्स कम है. इट वाज ओनली सुपीरियर इन टर्म्स ऑफ इट्स साइड इफेक्ट्स, बट इट वाज ऑलमोस्ट सेम. द रिजल्ट्स वर सेम बिटवीन ऑब्निटुजिमैब एंड ibrutinib and acalabrutinib, but combination obinutuzumab के साथ में was found to be equivalent almost. नेक्स्ट कम आया BCL2 इनहिबिटर्स आया वेनिटोक्लैक्स. वेनिटोक्लैक्स ने ये दिखा दिया कि हमारे पास, और ये सारी दवाइयां जो थी अभी तक ये सारी टाइम लिमिटेड थी, मतलब ये अनलिमिटेड इंडेफिनिटली देना. BTK इनहिबिटर्स के साथ में हम ऑब्निटुजिमैब यूज करें पर वो अनलिमिटेड देना है. वेनिटोक्लैक्स है, वेनिटोक्लैक्स ने ऑब्निटुजिमैब के साथ 6 मंथ्स और 6 मंथ्स ऑफ क्लोरम्ब्यूसिल दिया. 24 months of PFS was 88.2% in Ven O group versus 64.1 in chlorambrucil obinutuzumab, and 6 months पे recently updated demonstrated PFS benefit for Ven O. पर वेनिटोक्लैक्स ऑब्निटुजिमैब के साथ एक ही प्रॉब्लम थी, जब हाई WBC काउंट हो तो पहले मंथ से नहीं देना, क्योंकि उसके साथ ट्यूमर लाइसिस होता था. बट पेशेंट हैज टू बी मॉनिटर्ड फॉर ट्यूमर लाइसिस सिंड्रोम. सो दिस ड्रग हैज टू बी प्रूवन सुपीरियर. अब क्वेश्चन आएगा FCR चलो कुछ 10% सबसेट में हो गई, अब डिबेट है कौन सी दवाई सुपीरियर है. BTK इनहिबिटर सुपीरियर है या BCL2 इनहिबिटर सुपीरियर है. कौन सी दवाई सुपीरियर है अपफ्रंट सेटिंग में, प्रोवाइडेड वेनिटोक्लैक्स इंडिया में लॉन्च कर दे एबी. सो अभी ने अभी तक लॉन्च नहीं करी. वेनिटोक्लैक्स इब्रुटिनिब दूसरा कॉम्बिनेशन आया जिसने अगेन ये दिखाया कि टाइम फिक्स ड्यूरेशन कॉम्बिनेशन दे सकते हैं. फर्स्ट कॉम्बिनेशन वेनिटोक्लैक्स प्लस ऑब्निटुजिमैब का था. सेकंड कॉम्बिनेशन वेनिटोक्लैक्स प्लस इब्रुटिनिब का था, जिसने ये दिखाया कि कंप्लीट रिस्पॉन्स रेट्स बढ़ जाते हैं एंड MRD नेगेटिविटी भी बढ़ जाती है. सो MRD नेगेटिविटी बिकम द सरोगेट पॉइंट, क्योंकि OS में डिबेट में OS हम 7-8 साल को वेट करना पड़ेगा. नई ड्रग्स के लिए MRD नेगेटिव वर्सेस PFS दोनों को यूज करते हुए एज अ सरोगेट मार्कर यू कैन गेट एन अप्रूवल फॉर अ न्यूअर ड्रग. सो हमारे को इस दवाई पे इब्रुटिनिब प्लस वेनिटोक्लैक्स NEJM में आर्टिकल पब्लिश हुआ, जिसने का फिक्स ड्यूरेशन कॉम्बिनेशन अच्छा है. फिर ट्रिपलेट कॉम्बिनेशन आ गए, क्योंकि दो से अच्छा मिलने लगा तो ट्रिपलेट कॉम्बिनेशन आ गए कि फिक्स ड्यूरेशन दे सकते हैं कि नहीं दे सकते. ये फिक्स ड्यूरेशन की कॉम्बिनेशन की वेरियस ट्रायल्स चल रही है, क्योंकि हमें लगता है कि 12 महीने पे CLL में हम TFR की बात करने लगे. जैसे CML में डॉक्टर पंकज बहुत चैंपियन थे TFR के, अब हम CLL में TFR के चैंपियंस बनने वाले कि हम ट्रीटमेंट फ्री रिमिशन देते हैं उसको. फ्रंटलाइन थेरेपी ये इंपॉर्टेंट ट्रायल है. फर्स्ट लाइन वेनिटोक्लैक्स कॉम्बिनेशन इन CLL अभी NEJM में पब्लिश हुई है, जिसने बहुत ही सिंपल ट्रायल है. 12 साइकिल्स ऑफ वेनिटोक्लैक्स रिटुक्सिमैब, वेनिटोक्लैक्स ऑब्निटुजिमैब, वेनिटोक्लैक्स ऑब्निटुजिमैब एंड इब्रुटिनिब. ये और FCR के साथ में रैंडमाइज्ड ट्रायल से 1000 पेशेंट की ट्रायल थी. 1:1:1 के, मतलब 200 पेशेंट सब में थे. तो नट शेल में वेनिटोक्लैक्स इब्रुटिनिब इंफीरियर दवाई है, वेनिटोक्लैक्स ऑब्निटुजिमैब सुपीरियर दवाई है, वेनिटोक्लैक्स ऑब्निटुजिमैब इब्रुटिनिब और भी सुपीरियर है, बट स्टैटिस्टिकली डिफरेंट नहीं है बिटवीन वेनिटोक्लैक्स एंड ऑब्निटुजिमैब. सो थर्ड ड्रग वेनिटोक्लैक्स और ऑब्निटुजिमैब के साथ ऐड करने का बहुत ज्यादा फायदा नहीं होता. हमने क्या प्रूव कर दिया कि रिटुक्सिमैब से सुपीरियर ड्रग ऑब्निटुजिमैब है और एकालेब्रुटिनिब से सुपीरियर ड्रग वेनिटोक्लैक्स है, अगर वेनिटोक्लैक्स आपके पास है, क्योंकि वो फिक्स ड्यूरेशन है और MRD नेगेटिव है. अब हमारे को CLL के MRD नेगेटिव, हमारे को CLL की MRD को और सुदृढ़ करना पड़ेगा, मजबूत करना पड़ेगा, सो दैट हम ये फिक्स ड्यूरेशन कॉम्बिनेशन की तरफ जा पाए. सो ये इंपॉर्टेंट चीज थी. फ्रंटलाइन थेरेपी हैज मूव्ड लेस देन 65 ईयर्स IGHV म्यूटेटेड, नो डिलीशन 13, और 17P और TP53 में कोई फिक्स ड्यूरेशन नहीं है, आपको कंटिन्यूसली देते रहना है, क्योंकि अभी भी हम उसको डिफाइन करने की कोशिश कर रहे हैं. सो क्लिनिकल ट्रायल में FCR और BR और वेनिटोक्लैक्स और ऑब्निटुजिमैब इजीली टॉलरेबल है. अगर ऑब्निटुजिमैब से नीचे आ जाता है आफ्टर फर्स्ट साइकिल, यू डोंट हैव एनी कॉम्प्लिकेशन विद ऑब्निटुजिमैब. हाँ, वेनिटोक्लैक्स के साथ भी लोग 5-5 साल हमारे खा रहे हैं जिसमें कोई परेशानी नहीं हुई. ऑब्निटुजिमैब के साथ में और इजियर हो जाता है. बट एकालेब्रुटिनिब, इब्रुटिनिब के साथ हाइपरटेंशन, डायरिया कंटिन्यूज टू रिमेन अ प्रॉब्लम फॉर नेक्स्ट 5 years. वो रुकते नहीं है, वो हर बार होते ही रहते हैं. दे कीप ऑन कॉलिंग यू कि सर डायरिया हो गया, ब्लड प्रेशर बढ़ गया. सो प्लीज फैक्टर इन दैट व्हेन यू आर यूजिंग अ इंडेफिनिटिव थेरेपी लाइक एन ओरल ड्रग. सो ये फिट अनफिट, गो एंड नो गो, इसमें इंपॉर्टेंट चीज एक ही है कि कॉम्बिनेशन फिक्स ड्रग थेरेपी से हम इन्फेक्शन रेट्स और हेल्थ केयर इकोनॉमिक्स में पैसा लोगों का बचा पाएंगे. सो ये अगेन है. और नीचे रैंडमाइज ट्रायल बहुत सारी चल रही है जिसमें 2 ड्रग वर्सेस 3 ड्रग की कॉम्बिनेशन है और उसको बेनिफिट देखना भी जरूरी है. बट इस लास्ट ट्रायल में 3 ड्रग का कॉम्बिनेशन बहुत सुपीरियर नहीं पाया गया ऑब्निटुजिमैब प्लस वेनिटोक्लैक्स के मुकाबले में. सो सुपीरियरिटी ऑफ द ड्रग इज वेनिटोक्लैक्स, ऑब्निटुजिमैब होल्ड्स द फर्स्ट नंबर पोजीशन. सो टॉक्सिसिटीज रिमेन्स स्टिल अ प्रॉब्लम. आर्थेल्जिया, एट्रियल फिब्रिलेशन, लार्जर यूसेज इन द कंट्री हैज टू बी डिफाइंड ऑन अ जेनरिक मेडिकेशन. व्हाट आर द साइड इफेक्ट्स, बिकॉज दैट कैन नॉट बी टेकन ऑन अ फेस वैल्यू. प्लीज मेरा रिक्वेस्ट है कि आप सब जो डेटा पब्लिश करते हैं, हम डेटा बहुत ज्यादा पब्लिश नहीं करते, जो लोग डेटा पब्लिश करते हैं वो उस बात को जरूर हाईलाइट करें कि जेनरिक मेडिकेशन से हमारे कितने साइड इफेक्ट्स हैं और कितने डिसकंटिन्यूएशन है बिकॉज ऑफ द साइड इफेक्ट्स. सो क्वेश्चन रिमेन्स, इज ट्रीटमेंट विद BTK और BCL2 inhibitors better in the frontline setting? Answer to that is probably multiple trials will prove thus which are superior drugs. Right now it is going towards or trending towards use of venetoclax, obinutuzumab as the standard of care for a fixed duration. Is the addition of anti-CD20 necessary? Probably answer to that is again necessary, because obinutuzumab beautifully brings down the count so that the tumor lysis syndrome is not there. So with this we come to an end. The idea is that in a time limited space we are moving towards time limited space. Second thing which I asked on Twitter to the people in CLL space, that is there an end of single agent the BTK inhibitors, and the answer to that is the world is moving towards a combination therapy of BTK inhibitors plus the obinutuzumab for a better control and CRs and MRD negativity, but still not to a stage where they can discontinue the treatment. So now the debate should be how to use, what to use. If the patient do not have the money, acalabrutinib still remain, or ibrutinib generic remains the standard of choice. TP53, there is no doubt, both BTK inhibitors or obinutuzumab and venetoclax plus obinutuzumab remains the drug of choice. In those 10% people, FCR still remains the choice, and still patient does not have the money to buy and control acalabrutinib. BR still remains the drug of choice for those people where we can give at least 33 to 36 months of progression-free survival to that. With this, I come to an end, and thanks to my team, entire team, because of which we do number of transplants, 250, 300 transplants every year, who allows me to roam around across the country to specifically spread the message of hematology and promote hematology to the knock-in corners of the country. So to the remotest side where we do not have the access, the answer and the simple motto is they can't come to us, we will go to them and treat their hematological problems. Thank you, everybody.
धन्यवाद डॉक्टर राहुल. आपकी हिंदी में बातचीत सुन के बड़ी खुशी हुई. आई थिंक भार्गव ऑडिटोरियम को भी खुशी हुई होगी कि हिंदी में आज एकेडमिक मीटिंग में हिंदी में बातचीत करी गई. सो ओपन टू क्वेश्चंस. डॉक्टर पंकज प्लीज.
So Rahul, as always, you are still the same, and keep it up, keep like this only. That's very good. So 2 or 3 things you mentioned कि बाहर के trials को देख के हम and then we quote those PFS and OS and other things. जो एक और प्रॉब्लम इंडिया में हुई है कि अगर इंडिया में डाटा है भी है तो भी तो हम दिखाते नहीं है ना. मतलब अब हम क्या कहते हैं कि अच्छा इंडिया में डाटा प्रोड्यूस किया, ये तो यूएस जैसा होना चाहिए स्टैंडर्ड, ओनली देन वी विल कोट. नाउ यू डोंट हैव ऑल दोज काइंड ऑफ सिचुएशंस, एनवायरनमेंट to conduct those kind of a clinical trial. So obviously what we have is हमें उसी को ही कोट करना है. For example, CLL के लिए I think Dr. Dipesh has published maximum from this country. CLL का overall outcome क्या है, क्लोरम्ब्यूसिल प्रेडनिसोलोन से outcome क्या है, इब्रूटिनिब से क्या है, तुमने बोला जेनरिक इब्रूटिनिब से क्या है, लोअर डोज इब्रूटिनिब से क्या है, कॉस्ट इफेक्टिवनेस इब्रूटिनिब का क्या है. All these have been published from PGI. But you know, I'm sorry to say कि तुम्हारी किसी भी स्लाइड में कहीं पे भी कोई इंडिया स्पेसिफिक CLL का कोई भी पेपर तुमने नहीं दिखाया. So it's not you, you know, मैं तुम्हें कोई स्पेसिफिकली, you know, I'm not pointing towards you. What I want to say is कि जब हमारे पास इंडियन डेटा है भी है, तो भी ना हम उसको ये कहते हैं कि नहीं ये तो अमेरिका जैसा नहीं है, इसमें तो बड़ी फैलेसीज हैं, इसमें बड़ी सारी प्रॉब्लम्स हैं, ये तो ठीक नहीं किया है, डाटा ठीक तरह से कलेक्ट नहीं किया है, उसका पूरा आउटकम नहीं दिखाया है, एंड इसलिए हम यहाँ वाला कोट नहीं करेंगे, हम तो बाहर वाला ही जो है ना वो करेंगे. सो दैट इज़ वन कमेंट. द सेकेंड इज़ कि इंडिया इज़ यू नो वेरी हिटोजेनस कंट्री, यू नो, एंड यू हैव बीन गोइंग टू डिफरेंट प्लेसेस इंक्लूडिंग रूरल एरियाज. एंड इन PGI वी गेट ऑल टाइप ऑफ पेशेंट्स. हमारे पास वो पेशेंट्स भी जो कि हमारे पास बिल्कुल पैसा नहीं है. सो क्लोरेमब्यूसिल प्रेडनिसोलोन इज नॉट अ बैड ऑप्शन इन दोज पेशेंट्स. एटलीस्ट इट गिव्स अ PFS ऑफ 3.5 years. सो जिसके पास बिल्कुल भी पैसा नहीं है, सो आई थिंक इट इज़ नॉट बैड टू गिव दैट. एंड पेशेंट्स हु कैन अफोर्ड, व्हेन वी से कि अनलिमिटेड ड्यूरेशन के लिए, अब डायबिटीज़ के लिए अनलिमिटेड ड्यूरेशन के लिए नहीं लेते. डायबिटीज़ में पूरी उम्र खाते हैं ना, हाइपरटेंशन भी पूरी उम्र खाते हैं, हार्ट डिजीज इतनी उसमें भी पूरी उम्र खाते हैं. बट व्हेन वी टॉक अबाउट दिस कि ये पूरी उम्र खानी पड़ेगी, तो समहाउ बोथ फ्रॉम द पेशेंट साइड एज वेल एज समटाइम्स फ्रॉम द डॉक्टर साइड हो जाता है नहीं नहीं नहीं, टाइम लिमिटेड लो, टाइम लिमिटेड लो. So all these are questions. I'm not sure whether there are clear answers to all these questions, but yes, these are the points for discussion among the hematologists.
सर, आई थिंक आपने बहुत ही अच्छा पॉइंट रेज किया सर. अगर आज की तारीख में लोग गूगल पढ़ते हैं और अगर हमारे पास आज की तारीख में देश सेंट्रिक स्पेसिफिक गाइडलाइंस होती हैं, आई लॉट दीपेश फॉर ब्रिंगिंग आउट दोज थिंग्स. मेरे को लगता है कि एक डॉक्यूमेंट होना बहुत ज़रूरी है. अगर हम NCCN में गाइडलाइंस में पढ़ें तो आज भी वहाँ पे क्लोरम्ब्यूसिल कहीं ना कहीं लिखा होगा, उन्होंने हटा नहीं दिया होगा सर. जो 1980 की भी डेथ थेरेपी थी तब भी वो इंटरफेरॉन कहीं ना कहीं लिखा होगा. उसने लिखा गया था कि अगर लास्ट माइल का पेशेंट जिसके पास इंश्योरेंस है और वो कुछ नहीं अफोर्ड कर सकता, इंश्योरेंस वही देगा जो NCCN में देगा. तो मुझे लगता है कि सेंट्रल इंस्टीट्यूट का एक बहुत बड़ी भागीदारी है जहाँ पे वो देश स्पेसिफिक गाइडलाइंस बना पाएं, जहाँ पे उनको दिखा पाएं कि हाँ यार ये डेटा देखो ये है. क्योंकि मिसट्रस्ट हेल्थ केयर सेक्टर पे इतना है और अपन इस पर कितना भी डिस्कशन कर सकते हैं सर घंटों तक, क्योंकि हमारे पास राइट गाइडलाइंस नहीं है. एक डॉक्टर कुछ पढ़ रहा है, वही किताब जो आपने पढ़ी है और जो किताब मैंने पढ़ी है, बिकॉज ऑफ मल्टीपल रीजंस, आपकी विचारधारा और मेरी विचारधारा के अनुसार हम उस पर डिसीजन लेते हैं, और वो डिसीजन हो सकता है पेशेंट के हित में हो या नहीं हित में हो. उसके लिए क्या जरूरी है? आज से 60 साल पहले अमेरिकन ने एक ही काम किया कि उन्होंने NCCN गाइडलाइन बना दी. उन्होंने कहा ये सारी चीजें गाइडलाइंस में हैं. हमारे पास अगर एक गाइडलाइंस, मैं आपको आज भी प्रेरित करूंगा और आपसे निवेदन करूंगा कि सर आप इतना अच्छा काम करते हैं, सेंट्रल इंस्टीट्यूट्स जिसके पास फंडिंग है उनको ये गाइडलाइंस छाप देनी चाहिए, सो दैट गूगल पे आप बोल सकते हो कि हाँ ये गाइडलाइन है, सो दैट वो किसी और के पास जाए तो कंफ्यूज ना हो. एक सिंपल से एग्जांपल दूंगा सर, ज्यादा टाइम नहीं लूंगा. मेरी मदर को कुत्ते ने काट लिया, मैं मैक्स में घुसा, उसने कुछ कहा, फोर्टिस में घुसा कुछ कहा, मैंने कहा RTPS में मैं डॉक्टर हूं, तो उसने कहा सब चीजें लगवा लो. इतनी हेट्रोजेनिसिटी है एक डॉग बाइट पे कि हम क्या करें, इम्यूनोग्लोबुलिन दें या सिर्फ रेबीज का इंजेक्शन दें. और आप बता दो कि डॉक्टर तो कहते सब जिन दुनिया में चीजें सब दे दो. So I think the country has to move on the uniformity and glorify our own data telling that these things are good. Out of this generic we have found that this is good, so that the whole country can get benefited out of it and the trust बढ़ पाए. नहीं सर, सब फॉलो आज की तारीख में लोग गूगल पढ़ते हैं. अगर आप ICMR की गाइडलाइन पे बोलते हो कि ये है तो लोग उसको फॉलो करते हैं कि प्लीज कम से कम. हाँ नहीं सर, तो उसको काफी लोग फॉलो करते हैं सर. अगर मैं
स्टेम सेल में गाइडलाइंस है, मैं लिखा हूँ, हम लोग लिखा हूँ
सर, अपन इस पे डिबेट कर सकते हैं, बट मेरा निवेदन यही रहेगा कि अभी भी गाइडलाइंस एक यूनिफॉर्मिटी.
डू यू आस्क व्हाट इज द गाइडलाइन इन मायोकार्डियल इंफार्क्शन और इस्केमिक हार्ट डिजीज? यू डोंट आस्क. Various people are using various kinds of things.
सर मैं इसमें एक ही चीज कहूंगा सर, आगे चल के 5 साल बाद ये हमारी नेसेसिटी बन जाएगी, क्योंकि देश
होना जरूरी है, गाइडलाइन
इंश्योरेंस ड्रिवन होगा सर. वी आर मूविंग टुवर्ड्स एन अमेरिकन मॉडल, जहां पे आप अपनी विंस एंड फैंसीज पे अस्पताल नहीं कर पाएंगे. दे ऑल बी ड्रिवन बाय द गाइडलाइंस, बिकॉज दोज हैज टू बी शोन सो दैट द इंश्योरेंस हैज टू पे यू लेस. सो ये फ्यूचर के लिए हमें फ्यूचर रेडी होना जरूरी है. बट आई एम सॉरी इफ आई मिस्ड ऑन टू डिबेट दिस thing from Indian setting on CLL. The idea is simple as that, how we use it, and if you have presented
No,
so
as
many
Dr.
things.
Malhotra
good.
has said, in CLL, chlorambucil is not a bad drug. It is really a good drug. And many patients I have treated on CLL live 15, 16, 20 years on CLL, on prednisolone chlorambucil. But that is not the end of all. You have better medicine. The better medicines which you have put in, they have much better side effects also. Extremely better side effects are there.
सर हमारा सिंपल सा निवेदन ये है कि सर अमेरिकन्स में एक तरीका दिखाया साइंस को प्रैक्टिस करने का, हमारी problems is converted into opportunities to add to the science and a new dimension to the science. It is as simple as that.
See, nature.
साइंस को देखने के बहुत सारे नजरिए हो सकते हैं, अभी तक हमको सिर्फ एक ही दिखाया गया.
You are right.
हमारे फिजिशियंस को एक नया तरीका दिखा के वर्ल्ड को ऐड करना है.
No, but what he said is right. Our physicians should also not be drowned by the medicines, and knowing that in those cases, as you said, that all in our old guidelines somewhere in United States also chlorambucil must be there, but a doctor will be using chlorambucil in his own peril in United States. He does not know. One of my friend doctor is in jail now in United States.
Sir, अपना बहुत सारी पे discussion करते हैं. Let's end to that.
Thank you.
But the idea was that PGI is doing a great job. Central institutes are doing a great job.
It is a good idea to have guidelines.
I think we
have guidelines.
I as a person look always towards central institutes to get guided on an Indian setting rather than on the world stage. So I am grateful to Dr. Tulika and Pankaj and the guys who are doing a great job. Prashant is sitting here. We always call them and ask what is to be done in an Indian setting. So because those centers are trained to do research and formulate the guidelines for the country, they have got a huge load on their shoulders. I applaud them and laud them for all what they are doing. And
Right,
so I think it's important.
आप एक simple term बोला about dog bite. Dog bite do have guidelines, how severe is the bite, where is the bite, and depending on that, whether you have to give local immunoglobulin or you have to wash. There are 3-4 types of vaccine. They have different kinds of ways of giving them. So there are the guidelines on that. But it is difficult for the doctors to remember all of them. That is true.
धन्यवाद डॉक्टर राहुल. हम सब शायद एक ही चीज़ कहना चाह रहे हैं, but वो सारी सेम चीज़ें हैं. So next is a panel discussion, and it will be
that is true.
moderated by Dr. Parathan Karunakaran. He is an alumnus of PGI, and he is an associate professor at the Department of Medical Oncology, Adyar Cancer Institute, Chennai. And over to you, Dr. Parathan.
We'll call the panelists on stage.
Do you have it? I think, Parathan, you might have the
Dr.
next slide.
Nishant and Dr. Sachin. Okay, so okay, second. So I'll be talking about sequencing therapies in relapsed CLL after the previous talk on frontline CLL. I'll just skip this slide. So similar to what Dr. Rahul Bhargava told, we have two Indias, the old approach of first-line chemo, second-line chemo, and third-line chemo versus the Naya Bharat approach of BTK versus BCL2 inhibitor, first-line, second-line, and also third-line. So I'll just concentrate on the relapsed CLL part. So this is the NCCN present guidelines for relapsed CLL in a non-high risk setting. You don't have deletion 17p or TP53 mutation. So if you look in this list, we have only 2 chemo agents mentioned here. There's no chlorambucil, just BCR and FCR. These are 2 agents mentioned here. The setting is slightly different. But just to give you an idea, this was what was there in 2016 for a similar high-risk, non-high-risk group, where you have like at least 6 chemo regimens mentioned, which you can use in your relapse setting. So that's how the West is kind of progressing. So I'll just, in my panel discussion, I'll just discuss about some few practical aspects, so I'll use a case to do that. So we have a 54-year gentleman who came with some non-specific history of fever. He is a diabetic but is well controlled. He had some lymph nodes, not very big, and a small spleen as well. His hemogram showed anemia 9.4 and a platelet of 90,000 with a lymphocytosis, and a smear was showing your classical smudge cells with lymphocytosis. Coombs was negative. He was seen by a GP. The GP Sida made a diagnosis of CLL, and he also did the FISH panel by himself, which came as negative for deletion 17p. Finally, the patient has come to you for further treatment. Now, first question is to Dr. Charanpreet. So you have a low count CLL, just 50,000. Would you prefer to do a bone marrow here or just a peripheral blood flow?
So normally, if I am diagnosing a patient who I don't intend to treat immediately, I would not do a bone marrow at the outset. However, if I feel that the patient actually is going to need therapy, especially if they have cytopenias, I would want to get a bone marrow to establish exactly what the cause of the cytopenias is, whether it's an immune etiology. Obviously, the DCT is negative, but we know that patients may have like an immune PRCA as well in patients with CLL. So because this patient has some B symptoms and some cytopenias, I would probably get a bone marrow in this patient.
Okay. I mean, I would say a lot of people would like to not do a bone marrow for CLL, but you have spoken like a true Pgi-ite. Okay, so the next question is Dr. Sachin. So the standard donor model has this 4 markers, 3 deletions and a 1 trisomy 12. This is what all our standard pathology FISH report has. But in the current context, do you think the other markers other than 17p have any relevance or not? As in, is there any utility in knowing whether the patient has a deletion 11q or trisomy 12 or deletion 13q? Will that help you in your management in any sense?
So from treatment point of view, they may not be very helpful, but it's good for prognostication. Deletion 13q is a better prognosis, so we can, at least discuss with the patient that what kind of behavior your disease is going to have. But the season pointing would be with the deletion 17 mainly. And additionally, we can have IgVH for guiding the treatment. But for practical purposes, deletion 17p is what we require.
So in a cost constraint setting, would you just say just do the deletion 17p, I don't want the rest?
But these tests are done as a package, we are not ordering a single test.
We have to change the package, right? Fine. So I'll just summarize my case. So we have a 54-year-old gentleman who's fit and has a negative for deletion 17p with a IWCLL 2018 indication being anemia and thrombocytopenia. Now, similar to Dr. Rahul Bhargava's 2 Indias, we have 2 groups of physicians here. Dr. Charanpreet and Dr. Sachin would like to go for on the chemo-free path, whereas Dr. Nishant says that I'll stick to the old dinosaur way of just giving chemo. So I'll take the case in the same patient will be receiving 2 different types of treatment, and we'll see how it goes. So we'll start with the chemo-free group. So we're starting a BTK inhibitor. So the first question to Dr. Charanpreet, Dr. Rahul Bhargava also was suggesting about giving obinutuzumab to bring down the TLS. Would you consider adding monoclonal antibody CD20 to your BTK inhibitor?
So as far as the frontline data for CLL is, it shows relatively clearly that addition of rituximab to upfront ibrutinib does not really add too much in terms of a PFS or even an OS benefit. Obinutuzumab, I'm not too sure about what the data is, but at least with rituximab, maybe if we extend that, I would not be adding rituximab to upfront BTK inhibitor in this patient now.
Okay. In the private practice, a lot of people prefer to add because it brings on the patient's anxiety. You won't have lymphocytosis. So the question for Dr. Nishant, suppose this patient was IgVH mutated, would you consider FCR or BR?
Just a few things. So this patient, I think it's also important to rule out deficiencies. I mean, the platelet is borderline 90,000, but that doesn't mean you treat. We've not done a marrow, but at least an iron profile is something that you can look at. If the patient does need...
RBC was normocytic, normochromic.
So yes.
I didn't show the marrow, but let's assume that it was
anemia. So if we have to treat, we obviously should look at IGHV, and I think the other FISH panel, like you said, even trisomy and those do help with the prognosis, so even if it doesn't change with the treatment. If we have to start chemotherapy, like Dr. Bhargav mentioned in his talk, if you have a patient who is IGHV mutated, young, fit, there's a good chance that a proportion of them can have long-term disease control. So in those patients, FCR, in this patient's nothing beyond BR. That patient beyond 40, I think FCR would be a little difficult.
Okay. No, but I'll just add a point here. The other components of fish may not be important for Sachin because he belongs to chemo-free group, but you are the chemo group, and if you look at the older data, they say 11q is set separately because they say 11q you cannot get away with just FR regimen or monoclonal antibody. You would definitely need alkylating agent if you have 11q positive.
Right.
So the last question here to Dr. Sachin. So would your IGVH mutation status make you prefer one of, like suppose let's say the CLL is IGVH mutated, would you prefer chemo over a BTK inhibitor or the other way around if it's unmutated?
Yeah, so if I have a fit patient with IGVH mutation, so FCR would definitely be a regimen to go, and I assume patient is going to tolerate this, so that has an edge over other regimens. So here, this is actually a subset where FCR we should definitely prefer.
Okay. So we had conducted a survey among Indian physicians who treat CLL, and we put the same question up to them. So you have frontline setting, a young fit CLL, 17p negative with IGVH mutated. A lot of people agreed with Dr. Sachin that they will give FCR, and some said they will give BR, and a small proportion still said they would still give a BTK inhibitor. Now, when we put the same question slightly different, we said that suppose the IGVH is unmutated, most actually said that, yeah, we would prefer to give a BTK inhibitor, but still some small subset was still, like Nishant saying that, no, I would still go with a BR. So back to our case. So the patient, the chemo-free patient was started on ibrutinib 420 milligram. He had some intolerance in the form of diarrhea, so the dose was reduced to 2 tablets, and patient achieved a good response. So question to Dr. Sachin. So in such a patient where there's some intolerance, would you consider changing to alternate BTK inhibitor, or would you like to continue the same?
So very few patients would be tolerating 420. In our practice, we are seeing that the tolerance of our patient is not that great, and there's a lot of dropout. Acalabrutinib has definitely better toxicity profile. So these patients can be switched to acalabrutinib for better tolerance at least. If we have decided that this patient is going to get this oral therapy only, then that is a choice. But the tolerance does improve with lower doses, so there is sufficient data, a lot of trials and real world data is there that at lower dose similar efficacies have been maintained with so if this patient even continues on 280 and is doing fine, I'll be pretty happy with that also.
Okay, you answered both ways. So as a chemo group, the same patient received BR 6 cycles. He had some mild cutaneous toxicity which was managed with steroids and antihistaminics and was well controlled, and patient achieved CR. So question for Dr. Nishant, how often would you consider doing a bone marrow for MRD?
So in clinical practice, I would not. I mean, because, we're not planning any maintenance therapy.
You are working in a research center.
Yes. So even in a research center for outside of a trial, if there's a trial going on, I don't think bone marrow MRD in a patient who achieves a remission with CLL would really make a difference to the treatment. So not for a regular treatment.
Okay. So the MRD negative data for BR is in single digits, and it is a similar status for BTK inhibitors. So unless you're considering an FCR or a Ven-based regimen, there's not much utility in looking for it either. So the same patient, 4 years down the line, we had a second Pgi-Hem-Onc Fest at 2027. When the patient comes back to you, the patient did not go to another hospital like Rahul suggested, he came back to you. So has rising counts and some new onset lymph nodes. Your evaluation here suggests that it's a disease relapse. So you have a time to next treatment of 4 years. You do a repeat FISH, which is again negative for deletion 17p. So it's the same question to both groups. So first I'll start with Dr. Sachin. So we had a patient was on lower dose of ibrutinib, was doing well for 4 years now. Now, would you consider chemo in this patient, a BR chemotherapy?
So this patient was continuously on ibrutinib. Patient had not dropped out, and
yes.
So maybe we have a look at the whole clinical profile. Was there any transformation happening in this patient? Lymphadenopathy, some...
Okay, you want to do a PET for Richter's transformation.
If, clinically if indicated.
Let's assume for the argument's sake that there is nothing like that, yeah.
Okay. So look, so now this patient is on BTK inhibitors. So we have choices of going to this chemoimmunotherapy versus going to venetoclax plus minus obinutuzumab here. And so I'll be, happy with considering BR in this situation. One thing is time limited. Secondly, the availability and cost of venetoclax and obinutuzumab would be, way too high.
We are hoping that in 2027 the situation will be slightly different. Yeah, we are going into the future now. Sir? Sure, sir. So the same question to Dr. Nishant. So the patient is already doing well on BR and he's been disease-free for 4 years. And now do you want to re-challenge with the same drug or do you want to try something else?
So if he's relapsed after 4 years, the outcome with a second cycle of BR or probably another chemoimmunotherapy is not going to be 2 years, more than 2 years is what I would expect. So if the patient does not have any contraindications to give a chemo-free therapy, then I have to stick to chemo.
See, you have to act your role, okay? You are in the chemo group. You cannot talk about chemo-free here.
So I have to stick to chemotherapy groups. So if someone has had a good response for 4 years, I think we can re-challenge with BR. Because obviously you cannot give FCR. Our CVP is something that we use, but I don't think if that would be the right option.
Okay.
You can still give BR.
Sounds fair. So I'll call first Dr. Charanpreet. So okay, I think Dr. Sachin has kind of already covered your question. So we'll go to, as in both of you have covered your questions. Fine. I'll move on. So this is you open any guidelines, this is what it says. So you have a relapsed patient, depends on what's your front line. So if your previous drug was a chemoimmunotherapy, you have only 2 options, a VEN or a BTK inhibitor. If your previous drug was a covalent BTK like ibrutinib, if it was due to intolerance, you would switch to an alternate BTK. If it was due to progression, you have to go to VEN. If your first line was VEN, then the remission state duration decides your next treatment. If it was less to 2 to 3 years, then you have to go for BTK. Whereas it was more to 2 to 3 years, besides the BTK, you also have an option of re-challenging with VEN. This is your standard guidelines which you see in all your current publications. Now, the same question we put up to Indian physicians. Patient has received BR or FCR and had a treatment, time to next treatment of 3 years. What would you do? Most people agreed with the consensus of the panelists as well that they would go for BTK inhibitors. But surprisingly, quite a few said that they would actually want to re-challenge BR as well. Now, I'll just present some Western data of the same thing as well. This is from the United States. So the one above is about first line you use BTK, what would you be a second line? Most actually wanted to give a venetoclax-based regimen, but about 15% still said that post ibrutinib they were still giving a chemo-based regimen. For the venetoclax, it is skewed more in favor of the chemo-free group only. If you fail venetoclax, most of them prefer to use a BTK inhibitor over a chemotherapy regimen. And kind of highlighting what's happening here. So, I'm sorry. Yeah. So if you use chemo first, your second line was BTK, a kinase inhibitor in 54% of the cases. Total chemo-free was followed by 25% of the cases. And even in the West, about 25% were ready to use a chemo regimen as the second line after their either kinase inhibitor or chemotherapy. This is slightly older data in 2019. Maybe it is changing as we speak. So we'll come back to our case. So the chemo-free group, the patient had already progressed on ibrutinib after 4 years. So as Dr. Sachin suggested, we gave the VEN plus rituximab, the Murano regimen was tried. Patient had some cytopenias, but overall tolerance was fair. Question to Dr. Sachin again. So would you prefer, which monoclonal antibody would you prefer to use here, obinutuzumab or rituximab? Cost-benefit analysis here.
So the responses and data is more robust with venetoclax with obinutuzumab. That is giving better responses, better MRD, better PFS. But again, your question has the answer. The cost benefit, of course, we don't stand anywhere using obinutuzumab. It would be way too difficult for anybody to handle it.
True. So, but if you go by the studies, the standard study is upfront is Ven-G, whereas in relapse, the Murana is still considered the standard where it is Ven plus rituximab. But obviously the data is rapidly evolving. Coming to Dr. Nishant's side, the same patient received RCOP treatment. I agree that most people not even think that RCOP is still considered a regimen, but it is there in the 2016 guidelines at least. So patient had some steroid-induced hyperglycemia, which was managed well, otherwise no tolerance issues. And the patient, we move on to 3 years later. The next Pgi-Hem-Onc Fest has come in 2030 now. We have like 7 years down the line. So patient is 60 years old now. He's had a coronary artery disease and had a stent placed, and he's also on dual antiplatelet therapy. He has now come to you with a second relapse, a time to next treatment of 3 years, and you do a repeat CL fish panel. Somehow surprisingly, it's still negative for 17p deletion. So we'll come back to the two groups again. The chemo-free group, they received ibrutinib, was fine for 4 years, and then you give Ven plus rituximab fixed dose combination, but patient has progressed after 3 years. He has an additional comorbidity of coronary artery disease and deletion 17p negative. So I'll ask Dr. Sachin first, I guess. What would you like to do now?
You ask me? Yeah. So Dr. Rahul has just enumerated in his lecture also. So triplet is not helping much here. So I'll be happy with using BTK inhibitors with venetoclax in this patient. But of course, patient now has comorbidities, is a cardiac patient now, and we'll have to be very careful about the cardiac side effects and the other side effects here, especially atrial fibrillation and hypertension, diarrhea. So all these things are going to be problematic. And take care of tumor lysis also once we are starting the treatment.
Okay. So the data on doublet and triplet is more, it's more in the frontline setting where they're saying to say that you bring it up front, the Goldie-Coleman hypothesis, try to give all the best drugs up front. That's what they're trying to do. So Dr. Charanpreet, any other opinions you have? What would you do here?
So the one thing to take into consideration is the duration of the VENAR. So if you gave it for a fixed duration, and then the patient relapsed after, say, a couple of years, if you stopped venetoclax, then I think re-challenging with a venetoclax with a BTKI is really an option. However, if the patient was possibly on continuous Ven and he's relapsed on Ven, then I don't think giving Ven again will be a realistic option, and that's a true unmet need in CLL. One drug which is really gone out of fashion in the West, which was are the PI3 kinase inhibitors, which was initially in the guidelines, but now because they have so many BTK inhibitors and the side effect profile of the PI3 kinase inhibitors is quite poor, they're not using it. But in our setting, when we don't have those BTK inhibitors and we have a generic idelalisib available, and in 2030 I'm assuming other generics available, that is one agent which can be used. Otherwise we're looking at just trying to get the disease into control somehow and then pushing the patient for a CAR-T then.
Okay. But it is 2030, so it's possible that your non-covalent BTK pirtobrutinib must have entered India.
Pirtobrutinib, obviously, in patients who have progressed, so that's a non-covalent BTK inhibitor. Those patients who have even received previous covalent BTK inhibitors, including acalabrutinib, and even have the cysteine 481 mutation, pirtobrutinib has been shown to work in them, so that's an excellent agent in this case, yeah.
Okay. So we'll come to Dr. Nishant. So your patient has had a disease-free survival of 4 years of BR and then 3 years on RCOP and now has a diabetic and a coronary artery disease. He's still 17p negative. You are free to switch roles now. It's third line. Yeah.
So in this scenario, obviously, we'll go for a BTK inhibitor because even with the diabetes and the coronary artery disease, assuming whichever is the best available BTK inhibitor in 2030. But just because the patient has diabetes and coronary artery disease, I would not hesitate to give a lower dose of ibrutinib also. And utility of chlorambucil, so from what I have seen in patients in PGI who are getting a lot of chlorambucil, at this point giving it would not really be very helpful. I think the patient will have some response and then will become refractory. Not more than 3 months is what I would think. So I think this is the right time to switch to oral therapy.
Dr. Parnath, both the strategies we are having same PFS, same survival.
So, see, in a given case, anything can happen. In a study, you have like 500 patients,
So you
and you get a
educate
million
the
PFS this much. This is just, for discussion's sake.
Yeah,
I'm not trying to, say that chemo-free is equal to or better than, chemo is better than chemo-free, but we'll just take it for argument's sake this way. So I kind of agree with Dr. Nishant wanting to change roles in the second line, that he wanted to give BTK once the patient failed on chemo, in a sense that, delaying BTK too much is also not going to be as helpful. You don't want to give it too late that the benefit is too less here. And when the ibrutinib initially came to India, a lot of our patients were in the relapse already had failed 2 to 3 lines, and then we used the ibrutinib, and that was when we had the maximum cardiac morbidity, a lot of sudden deaths happening. So you don't want to, push BTK too much to the back either, but having said that, we have patients who are on chemo regimens, at least I haven't followed up, who are like, 15 years out and they are doing well and they're having a normal life. So it's not that chemo regimen cannot do that. CLL is still CLL. CLL is not changing, only we are changing. So the same question we asked Dr. Nishant, we put up to the Indian physicians whether they would like to use chlorambucil at any point in time. Surprisingly, there was only one promoter. There's only one person who said that, yes, I would use. Most said that they would prefer to not use chlorambucil. I mean, at least among the physicians whom we surveyed, chlorambucil has kind of gone out of fashion for them. So this is some real-world Western data. I know it's a little complex, but so the outer ring is your third line, the middle ring is your second line, and the inner ring is your first line. So basically what we can see here is that any combination has been performed. So you have like ibrutinib, CD20, venetoclax, ibrutinib, venetoclax, ibrutinib, chemo, venetoclax, chemo, ibrutinib, venetoclax, chemo, venetoclax. So any combination you want to use, the Westerns have tried it. This is real world data. They're not following the trial or they're not following the guidelines, but people have kind of tried it in all different combinations. We usually, earlier there was some reservations that if you use BTK inhibitor upfront, you're gonna, the disease is gonna turn bad and you will not be able to salvage them later on. That was the initial thought process going on. And then now people are saying that if the patient has failed ibrutinib and also has failed venetoclax, then they will not do well. But in the real world, people are kind of using everything in any sequence they want to, and that's what is happening, at least in the West. Maybe in 5 or 10 years down the line, we also have some similar data as to what works in the Indian setting. So a few final questions. So kind of similar to what Dr. Sachin was suggesting is, how is it possible that both chemo and chemo-free can, have the same treatment to an external benefit? I'll put the question to Charan Preet. So if you were the moderator, how would you have put it? How would the timelines have changed in yours? Would it be the same, or you would say chemo-free is better? So you are not in your role, you are out of your role. This is a common slide.
So I think the data published from our institute by Dr. Dipesh had shown that at that point of time, when we had published, the ibrutinib had not come up and we had not used too much of ibrutinib in the frontline setting. But if we do a cross-trial comparison and we look at the Resonate 2, the median PFS was something like 7 years for patients who had received upfront ibrutinib with non-del17P CLL, and obviously with BR, what you're looking at is a PFS of around 3 to 4 years. So yes, definitely the PFS you'll expect to be much higher in patients who receive a oral BTKI as compared to chemoimmunotherapy upfront, assuming that there's no del17.
Okay. And a question to Dr. Nishant, you're a transplanter, so what would you consider? Where would you like to do a bone marrow transplant for this patient? Like in the chemo-free group, the patient had failed on ibrutinib and on venetoclax. Would you like to do a bone marrow transplant there or CAR T-cell therapy there?
So transplant, there's a good GVL effect with CLL, so transplant is always an option, but then again, the patient has turned 60, and by the time she becomes refractory to whatever is there in 2030. She'll probably be 65. In such a patient, I don't think transplant is a great option. You know, it's going to be very difficult. So I would not really go for transplant in these patients who are elderly. CAR-T obviously is an option if there's chemorefractoriness and BTK inhibitors are not working and the ven has stopped working. So I think that would be a better option than doing a transplant in such a patient. I mean, at some point you have to kind of understand that, you know, the patient is 65 to 70 and not much can be done. So CAR-T would be a safer option then.
Okay. In a sense, CAR-T has become the fashion as far as lymphoma goes in the relapse refractory setting, but at least in CLL, there's still some hesitation because you have better drugs which you can give a reasonable quality of life. My final question to Dr. Sachin. So we know that ibrutinib has now come under PMJAY as well. So even the poor patients can afford ibrutinib to at least to some extent. So do you think 5 years down the line we will also become one India or will still remain two Indias?
I think it's too diverse. The disease is too diverse, from no treatment to so many treatments and transplant and CAR-T versus, and our country is too diverse with all sorts of socioeconomic status. So I don't think in 5 years this is going to happen. Maybe 10 years. Of course, the usage upfront would definitely increase over the period of time, but maybe it will take more than 5 years.
Okay. With that, I'll come to the end of my session. Thank you everyone for patiently listening. And thanks to panelists.
I think you did not ask the questions from the audience.
Yeah.
So, you know, although you believe that for next 10 years the patient would remain like CLL only, there is obviously this patient can transform also. And the second thing, we did not discuss much upon whether we need to do the KD mutation testing for the patients who are on ibrutinib therapy, and that will actually tell you whether to change the therapy or what kind of a therapy which you need to change. And the third thing is again doing a FISH test when you are changing the therapy, because some of those patients who are 17p negative may acquire these mutations. And the fourth thing is, I still believe that lenalidomide is not a bad drug. Even though Nishant did a kind of a maintenance therapy and it did not showed much benefit, but I mean there are other drugs. And the other thing is, you discuss about COP therapy. I would say mini-CHOP used to be used for patients who were failing chlorambucil prednisolone. So a 50% dose or a mini-CHOP which we use for many elderly non-Hodgkin lymphoma patient is good for even for CLL patients also.
No, I completely agree with the Len comment. I think that was one comment I was going to make. One worry always remains with FCR-BR kind of a regimen, particularly when you're hitting the older population. Are you creating a scenario for future MDS? Right, so that's one. I mean, I think it's somewhat underreported, the frequency of MDS in the long run. So that's something needs to be kept into mind. The question is that do we need to look mutations, BTK mutations or not? Hopefully in 7 years' time, if we come back, maybe the BTK degraders will come and the mutations will not matter anymore. Thank you.
Just a comment that it's well proven now that between the two anti-CD molecules, obinutuzumab is more superior in CLL than rituximab. Any combination we pick up with obinutuzumab with venetoclax or acalabrutinib or ibrutinib, the obinutuzumab stands better chance of having a progression-free survival in MRD, because that's where the world is moving towards, is that how can we have a time-limited duration, fixed duration therapy where to avoid the unnecessary toxicities of these drugs, both financial as well as the chemotherapeutic drugs. Thank you.
Like, one thing I'd like to just say here is regarding the patient choice of time. While the world is moving more towards time-directed therapy, like different people quantitate quality of life differently. So for some people, if you tell them that, this is time-directed therapy, but you'll need to come into the hospital and get it every 4 weeks, that's more problematic than staying at home and coming only twice or maybe 3 or 4 times a year and taking the oral medication. So the quality of life is different for different people. So that's why they may prefer oral BTKI over a fixed duration injectable therapy. So that's the discussion that we have when we start off with therapy. And some people like oranges, some people like apples, that kind of thing.
sorry to come back again. The other thing which I feel is, the data is generated like that obinutuzumab is better than rituximab. I'm not sure whether when we use the dose of rituximab in CLL, that is actually, supposed to be 500 milligram per meter square and not 375 milligram per meter square because of the weak expression of CD20. So, we always say rituximab is inferior to obinutuzumab. So whether, the trials which have used, whether they have used, the adequate dose of rituximab when they are comparing with obinutuzumab.
Yes, sir. So I think that the answer to that is all the Western world has used a 375 milligram in first dose, and then subsequently 500 milligram in second, third, and fourth and fifth, comparing with obinutuzumab. So both acalabrutinib versus plus obinutuzumab and acalabrutinib plus rituximab, obinutuzumab has been proven superior. And this 2023 trial just published in NEGM shows conclusively that when rituximab is inferior than when obinutuzumab. And the cost is also coming down. So cost is like 8-9 lakh rupees. So in a subset of people who can afford, and there are many people who can afford, that's why the physician's mindset has to change in these kinds of meetings, is that no age is too elderly. We are going to live up to 75. So 60 years when we say, oh, we are not going to transplant at the age of 60, probably we are pushing the benchmarks to 70. Because now allogenic transplant can be safely done with Flutrio at the age of 70, the way the Americans do it. So this is happening in India. At the same time, the obinutuzumab is being utilized with much of a less side effects. We have used just in one patient of 90 years old, who's a father of one of our colleagues in MD Anderson. 90, he had a cardiac event, and when in obinutuzumab, he's tolerating it very well at the age of 90. So I think mindset, as you go along and use more obinutuzumab, the cost has really started coming down. It's not 15 lakhs, it's 9 lakhs. And rituximab, either way around, you get in 2 lakhs. So it's the comparison-wise, you'll say, okay, this versus this. But the progression-free survival, if you see with obinutuzumab, probably will sway towards that. And you have a health economic guy who can actually help us in deciphering that.
Thank you, Dr. Parathan and the panelists for the entire beautiful and successful discussion. Dr. Nishant has himself done a clinical trial, only clinical trial on lenalidomide in CLL. And we need to look at the cost effectiveness analysis of obinutuzumab in the Indian settings. With that, I thank you all, and over to you, Dr. Manaswini.
Thank you, moderator and panelist. Delegate certificate will be available at registration desk. Kindly collect your certificate. And we are happy to announce that some of the selected abstract presenter will be gifted a free copy of PGI textbook. Kindly check your eligibility at registration desk. And all the faculty members, those who have not collected their kits, are requested to collect them from the registration desk. And now let's break for quick tea. Since you are running behind 30 minutes, so I would request you to come back after 15 minutes. Our next section will start sharp at 10:45 a.m. Thank you.
Oh, sorry, that's very loud. So
you need some stand to
no,
stand
no,
up?
this is just very loud. I didn't think it was so loud. So thank you very much, the honorable chairpersons, and without further ado, I will begin my talk. So hemophilia care, as we all know, has really transformed in the last several years. I'm old enough to remember when we only had plasma-derived clotting factors, and that too, they were very expensive and difficult to obtain. Now in India, we're pretty much using only recombinant factors, and there have been a lot of innovations in recombinant clotting factors. We now have third generation recombinant factors, and we also have the extended half-life products. In India, we also have non-factor therapies, but the speaker after me will be talking about the non-factor therapies. So I will be limiting my talk to the extended half-life clotting factors, which we've now had in India for several years, and we are seeing that they have many advantages. So what happens when we do prophylaxis with standard half-life clotting factors? So standard half-life clotting factors were a boon when they first came out, and we were very excited because with them we could treat patients who had bleeds, we could even save lives. And then we started prophylaxis because we wanted patients to have a good quality of life and we wanted them to be able to be productive. But there were limitations to prophylaxis with the standard half-life clotting factors. One, we found that most of our patients would not have zero ABRs, so that's the annual bleed rates would be zero, and many patients who had high bleed rates would continue to bleed, and we know that each bleed can lead to joint destruction. The other thing that we found was that when we were doing the prophylaxis with the standard half-life clotting factors, the frequency of the injections was very high. So in order to do it in an ideal way, you would need every alternate day injections for hemophilia A and maybe twice a week injections for hemophilia B, but this was also very difficult because there's so many injections that you need. So every week you're getting 3 or 4 injections, so that was really too much. And despite all of this, patients were still having bleeding. And the other issue in India is that most prophylaxis was not primary prophylaxis. So most of the patients that we had already had target joints, and they would continue to bleed in the target joints. So even with all the effort, even with all the expense, we were not getting good results. Now, this is a study where they talked about the trough level that we usually use when we're doing prophylaxis with standard half-life, and the goal was to try to keep the patient above a 1% trough level in order to convert this severe hemophilia patient to a moderate hemophilia patient and hopefully have less bleeds. But that trough level of 1% is not a magic number. If you have target joints, if you have high bleed rate, if you have a lot of activity, then keeping the patient, the trough level around 1 is not sufficient. So what has been found is that if you can keep the trough level higher in these patients and in other patients who are active, you will have a much better quality of life. But how do you attain a higher trough level with a standard half-life clotting factor? We know that that is very difficult. So there is really a paradigm shift with the advent of the extended half-life clotting factors, because these products, they increase the longevity of the product in the body, and you can have many advantages. You can prevent breakthrough bleeds, you can have fewer injections, and you can have a better trough level, and all of this translates to less joint damage. So the advent of EHL is really required, and all of the boxes that we needed to be ticked are being ticked by the EHLs. So how does this do it? So a lot of people have reservations about using non-factor products, and this we know we have 60 years experience of using clotting factors. So this is basically clotting factors which have been modified to extend the half-life. The method that we have most commonly in the products that we have in India are the pegylated ones. So by pegylation, you're increasing the solubility of this product, you're decreasing its accessibility to proteolytic enzymes, and you're reducing the excretion by the kidney. So you're basically making the product stay in the body longer. And with that, we can get the higher troughs, so you can easily reach to 4% or more, and the frequency of injections really reduces. So what does the WFH 2020, which is sort of the manual that all of us use for treatment, talk about EHL? So I'll start from the bottom. So first of all, safety. Now in our country, we are always concerned about inhibitors, and I think that's very valid because once a patient develops an inhibitor, then everything changes. So first and foremost, the extended half-life factors are very safe. In the previously untreated patients, whom we all know are the group where we're most likely to get inhibitors, there has been no difference in the development of inhibitors, in whether we are using standard half-life or extended half-life, and we know that in the pups, the reason for inhibitor development is usually the mutations that they carry. In the previously treated patients, there is again no risk of inhibitor development, and we know that in this population anyway, the inhibitor development is less. So there haven't been any safety issues. The biggest advantage is in the reduced injection frequency, not only because you have less pricks, but also people can, they don't need to take an injection before they go to school, before they go to work, before doing any activity. So you have less visits to hospitals, you have much more uptake because a lot of people found it very inconvenient to take these injections, and in small children, you may not find a vein if you're giving IV injections so frequently. So it's definitely very advantageous. And then the higher trough levels, I think, are really important because we have just been going with 1% because that was all that was really possible, and we always want to keep moving the goalpost and trying to get better. And now we have patients, at least at my center, who are actively engaging in sports, and their quality of life is good. So what does WFH say further about the benefits of EHL? It says obviously you have lower infusion rates and less need for central venous access devices. That is also cost saving and reduces in morbidity. And you have a much bigger uptake amongst many patients. Many adults would actually decline prophylaxis and rather just treat a bleed. And as I said, you have a much higher trough level. So WFH recommends prophylaxis with EHL clotting factors in sufficient doses and intervals for patients who have high bleed rates and frequent breakthrough bleeds in order to improve and preserve the joint function. So in India, we both have extended half-life clotting factor 8 as well as a clotting factor 9, and they're approved in India. So I'll start with hemophilia A. So the extended half-life clotting factor 8 that we have has a 1.6-fold longer half-life compared to the standard half-life clotting factor 8. And so this means that we can get away with, instead of having to do alternate day dosing, we can do less frequent dosing. And I know many people were using low-dose prophylaxis and maybe using it twice a week rather than the recommended thrice a week, but here you can actually do it twice a week or even longer gap and get a much better protection with the patient. And we don't really have data on the very low dose prophylaxis for many years, so we don't know actually what would happen in 10 years, 15 years for these patients. So here you're actually doing something that is recommended. The dose is a single dose that you could give every 4 days in adults, and with that you would get a good support. And a concept that we were not able to achieve with standard half-life was this concept of zero bleeds. Now, having zero bleeds is really the holy grail, and in patients who have been on studies, there have been 64% of adolescents and up to 70% of children had zero bleeds. So this is something that is from, of course, the Western data. Now, the big problem that we have in India is target joints. Target joints are patients who have a joint in which they have 3 or more bleeds within 6 months, and majority of my patients have several target joints. And resolution of target joints is really difficult. However, with an extended half-life factor in this product, there was a demonstration of 100% resolution of the target joint, which is really good and something that was previously not shown before. So you can treat your bleeds with 1 or 2 injections rather than having to give several days of factor, sometimes twice a day. You have no real safety risk, and you can even do surgeries with these products. So there is so this is definitely a game changer. And you can then individualize the way that you give the injections. Earlier, we would have to say that you have to take an injection in the morning before you go to work or before you go to school. Here, you have a lot more flexibility because of the longer half-life. So this is just a summary slide, and I think I have less time, so I will kind of keep proceeding. Now, what about hemophilia B? So hemophilia B, the extended half-life products are actually phenomenal. They extend the half-life much further. So rather than just a 1.6, you have a 5-fold increase. So you have a half-life of over 90 hours and a 10% increase in the area under the curve compared to your standard half-life recombinant factor 9, which translates to being able to give these products easily once a week. And the efficacy of this dosing of 40 units per kg once a week has been shown to really reduce the ABRs. Earlier, people tried 10 units per kg, but 40 units per kg seems to be the right dose. And again, you can have 0 bleeds with this. And if you're using it over time, specifically in patients who have got poor joints, the benefit actually accrues over time. So over time, whatever the ABRs are, further improve. So the clotting factor 9 extended half-life, again, is remarkable because here, again, you can treat with 1 or 2, you can treat a bleed with 1 or 2 injections. Again, the inhibitor risk is very low. And in this, it's even more phenomenal for surgery because you can actually do minor surgeries with a single dose. Here, the dose for surgery recommended is 80 units per kg, so a single dose of 80 units per kg, or if you're doing major surgeries, maybe 2 doses. So again, the actual consumption of the factor is much less. And again, the benefit of the target joints in these hemophilia B patients was 100%. Now, that's on studies. What about real-world data? So this is some real-world Canadian data in which they compared patients who had hemophilia B on standard half-life with target joints and hemophilia B patients who had target joints who were on the extended half-life product. And as you can see from the top, so you can see that this was the patients on standard half-life and these were the patients on the extended half-life, and the ABRs are much less in patients who are on the extended half-life. More than almost 30% of these patients actually had 0 bleeds as well. So this was real-world data, not a study where you select the best patients. This is actual, data. So to summarize, we can see that you have a lot of PK benefits, but the most exciting, I think, is the 0 bleeds and the target joint, and then the advantage is also there in surgery. So what about Indian data? So in the previous conversation, a lot of people were saying, well, that's other countries. What about in India? So there is, these were presented in the NHU update, and there's hopefully a publication coming up. So this is some EHL data from different centers in India, and what was found in the study about using it for major surgeries, decreasing the bleeds, making patients more active and having less absenteeism. All of that is being shown in many centers from India. So all of that is definitely there. And so these are just some of the centers that have talked about their surgery experience. And I think, again, this is being compiled as a publication of surgery experience, real world in India. Now, everything comes at a cost. So what about the cost of this? We know that it's a newer product, might be more expensive, and so this is a Markov modeling that was done in Italy because they also had this same question when they were planning to introduce it, and what they actually found was that you would end up using less product. Why do you use less product? One, because you're using less injections. So if something's 3 times a week, it's now going to twice a week, so 50 injections already eliminated. Then you have less breakthrough bleeds, so we also need to remember when you're doing prophylaxis, you also have to budget for the extra injections that are there to treat a bleed. And if you're doing surgery, again, you need less product. So if you can see this, the patient number and all is the same, but what is decreasing in the lower boxes is the actual usage of the product. So over time, if you actually are using the extended half-life because you're just making that stay longer in the body, you can save a lot of money. And in this Italian study, they calculated that they would save €1 million over a 3-year period. And this is another study that was a modeling, and this is some real world data where again they found a huge amount of saving, and it shows that by using this extended half-life factor, so that was for factor 9 and this is for factor 8, they found that there was no actual increase in expenditure. You would actually save money, and this is a Canadian study, again real world, where they found that these patients had fewer bleeds, less injections, and you reduced your clotting factor consumption, which of of course, if you're reducing 65% of factor, then that's, 65% is really important. Now, this is actually a slide that was given to me by the company, but I removed the name because we have to be careful. But I think what is important to show is that with just one injection, you can treat a mild to moderate bleed, and so the units used are going to be much less. And if you have a severe bleed, obviously we're going to treat for several days. If we're going to use the standard half-life, again, with just one injection, you can treat a severe bleed. And for surgery, even major surgery and the rehabilitation and other things that you're doing, again, you could just manage with 2 or maybe 3 injections. So your overall use is reducing. So at AIIMS, we have been using these products. We have a lot of patients who are ESI, CGHS, and other railways and other things. And we have been able to use this. And again, as I said, I think my experience with the target joints was absolutely amazing. It is actually unbelievable to see the fact that the target joints reduce. And over time, you see an increased benefit. And the same thing with the extended half-life clotting 9 factors. We were able to do major surgeries with just 2 doses. We even did a joint replacement with only 2 doses. And the resolution of the target joints in the hemophilia B patients was 100%, and even in the hemophilia A patients, it was really good. So I think you're using clotting factor. So again, there's no hesitancy on the part of the patient. You are able to reduce the number of injections in a hemophilia A patient to at least 30% less injections. So for children, that's very important, and even for adults. And if you're using a hemophilia B agent, factor 9, you reduce the injections by more than 60%. And you can safely get to a trough level of much higher than 1%. So in factor 9, it's very easy to get trough levels of 5 to 10%, and even in the extended half-life factor 8 products, you can get a trough level of 2 to 3%, which is the reason for the reduced ABRs and the reduced target joints and the better quality of life. So I think we have these products available, and I think we have a lot of practical experience, and I think it's important for us to do health assessment cost analysis, and I don't know if Joseph's here, but we have one paper that's coming up in hemophilia on the cost effectiveness, and we're trying to do some more studies in that field so that we can generate real-world data from India as well. So with that, I end, and I think that it's really important that we think about the patient's perspective as well, and we need to make sure that they don't have suboptimal quality of life, and by using extended half-life products, we can improve the quality of life. We can definitely give them a better life, and at the same time, not necessarily break the bank. Thank you.
Thank you, Dr. Tulika, for a very nice presentation on extended half-life factor and how they stand against the standard product. Now the paper is open to the house. If any question is there, you can ask. The cost part, she has already said that the cost is ultimately evens out because of the less bleed and less amount of product you use.
So,
use your mic.
So the question was on inhibitor development for our experience. We have not a very large body of evidence, but we've used it only in previously treated patients, and we've not seen any inhibitors, but those are anyway a group where we don't anticipate too much inhibitor. So in the previously unexposed patients, I have not used extended half-life that much.
Ma'am, it was very good presentation. So, do you have any experience, those who have already developed inhibitor and then you have given this product?
Okay, so that's a good question. Now, once patients have developed inhibitors, we have to change track. So this was clotting factors that we are using. So this is basically the same as the standard half-life, except that now they are extended half-life clotting factors. So once patients have developed inhibitors, particularly if they're high-titer inhibitors, we now have to change track, and I will leave that to the next speaker to tell you what other options we have. But then you have to use bypassing agents or non-factor products. So this is a clotting factor product. So this is for the non-inhibitor patients only. Right.
Thank you, Dr. Tulika. Now we can go to the next speaker.
Our next speaker is Dr. Varun Kaul. He will be speaking on non-factor replacement therapies, what the future of India. Dr. Varun Kaul, please.
Thank you very much, respected chairpersons. It's an honor and a privilege for giving me an opportunity to be here in front of the elite PGI and the elite faculty from all over India and all over the world, I suppose. And first of all, thanks to Team PGI for managing some PWH and children with hemophilia who we refer because of some non-availability of treatment facility at our center, and there we are giving the excellent results. So teamwork is wonderfully done well. Thank you very much from the bottom of our hearts. So I'll be discussing, my job has been made very easy by respected Tulika ma'am. So we are her students, and my job is now to go to the next line of therapy. So what are the non-factor therapies and what is the future in India? So what is hemophilia? I will not be talking about what is hemophilia, but yes, it's a bleeding disorder, majorly hemophilia A and B. Common is hemophilia A, which is seen in around 80 to 85% cases of all severe hemophilia, and hemophilia B is seen in 50 to 20%. And if we talk of the severity, it's based on the underlying factor levels. So the factor level, if it's less than 1%, it's severe, 1 to 5, it's moderate, 5 to 40, it's mild, and anything between 50 to 150% is normal. So ultimate goals of treatment of hemophilia. So first and foremost, we have to prevent premature deaths. So we have seen, because of the lack of the diagnostic facilities, we are having premature deaths in terms of IC bleeds happening in children, especially in the neonatal period and infancy, where we miss these patients because of the non-availability of diagnostics. But we have come a lot in the recent times, and we have got the facilitation from PGI, as well as we are having the coagulation studies done in our center also. So we are picking up new patients at the same time. So from right from prevention of death to a normal hemostasis and optimized health and well-being is the goal of any treatment for PWH. So this slide has already been presented by Tulika ma'am, but I would go to the last one, that is 2018. I remember vividly when I first observed this therapy and I was told about this therapy, I was a little skeptical. So skeptical regarding, the data was there, the trials were there, but I was skeptical about the cost. But somehow that has also been taken care of. So all these first generation, second generation, third generation factors are available. As rightly ma'am has said, EHLs are available. We have now another factor, factor 8, that is Altuviiio, which has got an even extended half-life for factor 8 patients. So, but with the advent of non-factor therapies, this is something which is really debatable, that what should we go for and what challenges we are facing. So the proposed approaches for FDA-approved indications of hemophilia A, B, and hemophilia A. So right from just managing on demand to going for prophylaxis, I'll not say prophylaxis, regular replacement, and then finally the gene therapy, which is a reality nowadays, both hemophilia A and B. So we'll go to the first out of the lot of non-factor therapies, that is an emicizumab. So emicizumab is a monoclonal antibody which restores the coagulation by bridging the factor 9, activated factor 9 and factor 10, which does the job of actually activated factor 8. So it's a bispecific binding to these two, clotting factors, and it generates thrombin. So thrombin to the tune of that much only, which keeps the coagulation into balance, and we achieve roughly a trough level of 16 to 20%. So we'll have the patient converted into a mild phenotype with emicizumab. So the dosing options, first there's a loading dose. We start with 3 milligram per kg, and the beauty of this drug is that it's to be given subcutaneous like all other monoclonal antibodies. No IV access required, no specialized training required, and there are minimal side effects with respect to even the local side effects, which we have seen because I have been using this drug for the last 3 years now. 4 years, because we started as a compassionate program for one of the CWH, and he's doing phenomenally well. I'll show you the video also of that child. So we start with the loading dose of 3 milligram per kg for 4 weeks, then we can go to a 1.5 milligram per kg every week, or 3 milligram per kg every 2 weeks, or 6 milligram per kg once in a month. So rather than talking of giving a prick every 4th day, or every alternate day, so once in a month, this is something which is out of the box. And we are getting good bleed controls, as we can see from the trials. So there have been the Haven trials, where we have seen that the ABRs over time have decreased dramatically. So you can see over here, there is a decrease in the bleeding pattern. So there is an overall decrease going on even up to 0, in some of the patients, especially the pediatric population, if we see. So if we talk about the treated bleeds with ME prophylaxis, so in Haven 1, which was on adults and adolescents with inhibitors, so Haven 2 was on pediatric patients with inhibitors, and Haven 3 was adults and adolescents without inhibitors, and Haven 4 was on adults and adolescents with or without inhibitors. So there was a dramatic reduction in the number of treated bleeds, even in the patients, any type of treated bleed. So 0 bleeds over time. So this is, as ma'am already said, that this is the holy grail of hemophilia right now. So what we are going to plan is like, what are the chances of the PWH or the CWH going for 0 bleeds? So if you see the 0 bleeds over time, they are increasing in all the trials. So there is a we would have thought of that would be a drug which given can reduce the bleeding dramatically to the tune of the child will forget that he's having hemophilia. So probably we are on the path of achieving that. So as rightly said, target joint resolution is something which is very, very important. So these children, they come limping, they are in severe pain. And when you find that this child is now without pain and the joint is also resolved, and to the tune of they are doing gymming and they are doing football, they are playing cricket, it's something out of the world experience. So if we talk of safety, as ma'am rightly said, that the safety is the first and foremost concern. So there were some concerns regarding the use of drug in terms of TMAs and TEs in the Haven 1 trial, but that was supposed to be because of the concurrent use of bypassing agents, especially APCC. That too in a higher dose of 100 IU per kg. Whenever there was a use of more than 100 IU per kg, that led to those 2 or 3 TEs, and one of them resulted in death. And after that, there's a black box warning to be, which has been given in the product insert, that we don't have to use bypassing agents as an on-demand treatment on these patients who are on ME prophylaxis. So there were some neutralizing antibodies present in one patient, but later on it was also self-cleared. So conclusions, so we have seen a long-term safety of patients with hemophilia treated with emicizumab, and the experience continues to be pouring in. As ma'am rightly said, we are also in the process of publishing the real-world evidence of the data of the patients which we are having on emicizumab. So right now we are having more than 20 patients on emicizumab, including those in government sector and those who are being given the drug through the CGHS, ESI and all. So we are publishing the data for the same. So there is one more trial going on in US that is regarding Haven 7, that is incorporating the pups and infants. So I had the opportunity of listening to Dr. Guy Young, so he presented his data, preliminary data of infants. So they are starting straight away, the patients who are diagnosed with hemophilia A on emicizumab during infancy. And they have seen that it works dramatically, and the chances of IC bleed have reduced very significantly. It's very difficult getting the vein of a child, especially 1 to 3 year or less than 1 year child. Every 3rd day or every 4th day, you are to get a vein pricked of a child. So in this case, once in a month, you give the shot and forget it. So they have seen that they have maintained, 77% of them have maintained 0 treated bleeds with no new safety signals generated. So we go to the next new generation factor 8 mimetic, which almost has the similar, structure or similar efficacy with respect to working, that is Mim8. So So it also has the same mechanism of action, like bridging the gap between factor 9A and factor 10 and leading to thrombin generation. It's not yet FDA approved, but it's in the process. The only caveat about this product right now is that it's 15 times more potent. So there may be theoretical chances of increased thrombosis. But right till now, in the concurrent trials, there have been no safety signals generated with this product. So there comes the newer concept of emerging therapies where we will do rebalancing, where we are planning to rebalance the both clotting as well as the anticoagulant pathway. So we know that as a part of the maintaining of rheology of the blood, that is the flowing state of blood, we need to have anticoagulant system which is more predominant as compared to the coagulants. So in hemophilia, what is happening is that the coagulants are less in quantity and anticoagulants are more, so there is bleeding. So what we can do, like we are doing rightly now, we are trying to replace the coagulants with the factor replacement and balancing the bleeding with respect to the anticoagulants. The other way around can be, we can balance the clotting with the anticoagulants decreased. So there are some pathways by which we can do this. So as we have already seen, there can be protein C directed mechanism, there can be antithrombin directed mechanism and TFPI directed mechanisms. So we have the development of antibodies, again monoclonal antibodies like concizumab. So there was recently a paper published in NEJM which is showing superior efficacy of concizumab in patients of both hemophilia A and B. So and then fitusiran, again it's an antithrombin drug. So it's an it decreases the antithrombin levels and at the same time increases the thrombin generation and thereby balancing the pathway. So fitusiran, I had a talk with Dr. Cecil Ross. He is in St. John's and they are getting it as a part of the trial. So I had a side talk with him in NHU and he was like, wonderful, this is a drug which is like, which will change the future of hemophilia landscape. But only problem with this product, which we'll be discussing in the subsequent slides, that there is some issues with this drug with respect to dose titration. And then we have Serpin PC antibodies also. So if we talk of the fitusiran, it is a signaling RNA-targeted antithrombin. It is also subcutaneous. So it can be used both for hemophilia A and B. And it has been shown to found benefiting in case of both hemophilia A, B with and without inhibitors. And there are the ATLAS trials which have gone in for doing this. So what does it do? It decreases the antithrombin levels and at the same time the thrombin is produced more and it rebalances the deficiency of clotting factors. So in the ATLAS trials, INH A and B, so they have compared the fitusiran with bypassing agents on demand and they have seen that there is a reduced bleeding rate with the use of fitusiran and there was an estimated ABR reduction of more than 77% in case of fitusiran. So if we talk of the safety, yes, there were some safety issues with respect to developing of thrombosis, especially the deep vein thrombosis, superficial vein thrombosis and subclavian vein thrombosis in these. And there were treatment emergent adverse events like increased AST, ALT and thrombosis which were seen with fitusiran versus on-demand therapy, but none of them translated into death. So these patients responded well because they had a mechanism put in place when this is also showing the same effect of BPA versus fitusiran where there is a reduction in the ABR. So what they did was the revised dose regimen for fitusiran. So initially it was given as 80 milligram once in a month. Then they, depending upon the decrease in the antithrombin levels more than 35% from the baseline, so they were able to reduce the dose to 50 and then 50 every 2 monthly. If still with 20 milligram monthly or 20 milligram 2 monthly, the levels were less than 15% of the normal, so they discontinued. So same I talked to Dr. Cecil Ross, they stopped the drug in 2 of their patients who had persistently decreased levels of antithrombin in them. So the patients were happy, they were not having any evident thrombosis, but the levels were less and as per the protocol, they were discontinued. So they were saying that please don't take us off the drug, they were bleed free otherwise. So the second drug is concizumab. So it is also recommended for both A and B with and without inhibitors. So we can see the effect of recombinant factor 7A in concizumab with respect to decreasing the ABR and same with respect to factor 7A in concizumab depending upon whether all treated bleeds or spontaneous treated bleeds or joint treated bleeds. All these bleeds, they decreased in the Explorer trials. So we had the no prophylaxis versus coinzuzumab prophylaxis arm, where the patients are randomized. So ABR outcomes, as you can see, right from 11.8 reducing to 1.7 in these patients. So similarly, Explorer-7 trial also showed 91% reduction and 69% reduction in treated spontaneous traumatic bleeds in a case of hemophilia A and hemophilia B. With respect to the adverse events, yes, there were adverse events, but most of them were local injection site and reactions. So there was no serious event. Yes, there were fatal events both in the randomized groups with respect to no prophylaxis and coinzuzumab prophylaxis, but it was because of road traffic accident, and other were attributed to pneumonitis and death because of COVID-19. They were ultimately not reflected, the death was because of the coinzuzumab. So there was a report of some treatment being paused in phase 3 trials after 3 patients had thrombotic events, but later on, because of the dose reductions which were done on the basis of ELISA measurements of the coinzuzumab levels, so they were again re-recruited and they did not have any problems. So then there's a Serpin PC in severe hemophilia A with or without inhibitors. So it acts on the activated protein C, decreases the activated protein C, which in turn decreases the effect on the prothrombinase and decreases the thrombin generation. So in a way, balancing the pathway. So it is also being given every 4 weeks as a subcutaneous injection at 1.2 milligram per kg. So there were no treatment related adverse events seen in the phase 3 trials. So these are some of the newer molecules which are being documented as a usage in case of hemophilia. So marcizumab again in anti-TFPI. Then bevacizumab, this trial was terminated because of the 3 CNS venous thromboembolisms in phase 2 without concurrent factor. So as we have seen already in emicizumab, the embolism, the TMAs were because of the concomitant use of APCC. So herein, without even the bypassing agents, they had thromboembolism, so this was discontinued. So anti-APC, the proof is good. Anti-PS, it's good. So they are recruiting still. We don't know the current status. So now comes the newer concept of gene therapy. So we have been able to, get this gene therapy possible. So we have gene therapy trials in hemophilia A. So one of the gene therapy which has been, recommended and it is in place in European Union. Still, it is not approved by US FDA. So it is velactoxin roxaparvovec. It's Roctavian. It comes by the trade name of Roctavian. The cost is humongous right now, but they have seen the results are very good. So the modified intention to treat graph shows that there is a persistent reduction in ABR, as well as the factor VIII concentrations are remaining well above the threshold of like 20, even despite 104 weeks of study. So there were no adverse events reported in this study. So there was, as we know, that is an adenoviral associated vector delivery. So that colonizes in the liver. So there were, as usual, there were ALT increases, and there was no thrombolytic event reported and no factor VIII inhibitors were reported. So there have been associated immunosuppression used in this intention to treat protocol population, wherein we had to use, they had to use corticosteroids, budesonide, tacrolimus, mycophenolate for some time so that the gene can be taken up. So we have already discussed that it's an AAV5 derived vector-based gene therapy for hemophilia A. So because AAV neutralizing antibodies, whenever they are present, it is a big problem. So 65% of the population will have this kind of a presentation, so they are not used. So treatment for hemophilia is expanding, so we have the availability of all these non-factor replacement therapies, and future is full with these subcutaneous therapies, and all the children who have this hemophilia can look to a disability-free life and add to a less prick induced life. So there are some real-world evidence which I would like to share with you from our experience. So I have just 4 studies, 4 cases. So this is a kid who was on emicizumab. So he had a fall from brick from a 10 feet height, so on his head. So imagine a child who is inhibitor positive, high titer inhibitor positive, brick falling on the head from 10 feet high, and scalp bleeding. Even in a normal individual, the scalp bleeds like hell. So bleeding was there, but we could stop with just 2 milligram of factor 7. And to tell you, the weight of the child is 80 kg. So there is another child, he had a trauma to the triceps blade. So in Punjab, there is a lot of, poverty, and they don't have the facility for using even coolers. So there was a fan without the cage which would protect. So the fan blade went through the triceps and cut the triceps, as you can see in this figure. So we could manage only with 1 milligram of factor 7 and he did not bleed. So this is something which is very life-threatening for this particular person. So you can see the condition of the car. So this was a head-on collision with the stationary truck, and the PWH was traveling in that car, and he was on emicizumab, although non-inhibitor, but he just came out with just a nasal bleed and no major trauma and no requirement for any prolonged factor therapy. So this was something which was very good. And I just want to show you this guy. So this is one of our PWH. So he was totally bedridden. He was not able to go to school. Total school absenteeism for more than 4 months. And as you can see from his, leg, so totally wasted and emaciated. And now what he can do post emicizumab, you can see. So he's doing push-ups. So this was something which was out of the box for us. And this is the first patient which we had received as a humanitarian grant from the company, wherein we were able to put him on emicizumab therapy prior to COVID. So he was totally going on a scooter. If you must have watched that scooter in which the legs are totally curled up. So the only way of mobility for him was that scooter. So right now, this is his condition. So he can walk unassisted, and this is something which was really wonderful. So in the last, I would like to go through this beautiful, couplet from none other than Sir Robert Hutchinson. And we in all pediatrics and medicine, everybody knows who Sir Robert Hutchinson is. And there is a famous couplet from him. So I will just say the starting and the last. So he says, from inability to let well alone, and from making the cure of the disease more grievous than endurance of the same, good Lord deliver us. And that means if you cannot correct something, please don't try to distort it. And at the same time, be always in pursuance and be always worry about using newer things, but with the evidence we can use, but never forget the older ones, because they will remain and they are a part of the treatment armamentarium. So thank you very much, and any questions, please.
Thank you, Dr. Kaul. Thank you for a very nice presentation. Your paper is open now for discussion, if any question is there or comment is there from the hall. I will give you a story. Basically, the story of fitusiran starts from my institute. We published a case in 2001 where a family of a normal and 2 hemophilics. One hemophilic was severely bleeding, 3 brothers. One hemophilic was not bleeding at all, and normal had a thrombosis. And this patient who was not bleeding at all and the thrombosis normal one had low antithrombin 3 level. This we reported, and after that I contacted 3 important pharmaceutical industry to help us developing an antithrombin 3 directed RNA molecule. They refused because they said it will not be done. Then I was contacted by a company called Al Nilim from United States. And obviously we could not get in because of government and other kind of things. So they developed the first material. And both fitusiran and the other one where you have antibody directed to the inhibitor of the pathway which produces the thromboplastin, the concizumab and others. Both of them have good tendency to cause thrombosis. So fitusiran was actually discontinued for some time and was reduced. So basically, fitusiran will always require antithrombin 3 assessment, and if antithrombin 3 falls, there could be thrombosis, and if there are other pathological problems, they can have thrombosis. Now, if there is any question or comment.
On the same line, taking cue from what you mentioned and what Dr. Ghosh is mentioning,
would anti-fibrinolytic drugs like tranexamic acid have a role? I mean, relook at that as a possibility, as an additional way of handling these patients?
Sir, as far as our practical experience goes, we have been using, as recommended, it's a, if there's a mucosal bleed, it is one of the best adjuvants. But what we have seen in our clinical practice, even with, because we are a resource constrained economy. So what we do is we give factor support, but we also give, tranexamic acid for 3 to 5 days. And in our clinical experience, it causes a, recovery which is faster as compared, because we don't have the availability of factors in the right amount of dose like what is written in the Western literature. So ma'am was talking about very low dose prophylaxis, we are giving very low dose on demand also. So with that, because we have to take care of all the PWH, so we are using as a part of, even if we talk of patients who are on APCC, because it's also very costly, so there is a warning that we should not use tranexamic acid with APCC, but under guidance of PGI, so we are even giving, like with 25 IU per kg of APCC, we are giving low dose tranexamic acid also, along with it, and it causes a bleed resolution even in the joints. Yeah. So it can be looked as a part of trial also, sir.
Another one problem is there with Hemlibra, that is emicizumab, because it is not a standard factor, so you cannot measure it in the standard way. And the another problem, as he has shown already, if somebody has an acute bleed, you cannot use really emicizumab, because you have to then use standard factors and other kind of factor. So if there is, you want to ask something? Yes, please. You come to the microphone. Microphone mein aa jaiye aap.
Well, primarily because earlier, before all these drugs came into use, we used to use cryoprecipitate. And well, nowadays even some of the centers still use it. It is not.
Yes, sir. Yes, sir.
And we also were advocating that we give desmopressin DDAVPs, and so that we use a nasal spray.
Yes, sir.
For this. How you have felt?
Sir, first of all, the availability of the nasal spray, because we need a 150 microgram spray, and it's not available that too very commonly. So Mindrin 150 is probably available. I don't know about AIMS and PGI, is it around here? Because in our surroundings, it's not available, sir. And it is only recommended when we have a baseline von Willebrand factor along with factor 8, which may be even mild to moderate. So in severe hemophilia, it is not going to work, because ultimately it is going to release the factor 8 which is bound to the von Willebrand factor. So if we don't have the factor 8 in severe hemophilia, it's not going to work, sir. So in mild to moderate, yes, without inhibitors, we can try, especially in the bleeds. But just a caution that we have to take care of the fluid intake prior and after giving, because a high dose, this thing. So we are using Mindrin spray 15 microgram for nocturnal enuresis, but 10 sprays in nostril, the vial is gone. So it's a practicality issue. We can try, sir, in mild and moderate hemophilia. Yeah.
Right, yourself. आप कुछ पूछना चाहते हैं ना? पूछिए.
Sir, I was trying to ask this thing कि जैसे factor 8 होता है normal, उसकी half life 12 hours होती है. तो हम उसकी जो डोज है वो 48 आवर्स के बाद लेते हैं. लेट्स से कि हम थ्राइस अ वीक लेते हैं, एवरी अल्टरनेट डे लेते हैं, तो दैट कम्स आउट टू 48 आवर्स. जैसे आपने हेमलिब्रा के बारे में बताया, इसकी हाफ लाइफ आपकी मैं स्लाइड में देख रहा था 30 डेज लिखा हुआ है.
यस.
सो उसका हम 15 दिन के बाद ले रहे हैं, 30 दिन के बाद ले रहे हैं. व्हाई आर वी नॉट गोइंग फॉर लाइक 2 months डोज एंड और लाइक दैट?
So yes, you are right in this question. So there are some studies which have already been published and presented in ISTH by Dr. Ruchira, and Dr. Tulika might be able to better answer this. So there are very low dose, prophylaxis with emicizumab, wherein we are giving just 1.5 milligram per kg once in a month. So our target is to convert a patient of severe hemophilia into moderate type. So even with factor prophylaxis, that is even EHL or SHL, we are converting with a trough level hitting of around 3 to 5%. So if we are talking about emicizumab, it is giving us 16% with the routine dose. So if we just theoretically, if we just reduce the dose 4 times, we'll be targeting around 4. So that is the basis of giving low dose, and probably PGI is also planning for this low dose prophylaxis for all patients with hemophilia A, especially coming to them and who are a part of the hemophilia, management in the PGI as such.
नहीं, एक मिनट, सुनिए. When you are telling about factor, 5-6 हाफ लाइफ तक जा सकते हैं. एंटीबॉडी का हाफ लाइफ जो एमसीजुमाब है वो एंटीबॉडी है. एंटीबॉडी का हाफ लाइफ 2 और 3 हाफ लाइफ के बाद जितना एंटीबॉडी रहता है वो कामयाब नहीं होते हैं. एंटीबॉडी अलग है, फैक्टर का तो अब 1% 2% तक जाते हैं ना 100% से. लेकिन एंटीबॉडी का 4 हाफ लाइफ के बाद वो मोस्ट ऑफ द एंटीबॉडीज आर डिस्ट्रॉयड. उसीलिए उसका जो हाफ लाइफ है उसको आप उतना नहीं कर सकते.
Sir, I would like to come in, sir, with one point because, sir, what happened during COVID, I told you about that patient who is now walking. So this patient was bleeding like 3 to 4 times in a week before shifting to emicizumab. And with the onset of COVID, we could not get the drug. And after stopping the drug, he was on 3 milligram per kg loading and 1.5 milligram per kg weekly. So after stopping the drug, he did not bleed for 5 months, sir. And this is on record. So he did not bleed for 5 months. So something we have to see on this pattern also.
Doing any physiotherapy or anything.
Yes.
Then once you have started the thing, he started all those things together. So that itself has contributed.
Yes, yes.
And as you said, it has to be seen. Every individual is different.
Yes, yes.
But whenever we give any antibody therapy, 3 or 4 half-lives, the antibody usually lasts in the body.
Yes, sir.
So just to summarize, I think what Dr. Ghosh has already said, I think one, we should always follow the guidelines. It's nice to discuss, individual cases, but an individual case cannot make a policy or a practice decision, and we definitely need to keep publishing our data. Once we have more data, then perhaps we can say, okay, perhaps in Indian patients we can use lower dose. So I'm really excited that lots of people are having great discussion on this, and now we need to see more collaborative work and more publications. Thank you.
Thank you, ma'am. Thank you very much. Thank you, sir.
Next speaker is Dr. Aryans Jain, and he'll be talking about managing surgery in patients with hemophilia. Dr. Aryans Jain, please.
Thank you, sir. So with the background of the clotting factor therapies and the non-factor therapies, my job is easier. So the topic outline is the perspective, the prerequisites for surgery, hemostatic therapy for surgery, what are the things we need to keep in mind with standard half-life products, extended half-life products, bypassing agents, emicizumab, and anesthetic considerations, the post-operative considerations, and a few slides on our own experience. So if we go to the 1935 era, surgery in hemophilia was a scary proposition for patients and doctors. The old articles do mention that surgery in hemophilia is very difficult. It should be postponed till the patient is close to death. There were other reviews which were written in 1960s. They still maintained the view that hemophilia surgeries are actually forbidden, and there was a estimated 30 to 60% mortality even in the elective surgical procedures. So much has changed in the last 50 years. Over the 2 decades now, in fact, we are comfortable probably in doing surgeries even in patients with inhibitors. There are guidelines and multidisciplinary management protocols which are available for doing surgeries in patients with hemophilia. So, to an extent that now we are actually talking about giving thromboprophylaxis while these patients undergo surgery. So, but still the challenges are there. The first thing is the fitness for surgeries. These patients do have comorbidities because of their unhealthy joints. They may be obese, they may be gaining weight, they might be having liver dysfunction because of the viral infections, transfusion transmitted infections. Their vascular status may be compromised. The protocols for the anesthesia, analgesia, and anticoagulants are not uniform and robust in most centers. discuss the various factors which are required for effective hemostasis. They may be in short supply or difficult supply. There is a longer course of rehabilitation after surgery, and then there are questions regarding the optimal duration of hemostatic cover after surgery. So, but before that, so if there are so many challenges, then why actually do we need surgery in hemophilia? So basically, surgeries are required, one, for hemophilia-related complications. Most commonly, they are either related to the joint bleeds, where we need a lot of orthopedic procedures and knee replacements. Then, and there is data to suggest that these surgical procedures actually lead to pain relief, fewer bleeding episodes, they improve the mobility and quality of life. The second most common reason why these patients would need surgeries which is related to hemophilia related complication would be intracranial bleeds. So I think even in our center we would be getting some 5 or 6 patients in an year with intracranial bleeds who would actually require surgeries. Then there can be certain unrelated complications, most commonly the genitourinary, gastrointestinal or dental complications which require a surgery. So the first prerequisite for surgery in hemophilia is the development of a multidisciplinary team that would comprise of a laboratory specialist, a hemophilia physician, a surgeon, anesthetist, physiotherapist, financial support, and a transfusion support team, and they all should be well versed with the intricacies of hemophilia management. So what would be the goals of this comprehensive care team? The first thing is to have an accurate diagnosis of the bleeding disorder. A lot of times there is a difference between von Willebrand disease and hemophilia which is initially missed, and that label has to be ensured that the VWSA has been done when the diagnosis was made. There should be accurate assessment of the need for the surgery, the timing, whether it is elective or urgent, the accurate calculation of the factor support, the conducting of surgery with minimal trauma and blood loss, and adequate post-op rehabilitation. So surgery, particularly the elective ones, it has to be a shared decision making, and we have to discuss with our patients whether it is a right choice or not, and at the same time we have to discuss amongst ourselves that does our hospital have the adequate means and support to conduct that surgery. Coming to the phases of management of hemophilia surgery, like any other surgery, there would be a pre-operative, perioperative, and a post-operative phase. The pre-operative would start with confirming the diagnosis, the perioperative, the hemostatic support, and the post-operative, the rehabilitation procedure. So, as all anesthetists are well-trained in taking the medication checklist, so same holds true with the hemophilia as well. There are a lot of medications, say NSAIDs, beta-lactam antibiotics, SSRIs, omega-3 fatty acids, herbal supplements, and in a country like India where people are so fond of taking all these things, these drugs do interfere with the platelet function and coagulation, so these needs to be, they all need to be stopped before we are contemplating a surgery in these patients. Then coming to the guidelines of the management, the actual hemostatic therapy per se, that the Gita, the WFH third edition of hemophilia does mention a chapter on this, and they say that it has to be a comprehensive hemophilia treatment center. The inhibitor screen and assay is mandatory before doing the surgery. Regarding the anticoagulant prophylaxis, they say that it has to be individualized. So coming to the classification, what type of surgery these patients would undergo, these can actually be classified as major surgical procedures and minor surgical procedures. Major surgical ones are the ectomy and otomy procedures, and even a dental extraction which is more than 3 teeth is actually a major surgical procedure, while central line insertions, liver biopsies, prostate biopsies, circumcision, wound suturing would actually be minor surgical procedures. So the definition of a major surgery is anything which requires, this is specific to hemophilia, anything which requires a general or a spinal anesthesia, a provision of respiratory assistance, penetration of a major body cavity, or any orthopedic surgery on the joints or 3 teeth. And the WFH says that any surgical procedure where your requirement of hemostatic support is exceeding 5 consecutive days should be classified as a major surgical procedure. So first we would do the pre-op lab assessments. In addition to the confirming the diagnosis of hemophilia, they would also need a lipid profile, a viral marker screen, and probably a microbial status of MRSA carrier thing, because the implants are notorious to get infected, and if they are having an inhibitor, then we need the exact assays of the titers. So this is the role of the coagulation lab. Ideally, it should have both one-stage clot-based assay and the chromogenic assays, and even with probably bovine reagents available. And the lab should actually be offering 24/7 services, including weekends, if emergency surgeries are being conducted in that hospital. So the practical tips are that you should plan in advance. That's the one takeaway. You should determine the choice of factor and the non-factor support which you would be taking. Ensure that factor support is available in the vicinity of the patient, because all the time we are inducting factors from the government agencies, and sometimes there are inadvertent delays. Weekend surgery should always be avoided. Then once we have actually decided to do a surgery, the pre-operative bolus should be 30 to 60 minutes prior to surgery, and the post-op monitoring should be depending on the half-life. It is generally 8 to 12 hours after the standard half-life factor 8, 12 to 24 hours after standard half-life factor 9, and any stat level. If then immediately we would need a factor assay if there is any inadvertent bleed. In addition to ruling out the anatomical causes. These two definitions, the younger people need to be aware of: the peak level and the trough level. The peak level is one which is measured within 1 hour of a bolus injection, and the trough level is the minimum factor level which is measured immediately before the next scheduled bolus injection. So going to the pre-anesthetic considerations, something which we need to interact and tell our anesthesia colleagues that peripheral lines should be secured with utmost care. The line is an issue. Intramuscular injections and arterial punctures are to be avoided. The plane of anesthesia has to be smooth and deep. There should be, as far as possible, we should avoid neuraxial block and regional blocks. Succinylcholine, which is almost used in every surgery, should actually be avoided because it causes tremors and cramps, and that can lead to hematomas and bruises. The intubation should be atraumatic. Suctioning should be avoided. NSAIDs, which are so commonly used for post-operative analgesia, should be avoided, and hypothermia should be avoided. Then when we are actually conducting these surgeries, we should be monitoring how good our hemostasis was. The ISTH does define that, and hemostasis is considered good if the blood loss is 10 to 25% of the expected level, and fair and poor is when it's more than 25 to 50% respectively. So what all do we have in our armamentarium for surgeries? We are having a lot of options. Then this is with respect to their inhibitor status, as well as their whether they are hemophilia A and B, and the previous speakers have alluded to that. Antifibrinolytic agents, topical fibrin glue, and transfusion supports are adjuvant drugs. And one thing to remember is that the WFH clearly says that APCC and FIBA should not be used for patients with congenital hemophilia B and inhibitors due to to the risk of accumulation of other clotting factors which can lead to higher thrombotic complications. With emicizumab, again, it is the recombinant factor 7 which should be used, and TXA can be used, but with a closed monitoring of the DIC and TMAs. So if we have to plan, the first question which we need to answer is how much standard half-life factor do we need to arrange if we are planning a major surgery. So there have been studies on that, and the median recombinant factor 8 consumed in the major surgery domain, if it is an orthopedic thing, the usual amount is around 424 IUs per kg. For non-orthopedic, it is around 270, and overall, so around 400 IU per kg of in the next 2 weeks of the major surgery is the amount you should be ready with prior to contemplating a major surgery. So now coming to the specifics of the hemostatic various factors which are available. So the first and the most commonly used one is the standard half-life factor concentrate for surgery, and these have to be used in patients without inhibitors. So these are the tables. The pre-op peak level, the goal should be around 50 to 80%, and the post-op peak factor level should be around 30 to 80% for 1 to 5 days. These are again the charts which are available, and we encourage that these protocols and charts should be actually pasted in the patient's surgical files, so that it's easier for all the nursing as well as other healthcare personnel to administer and calculate the doses. So the other question which is often discussed is whether we should be using a continuous infusion or a bolus infusion regimen. So there have been studies which looked at this, and they said that the continuous infusion regime actually allows to achieve a 30% reduction in the CFC, clotting factor concentrate requirements. However, the logistic issues with the continuous infusion regime is the stability of the product, the expensive infusion pumps and disposables which are required, and you would actually need more frequent monitoring of factor assays. So for these reasons, most centers use the low-dose intermittent bolus replacement therapy because it is easier and cheaper than the continuous infusion, particularly in the resource-constrained settings. So this is the kind of the summary table of the major surgery trials, and actually most of them have used the bolus regimen rather than the continuous infusion regimes. So next comes what do we need to take in mind if we are using the extended half-life products for surgery in patients with hemophilia. So I'll go with the EHL factor 9, which is N9GP data in surgery. This was with the Paradigm 3 study where these patients who were on 40 IU per kg twice weekly prophylaxis for 2 to 8 days apart were administered 80 IU per kg of a bolus dose. This was up to 4 hours before the surgery, and the post-operative period was for next 6 to 21 days, and most of the patients actually required 2 to 3 doses only. So, the recommended dose pattern would be for a minor surgery, just a single 40 IU per kg of EHL factor 9 and 9GP would suffice. For a major surgery, one bolus dose of 80 IU per kg pre-operative, and maybe 2 repeated doses 1 to 3 days apart, 1 to 3 within the first week of surgery. So with 2 or 3 injections, you are actually done with a major surgery in patients with hemophilia with this drug. So the surgical prophylaxis is actually efficacious, almost 100% with 76% surgical hemostasis achieved and 0 failures which were reported. The factor 9 activity level was above the required threshold throughout the first 48 hours. So the conclusions are actually what I just said, that there is a 100% success rate. A single preoperative dose of 80 IU per kg is sufficient for most of the cases, and there were no thromboembolic events which were noticed. Coming to the factor 8 product, which actually is extended half-life, but still the half-life is not as long. The study which supports its use is actually the Pathfinder 3 study, where they took the patients of the Pathfinder 2 who were actually supposed to undergo the surgery. So on day 2, on day 0, they would need a factor. Then post-surgeries, every 3rd to 4th day, they would need a factor support. And there was a data of around 49 patients which was available, and again, it was proven to be efficacious. So the dosing recommendation is that for more than 12 years of age, you actually need around 50 IU per kg pre-operative dose, and for major surgery the dose is the same. For kids it is slightly higher, and additional doses can be administered. So if you are using a SHL product, it's after 12 hours, but because it is an EHL extended half-life product, the additional doses would be after 24 hours if necessary. And for major surgery, for the first 1 week you would actually do an OD dose, and then maybe you can go to the lower doses. And this was the hemostatic response. Again, it was efficacious. In the interest of time, I'll skip. So again, this is showing that the number of total infusions, if you are using an EHL product, reduced to only 3, and the total dosage also reduced to around 160 IU per kg as compared to 790 to 750 IUs if you were using the standard half-life products. So the EHL factors do play a vital role in enhancing the conduct of surgery in patients with hemophilia. They reduce the number of injections, and they have an improved trough levels. So the next thing is the use of bypassing agents. So both the bypassing agents, the recombinant factor 7 and APCC have been used, and there have been data of many publications with around 300 to 400 patients suggesting a 75 to 100% surgical hemostasis efficacy. And the only thing which we need to be remembered is that a bypassing agent should be initiated even if there is a lack of, we need to use these agents if, if the patient is already a known case of inhibitor, or if the patient is not a known case of inhibitor, but there is a lack of clinical efficacy, and the plasma recovery factor 8 is inadequate. So sometimes what happens is these patients would not respond to some patients. So there would be around 10 to 20% of the patients where you would need to switch from a FIBA to a Novo 7 or from a Novo 7 to a FIBA, and that has to be taken post-op. This cannot be determined previously, but if the surgical hemostasis is not being achieved, if you switch to the another product, they do achieve their hemostasis. So that is one option. So these are the regimens which are there. The doses are actually, if you come to the costs of it, they are actually very high. The first 48 hours, it's too early for recombinant Novo 7, and and they need to be maintained every 4 hourly for next 14 days. Similar dosing regimens, the for the FIBA as well, for the major and minor surgeries, around 8 to 12 hourly. So the incidence rates of thrombotic events are actually higher with Novo 7 rather than FIBA. So this is the proposed algorithm which we can use if the patients are with inhibitors. Regarding emicizumab prophylaxis in surgery in patients who are already on emicizumab prophylaxis, the one takeaway which is there is that if you are doing a minor surgery, most of the times you generally do not require a bypassing agent support or a factor 8 support. But if you are doing a major surgery, you should not be relying on the emicizumab, and you would need the standard bypassing agents to support the surgery period. Though the bleed rates are less and the amount of bypassing agent support required is way lesser, but still you cannot rely on emicizumab. So these are the guidelines which tell about the guidance, and we can look into that. Regarding the nuances, so the surgeon also need to be aware of what are the basic things. If you are doing a knee replacement, you would need extensive soft tissue releases, you would need increased resection of distal femurs, there would be more extensive surgery, and very frequently they require bone grafts. So post-operative care is equally important. You would need early mobilization and physiotherapy. You generally resort to mechanical DVT prophylaxis, and adequate post-op analgesia should be using morphine and opioids rather than NSAIDs, and the drains and dressings and sutures should be removed at the time of peak factor level, which is within 1 hour of bolus injection. The inhibitors need to be monitored post-op as well. All these patients who have undergone a surgery need to be rescreened for inhibitors 4 to 12 weeks post-op for the development of inhibitors. There is a long rehabilitation course which needs to be ensured. So this is our data of past 2 years, around 15, sorry for the busy slide, around, so the red ones are actually with inhibitors, and the timing required, around the duration of days where these need to be hospitalized were around 42 days, 25 days, and 21 days in patients with inhibitors. Without inhibitors, the things are easier. So this is an illustrative case. This patient underwent ORIF outside the hospital and had developed a big pseudotumor, and this is the femur which is almost disappeared, and this is the case before surgery when the patient first came to us. So what we decided was to do an angioembolization. So this is the pre-embolization angiogram, and this is the post-op post-angioembolization angiogram. Our team decided that we would do an angioembolization first so that the blood loss is less, and then allograft bone, an artificial femur allograft was actually inserted, and there is significant, the patient who was having a very excruciating pain and a huge pseudotumor of the thigh did report a significant improvement in quality of life and pain scores. This is another child who had come unconscious with a large SDH and was discharged successfully day 5 post-op. This is again a completely destroyed knee joint with high titer inhibitors. We decided to do arthrodesis, and the patient is now ambulatory. So the conclusions are that the surgery in patients with hemophilia is actually feasible with and without inhibitors. It is actually a multidisciplinary effort and requires adequate planning and infrastructure. We have various options available for hemostatic therapy, and the choice of therapy would actually need to be individualized. The hemostatic therapy needs to be individualized as in what is there in your inventory. Thank you.
Thank you, Dr. Jain, for doing a very good job. And before I open it to the House for question and comments, I would like to say that two just comments. Is on the top of the case paper, you must write that no NSAID and no intramuscular injection. That should be written. Other thing you have said, if you are using desmopressin for a moderate hemophilia, actually before you use that, you should do a desmopressin test. And you should write that yes, we have used desmopressin. On using desmopressin, his factor level increased from 15% to 45%. That is one. And usually when you use desmopressin, desmopressin activates also the fibrinolytic system very actively. So basically it has to be coupled with some sort of antifibrinolytic agent. So now I open the Dr. Jain's discussion to your discussion and comments.
Very nice presentation, Jain. You did refer to the intricacies of surgery in these patients, particularly the lower limb surgeries. And we know that patients who undergo lower limb arthroplasty, in otherwise normal people, they have a very high incidence of DVT in spite of receiving heparin. Now, how do you balance that versus the risk of bleeding in these cases? You did make a passing reference to that, but I would like to hear what are the considerations that you look into or take into?
So one thing is that at least if I go to the guidelines part of it, the WFH is kind of maybe considered, and they don't talk about the post-op prophylaxis, whether it has to be mechanical, which means a pneumatic compression device and early mobilization, versus enoxaparin. So what we do is we individualize. The two things which we take into consideration is what are the comorbidities. If the patient is obese, he's unlikely to, if the other joint is also actually immobilized and he's obese, and the risk of post-op VT, we have the scores available for that, those are high. And the second thing is, if we have the adequate factor 8 support available with us, we give a lower dose of anticoagulant prophylaxis, 0.4 milligram per kg of enoxaparin once daily. But if we are in short supply, or the patient is getting ambulatory early and the surgical hemostasis is already achieved, and the other thing is that the patient has started moving and there are no major risk factors, we omit the LMWH prophylaxis. So we individualize basically, that's if...
Actually, I think Dr. Dasgupta's question arises because they did a study in Hinduja Hospital, not in hemophilia patients, in non-hemophilics. About 20% of them, before knee replacement and hip replacement, already had a venous thrombus pre-operatively. So one of the question was whether for he is having hemophilia. It was in a private hospital. Then he bled for 59 days and developed a post-operative inhibitor. Many of our hemophilia patients develops inhibitor for the first time on 7th, 6th, 7th post-operative day. So he developed, and then he came to me. It was a prosthetic valve. It was not a biological valve. Oh. This patient is still on oral anticoagulant therapy. I have started the oral anticoagulant therapy, but I have kept in this hemophilia patient the prothrombin time about INR at about 1.5 to 2. And I usually measure his D-dimer regularly, and once in 3 months an ultrasound for an atrial echo, that whether there is a thrombus which is generating. He is doing for last 10 years very fine. I have got a lot of letters from Western countries that how did you anticoagulate with standard oral anticoagulant in a prosthetic valve patient. So anticoagulation may be needed, but question is very simple. Once you convert a hemophilia patient with factor 8 concentrate adequately, so when there is anticoagulation needed, you can give the anticoagulation.
Yes, yes, thank you.
It's a great talk. One thing I wanted to ask, like sir pointed out that the incidence of inhibitors after surgery, after stress is more because of many reasons.
In our country.
Does it matter if you're giving extended half-life versus a regular concentrate?
You won't be able to tell.
So no, there have been, so the risk of inhibitor development actually is more to do with the type of mutation rather than the type of product which you are using. One thing is sometimes even still at adolescence or later age of life, the patients are coming who have previously not been exposed to plasma or factor therapy, and if the exposure days are less than 50, then and you are actually exposing them to the factor support first time during the surgery, then you have to, that 4 to 12 weeks which the manual says post-op, you have to recheck for inhibitors. That would actually become safe once you will have to do is after whenever your 20 exposures have reached. But for precisely for your question, the type of whether it is EHL or the SHL, the risk of inhibitor development does not vary.
And so you said that your patient had inhibitors and you anticoagulated. So did
inhibitor, very low inhibitor.
Okay,
and
so
it
you were able to
vanished.
provide factor support and anticoagulation both. And so one more thing. So emicizumab, you said that you still need to give concentrates, right?
If you are doing a major surgery.
If you're doing, that's
Yes.
because you don't want to take a chance.
Not concentrates, the
because-
bypassing agent. So inhibitor patient,
No, not inhibitor. In a patient who's on emicizumab,
yeah.
do you still need to give replacement for a major surgery? Is it because we are worried, or is it because there's
No. It is only
inadequate?
No. See, it is because emicizumab does not increase the factor VIII level to that level, active coagulation to that level.
Okay.
He has already said, previous speaker has already said that emicizumab converts a severe hemophilia into a moderate hemophilia. So a moderate hemophilia, when you are doing surgery, you still have to give factor concentrate. So whenever acute bleed, major surgery you are doing in emicizumab patient, you have to give a factor support.
So, thank you, sir. Thank you for your patient listening.
Thank you very much. And applause kar do.
I thank all the speakers for this session. They kept time and we have reduced the delay time by almost 20 minutes. Thank you very much.
Thank you, and we close.
I thank the chairpersons and speakers for the session. I also thank the sponsors, Novo Nordisk, Roche, and Takeda. We're happy to announce that some of the selected abstract presenters will be gifted a free copy of our PGI textbook. Kindly check your eligibility at the registration desk. All faculty members who have not collected their kits are requested to collect them from the registration desk. The certificates of the delegates are also available at the registration desk. Now I invite Dr. Radhika Srinivasan, HOD of Cytology and Gynecological Pathology, PGI. Her areas of academic interest are oncopathology, molecular oncology, cytopathology, and gyne-oncopathology. I also invite Dr. Vikram Narang. His areas of academic interest are leukemias and lymphomas. I invite Dr. Uma Handa, HOD, GMCH. Her areas of interest are aspiration cytology and oncopathology. We have 3 talks in the lymphoma update session. The last talk is sponsored by Immunil.
Thank you very much. Thank you very much, and thanks for the opportunity to chair this session. And without further delay, we have 3 speakers in this session, which is an update on lymphoma. Essentially, I think it's focusing on the T cells. And the first talk will be delivered by Dr. Sambit Mohanty. May I invite Dr. Sambit? He is very well known in the uropathology circles, and I learned today that he also does lymphoma and is an excellent speaker. He is currently the director of surgical pathology and research at the core laboratories. So he's our own alumnus, PGI Chandigarh Path alumnus, and of course moved on to the US Beth Israel Deaconess Center, and has done a lot of fellowships and has contributed to the WHO 5th edition of GU tumors and several publications and memberships, and on the editorial and review boards. Brilliant guy. Over to you, Sambit.
Thank you, ma'am. Thank you so much. And it's great to be in the same dais where I left like 20 years ago. And thank you, Dr. Reena, and the entire organizing committee for inviting me over. I do a little bit of lymphoma. I would say 80% of my job is GU tumors, but I love the lymphomas, so I do it. I am zero in liquid hematology, so I do not. So that's a disclaimer. I just want to present. So what we are going to do in the next 20 minutes, I will show a few cases. Those are basically, where is this thing? Yeah. Those are the cases which came to us from outside hospital with different diagnoses. So with those cases, I'll walk you through the T-cell lymphoma. I thought like 20 minutes, I probably won't do justice to the entire blue book if I talk only about the entities. And it is, I will try to make it a little clinically palatable for the audience because it's a mixed audience, but it's more pathology directed. So we have now almost 27 entities among the lymphomas and particularly the T cells. And it is, unlike the B cell lymphoma, is heterogeneous clinically as well as morphologically. And sometimes, like, even after doing a lot of stains, if you are not aware of the clinical history, the lab finding, the drug history, you are in a soup. And particularly when we are resident, we used to get big tissues. Now the tissue size is becoming small, and we're expected to give a very specific diagnosis. And for the youngsters, morphology is still the gold standard. Do not run towards the molecular all the time, so I have the slides towards the end. So what I'm going to do, I'll talk on the practical recommendations, what to do, the shortcomings, pitfalls, and when to use molecular. So the first case I'm starting is a case which came to me about a year ago. It's a 52 years woman with a history of Sjogren, treated with steroid and acute onset chest pain. There was a large anterior mediastinal mass with several lymph nodes. And no organomegaly, HIV serology was only done prior to the surgery in the local hospital, which was negative, and the mass was kind of extending all over the place, involving the pericardium. And the frozen section done in the hospital there had a diagnosis of thymoma, and a surgery was done. I did not have the picture because I got the consult cases, and my practice is fairly a consult-based practice. We do get a lot of in-house cases, but mine is more consult-based. And it was a heterogeneous mass with a lot of variegation, small lymph nodes. And there was no mention about the lymph node histology there, but I did get all the slides and the blocks for review. So what happened, why they sent the thing to us? Initially it was a thymoma diagnosis, but the patient was symptomatic after a few months. And the biopsy from the multiple lymph nodes that time, and they are petabyte lymph nodes, were showing the features of something else. So I'll start with, this is the slide from outside what I see. There's a lot of collagen kind of making a capsule, and the entire thymic parenchyma is replaced by these lymphoid nodules. And what you see, I'm actually not showing the process. It is a periphery with a lot of nodules, and if you get into the center, there are a lot of holes with these clear cells and some lymphoid cells, and here also the next one is better. So what we have these histiocyte-like cells, small cells with hypochromatic nucleus and clear cytoplasm, and there are very few cells which have nucleoli. And this is at a high magnification. You see these mononucleate cells which are nucleolated, a lot of cytoplasm, and the majority of the cell are the histiocytes and these small cells. Probably like 5% of the cells are the bigger cells. So the differential as definitely, we have a diagnosis of thymoma, so I threw a few keratins, considering it a thymic neoplasm, or I did try to look for emperipolysis, could be a Rosai-Dorfman, but the clinical history was bad, and the SUV max was high. Then also I thought of a Hodgkin for the site, primary mediastinal B, the lymphomas. Keratin was negative, only the residual thymic tissue was there. The peripheral nodules are composed of mainly B cells, the smaller cells, but the larger cells which we got, which are about 8-9%, they are all B cells. They're 20 positive, strong PAX5 and 79A, and negative for EBV, ALK, and MUM1. So this is the T cells, which are basically the bystander cells are all T. CD68 and 163 will also stay in the histiocytes, and these are the culprit cells, and in the MIB, these cells only lighted up. These are the B cells. And this is, if you see the PAX5 for the trainees, the PAX5 staining is bright. It is not barely perceptible or weak, like a Hodgkin, what you expect. The cells are EBV negative. They are positive for leukocyte common antigen. And Ibarish was also done. That was also negative. And this is a CD30, dead negative. So, any thought from the residents or the fellows?
I think audience participation at this point would be very
It would be nice. Because the cases, I kind of kept it in that way, so if people can participate.
Yeah, especially the fellows.
The fellows, the HIMPATH fellows.
Yeah.
So it not necessarily it is a T-cell lymphoma. I'm talking on a T-cell, but it may not be a T-cell lymphoma. Yeah, it is, the scattered B cells, they are less than 10%, and there is no loss of T antigen. We did like 2, 5, 3, 4, 8, and 7, and 56 and TI per 4 in granagem, they're all present. And I love BCL2, the way I was trained in the US. If nothing helps, BCL2 helps, because if there is loss of BCL2, that is also a sign of clonal, this is basically IHC surrogate for a clonal loss. And 45 was positive, 30 was heterogeneous. It was weak and heterogeneous, not in many cells, and the cells express BCL6 and 10. So the bone marrow was involved in this, and these are the big cells in the bone marrow, which are again 20 positive, and they showed a immunoglobulin heavy chain rearrangement. TCR was polyclonal, and there was no loss of T-cell antigen. So we sent it out, as you said, a T-cell rich, histiocyte rich, large B-cell lymphoma of the lymph nodes, because it was primarily in the lymph node. It was not thymic, because when we so that is a take-home message. Whenever you're getting anything for the youngsters from an outside hospital, do talk to the primary pathologist, because you get a lot of information from the primary pathologist and the primary clinician. Get all the material instead of having 1 or 2 slides. Then you may make up anything erroneous. So the second one is a 47-year male with a left cervical lymphadenopathy, no B symptoms, and the lymph node biopsy was reported outside as a lymphocyte-rich classical Hodgkin. PET showed multiple lymph node, no lesion in the liver and the spleen, and the bone marrow is involved. I did not get a chance to see the bone marrow because we didn't receive it. And this is what we have. This is the periphery. And what you see here, there's a little bit of mottling. There's some white areas and some blue areas with a lot of cells in the unit surface area, and no vasculature. Basically, it looks vaguely nodular, if I say, and there is not much of internodal fibrosis. There is perinodal fibrosis, and if you see, there are some big cells here, and these are the big cells, and they are kind of surrounded by this small mature lymphocyte, and the background is basically mostly small mature lymphocyte, no proliferation of the high endothelial venules that I want to emphasize on, and we have this sort of nodules. And these nodules are all throughout, so it's difficult to discern is the medulla and the cortex and the paracortices. These cells had a Golgi type or a perinuclear dot-like CD30 positivity, which is all over. 20 was negative. They're negative for B markers, and they are 45 positive. The LCA was positive, some negative, but majority of the cells were CD45 positive. PAX5 has heterogeneous pattern, but the lowest kind of weak positivity we received this, mostly they are good. And PDL1 when done, they are not actually positive in the large cell. PDL1 mostly highlighted the background cells, which are T cells, not the larger cells. Similarly, EBV stained the background T cells, not the large cells. PD1 stains them. PD1 is a helper T cell marker which stained the large cells are negative, basically. So any thought at this? So we have some large cells. We have a nodular thing. It was diagnosed outside as a classical Hodgkin lymphoma, lymphocyte rich. But big cells are 45 positive. PAX5 is more or less strong. The milieu is rich in T cells, EBV negative, and they are negative for 30, they are 20 positive. So let's see something else. So more IHC will follow after I show you the flow cytometry report. So what we had a CD4 positive T cell predominance with a 4:8 ratio of 4.9, and there's an aberrant about 37% of CD3 and 4 positive T cell population in the lymph node flow. And there are two minor components of double positive and 10+4 positive. So these cells do have a follicular helper cell type immunophenotype. And they are not very low, they are a little bit more. And on the B cell tubes, there is no monotypic B cell proliferation. So, and this is the plot to show the gene expression profiling. Not the gene expression profiling, the T cell gene and immunoglobulin heavy chain gene rearrangement. There is no rearrangement here, but there is rearrangement involving the T cell receptor gene, and there is a RHOA mutation. So I'm reviewing the nodules. Then we look back to the nodules again, which are so I thought the lymphoid cells, the cells in the background are basically bystander. They are just a sign of activation, and it is because the tumor cells, they want to home in, they want a lot of support from other cells so that they can escape the immune machinery. Actually, I was wrong. Those are the tumor cells, and there is a focal HEV prominence. And what we had, these cells, they had a loss of 8 and 7 with partial loss of 5, and BCL2 was partially lost. So they had a helper T cell phenotype. So the final diagnosis offered in this is a follicular T helper lymphoma that mimicked LR-CHL, which is the LR-CHL thing is again expanding post the last WHO, and they're adding up a lot of FTH phenotypes. The third one is a straightforward case.
Sorry, if I could just interrupt you, Sambit.
Yeah.
I mean, if you had not done flow cytometry on that case, number one, what would you have ended up calling?
Yeah, I would have ended up calling something as a gray zone because all my markers were not helping, and I did not bother to put all the T cell marker actually to the first go.
Which may be difficult to even to interpret on a histopath specimen. I think I would say the very important take-home message from that case is the importance of using flow cytometry,
right,
especially in T cell lymphomas, where you can have a very large repertoire of T antigens, and also the ability to dissect out what is the neoplastic T cells versus the reactive non-neoplastic T cells. And the aberrancy in the neoplastic T cells can be easily defined, more easily defined on a flow cytometric plot than you can on a histopath section.
Yeah.
So
exactly.
that is really the importance of this, and it has mirrored our own experience in this
Exactly,
lymphoma.
yeah, because if you have a core biopsy and thinking of a T cell process, the flow is a better bet than IHC. Because unless you do all the markers, you'll end up missing it out. Then the third one is a subacute intestinal obstruction. Jejunum was resected, lymph nodes are reactive. So what we have here, there are two entities we are talking nowadays. So what you see here, it is a bulbous jejunal fold, which is, but if I go to the next one, the stroma is kind of expanded with some lymphoepithelial lesion, but there is nothing, they're not doing anything to the crypt epithelium. There is no intraepithelial lymphocytosis. If I go to, and the cells are fairly monomorphic and occasional big cells. So if I see here, this is a CD3, there is only a little bit of CD3 positive cells. Majority is expanding the lamina propria with these cells. So there's some relevance to that. I'll come to that in a minute. These tumor cells, so loss of 4 and BCL2, there's 8 positive strongly, perforin and TIA. So what is the diagnosis? There is no celiac lag changes, no intraepithelial lymphocytosis, no venous blunting, and there's a CD8 positive cytotoxic disease with a loss of 4. Yeah, is a metal. So it's a monomorph, and the cells are monomorphic. So it's a monomorphic epitheliotropic intestinal T cell lymphoma. So I'll just quickly get into the table because we're running out of time. So what is ETL and METL? ETL is a polymorphic disease in a background of celiac, and it can show a double negative disease, and they have a cytotoxic phenotype. Middle is a monomorphic disease, no features of celiac, and is a cytotoxic disease. Then the last one, is a 19-year-old female with a 2-week history of generalized malady, rash, fever, night sweat, and upper quadrant pain. There are rashes. It's a very straightforward case for a first-year resident with malar rash and bilateral cervical lymphadenopathy. TLC is high with 5% atypical cells. These are some of the cells. I'll just show you the cells, then I'll ask at the end, what do you think about it? Peripheral blood flow, so mature T cell phenotype, there's loss of multiple antigen, and this population has a 4 and 26K co-expressing T cells, which are 7 negative. So what is your thing for a first-year resident, probably in the first or second 6 month? Now they're using the word semester. When I went to the department, they said, we are in the second semester. So what is your thought process maybe in this? Okay. The skin biopsy was normal. I forgot to say, the skin biopsy was normal, and this is all from the peripheral blood. Okay, let's see what we are dealing with. And the cells are atypical, they have irregular nuclear envelope, cleaving leptin. And this is the bone marrow cells. And so the bone marrow IHC, these are mostly the T cells, and they're positive for CD30. And in the fish, they saw allogen rearrangement in about 37.8%. It was a break-apart probe, so we take typically more than 10% as positive. And in the lymph node biopsy, the tumor has, this is the paracortex and the interfollicular area, which has this with lighter zone, and the sinusoids, which are filled up with these big cells, and they're ALK positive and 30 positive. So it's the ALK positive anaplastic large T. Then this is a pitfall. I made a bad mistake in this, but finally the telephone stain helped me after talking to the clinician. Is an 18-year-old male with multiple lymph nodes, mild B symptoms. LDH was high, fairly high, and CRP was high, and some history is there. I'm going to reveal that history later on. So in this, what happened if you see this picture, everything is 3. And there is no corticomedullary distinction. The paracortices are expanded, they are white. There's a lot of high endothelial venules here, clear cells, mitosis where they are, KI was like Christmas tree, and these cells are 30 positive, S100 was showing some dendritic positivity, and the 5 positive, but if you 3, so there's a lot of 3 and with a loss of 5. So I thought I'm dealing with a T cell lymphoma. This is what happens when you have very little knowledge about the clinical picture and the onset and the type and the progression of the disease. So my search path fellow actually helped me, and she said, sir, just wait for a day, let me get the history. I was a little adamant. I said, no, it's fine, we'll just take it out, because there are multiple T cell antigen loss. These cells, they saw like a 4 to 8 equal, which was kind of bothering me. Why 4 is equal to 8? If 4 is equal to 8, typically it is not a lymphoma. We see either 8 more or 4 more. 4 is normally more, so we don't care unless 8 is completely lost, but they're kind of equal. And there is, BCL2 is dead negative. I thought about Dr. Harris, who taught me lymphoma, like BCL2 negative, stay away from saying something benign. And the proliferation index is very high in the T zone. Immature markers were negative. And when I did this follicular dendritic mesh work, I had a very rudimentary mesh work, so that means the lymph node architecture is effaced morphologically and by IHC. So the tumor or reactive, or I need more history. There's a history, long-standing history of anticonvulsant in this patient. And so I kind of reported giving a possibility of a dilantin-induced paracortical expansion, but because of all these odd features in the comment, I asked for a T-cell gene. I basically, whenever I do not know what is happening, I give a 2-paragraph comment in the report saying the T-cell gene rearrangement doesn't reveal any clonal proliferation, and FCM was negative. So basically, it is a reactive T-cell proliferation that may mimic lymphoma, including the drug-induced, vaccination, dermatopathic lymphadenitis. In a core biopsy, people do miss out dermatopathic lymphadenitis if they do not get attention to the melanin in the thing. I mean, we are lucky, few handful of people who are trained by great experts in PGI, but if you consider about the entire nation, people do make this mistake. Unless you think about the differentials, you miss it out. So the morphology clues for the youngsters, when you see there is lack of architectural effacement, there is some residual thing. The sinuses are patent. In T-cell process, usually they attack the sinuses first. If the sinuses are patent, probably you are dealing with a reactive process, or the chances of reactive is more. FDC is not. T-cell tumors, they secondarily stimulate a follicular dendritic cell proliferation. And similarly, if you see this polymorphous infiltrate, ask about skin rash, autoimmune diseases, high rate, LDH would be high. Anyway, when there is a reactive process going on, all these CRP, LDH, ESR, they all could be high. And secondly, there are few features. When you see the complete architecture is obliterated, there is marked diminution of B cell follicle, presence of atypical cell, but if your 4 and 8 are equal, you stay away and kind of ask questions. So this is another case. From this picture, Pulkit, what do you think? What is your thought on this? I have the entire thing. I did not give you any history. Just Dr. everything together. Is a nodular lymphoma or a nodular process, I would say. These nodules are all throughout. But if you see the three, I mean, this is a 20. 20 is outside. The center is all 3. PD1 is actually not making a RIT kind of thing. Bob and Oct are negative. These cells are 45 positive. They're 30 negative. EBV was negative. But these are helper T cell type nodules. And do you want any other stain? BCL2 obviously is going to be positive because T cells are positive, so it's difficult to say it is a B lymphoma follicular or a T lymphoma follicular. So I reported this case as a nodular lymphoma with T helper cell phenotype. I could not get to the point whether it is a lymphoma or neoplasm or not, though clinically all the features of neoplasm were there. And KI was low in this area. So, any other thought? Any other stain you do? Before signing out the case, I did a LMO2, and LMO2 highlighted these areas along with BCL2 and BCL6. So I thought it is a follicular lymphoma with marked expansion of the T helper cell. What happens in follicular lymphoma? Because the lymphoma cells, they are arising from the follicles, the lymphoid follicles, and normally we have CD4 positive T cells there. They incite a reactive response to the follicular cell, helper cells, and you see. So I'll just skip these slides and directly go to when to use what.
Dr. Sambit, you have to be a little...
Yeah, I'm rushing the last 2-3 slides. So when do you need molecular testing? When there is minimal involvement, like something like AITL, where 20% is tumor, 80% is non-tumor. When there is morphologic and immunophenotypic discordance, and when the history is highly suggestive, but morphology is not supporting, or there is a discordance. So this, the nodal T-cell lymphomas, they highly rely on morphology, and we have to do an immunophenotype and molecular data, but the pathology data should be integrated in the light of clinical finding, the age, the ethnicity, past history, site of involvement, multiple nodes on single node, hepatosplenomegaly, and associated symptoms before you give a final assessment. And you need to know about the mutational landscape, but still we are at a very, very infancy stage to use it in somewhere like in India, also in the US, they're not using routinely to give a diagnosis, ignoring the histology and flow. Flow, as ma'am said, is a very good thing for T-cell lymphoma, and these things can be used as adjunct. So I thank all my mentors, friends, and juniors and students, and my technical staffs, and finally all the patients and the students and the clinician from whom I learn the maximum, and they drive my energy and passion for pathology and medicine as a whole. Thank you very much for your time.
Thank you, Samvit. That was indeed a wonderful collection of cases. I mean, I would sum up by saying that every case of a T-cell, the mature T-cell lymphoma, is actually a challenge to diagnose. You have shown at least the few ones which mimic the reactive process, which mimic B-cell lymphoma, and which don't look like a T-cell lymphomas. So with these comments, as we are running short of time, if there are any one or two very quick comments, we can allow for that. Yeah, Pulkit.
So drug-induced lymphadenopathy was indeed the challenging case, and we have faced such challenges in our practice also. And another thing is that sometimes there can be a sitting NKT cell lymphoma. So if you miss to do CD56, you can land up in giving just a PTCL NOS.
Exactly.
NKT cell lymphoma. We have seen lymph node involvement in NKT cell lymphoma. It has a different therapy. So that is another pitfall of a T cell lymphoma.
Yeah, you have to take T and NK as the two sisters and use the 56 together. Otherwise, you'll end up calling everything as a PTCL NOS. Very good point. Thank you.
Yeah. Yes, Dr. Gaurav.
So from pathologist to clinician, basic question. In ALCL, the traditional understanding is ALK positive, negative, and null cell. Are we able to solve this mystery of null cell lymphoma?
Null is a difficult player. Null is a difficult player, though it is rare, we do face. So for that, we have to basically do all the markers. And if you have a facility for flow, it does help, and fish, because genetic aberration is there. And that is, null cell is an area where I would recommend doing NGS. We do that, but not for the ALK negative or the positive ones.
Thank you. I think, thank you so much, Samvit.
Thank you, ma'am. Thank you.
Yeah. We move on to the next talk, and over to you. Thank you.
The next speaker is Dr. Manju Sengar. She is from Tata Memorial Center, Mumbai, and she is an expert in treating colon cancer, breast cancer, and blood-related cancers. Over to Dr. Manju.
Thank you so much. And I can hear Hari laughing out loud because he knows the last breast cancer and colorectal cancer which I saw was near 2003, if I'm right. So yeah, I don't treat colorectal and breast cancer. And what I'm going to talk on is management of T-cell lymphomas. And clinicians share the sentiments with pathologists. It's a very difficult disease, not only to diagnose, but to treat. And we, really take a deep breath when we get to see a diagnosis which says that it's T-cell lymphoma before planning the management. So as Dr. Samvit already showed that it's a complex disease with a lot of challenges. There are almost close to 30 odd entities. And if you look at two things summarize T-cell lymphoma, it's rare. So if you put together all these 30 entities, they constitute roughly around 15% of all NHLs. And they have a variety of presentation. As we saw, they could be nodal, extranodal, leukemic, or a combination of all this. And they have a very poor outcome. So if you look at the International T-cell Lymphoma Project data, which was basically a registry from 3 different continents, and they summarize saying that if you look at the PTCL, and this includes all peripheral T-cell lymphomas, the 5-year survival, overall survival is in the tune of 35 to 40%. So it's a difficult disease. A lot needs to be done. Some things have happened, more from the basis of understanding the disease better, rather than so much as to therapeutic advances. If you look at the heterogeneity, and this figure, practically sums up the heterogeneity. On the y-axis, this is the survival, and on the x-axis is the median age of presentation. So these lymphomas vary in terms of their outcomes as high as 100% if we talk about the cutaneous anaplastic large cell lymphoma, to the ATLLs where the 1-year survival, so median survival is less than a year. So this is what sums up the heterogeneity with respect to the T-cell lymphoma. It's a very vast disease, and I'm not going to talk about management of all. I'm going to focus mainly on the nodal peripheral T-cell lymphoma and extranodal NK T-cell lymphomas. Few things which I want to highlight for the, for the postgraduate's point of view, that as opposed to B-cell lymphoma, the initial workup may be little different based on what the clinical presentation is, and you may need to incorporate Coombs test, especially if you're looking at AITLs and there is significant amount of anemia. You may need to do HLH parameters if you're dealing with peripheral T-cell lymphoma or NK T-cell lymphoma or a subcutaneous paniculatus like T-cell lymphoma. You would need a PET-CT except for the cutaneous T-cell lymphoma, and for some of these lymphomas, especially the NK T-cell lymphomas, it becomes quite important to do a PET-CT because you can pick up an occult nasal primary for an otherwise disease which is looking like non-nasal, more of systemic presentation. Some of the parameters which have come up lately, like EBV DNA levels, and this is important when you're handling the NK T-cell lymphoma for the prognostication as well as for the follow-up. Bone marrow aspiration biopsy, one important point here is that if you're dealing with NK T-cell lymphoma, to say that it is and there is no marrow involvement, you should have an Eberish on the bone marrow, because otherwise you may not find a lymphoma cell in the bone marrow and you may call it uninvolved. The challenge of management and the poor outcomes is reflected even in the prognostic scoring. Not that we don't have that in the diffuse large B-cell lymphoma, but this is much more here. So you have IPI, which is used in any other aggressive NHL, the peripheral T-cell lymphoma prognostic index, PIT, modified PIT, and international T-cell index, T-cell score. Taking different parameters to figure out, can we classify patients into different groups based on their outcomes. But here again, the therapy remains the key. The kind of therapy which you're going to use is going to define the prognosis. And more, if you look at it, none of these newer prognostic indices have made any difference. People still continue to use IPI, and in some of these situations, the PIT index. If you look at the treatment, so what I'm going to talk about how, what are the current concerns we have in treatment and whether we can select a particular therapy based on the subtype. So CHOP and then CHOEP and then combination of brentuximab with CHP and hypomethylating agents and HDAC inhibitors. Do we really need anthracyclines? How did we get to anthracycline or CHOP in T-cell lymphoma? Because we know that initial trial data for CHOP comparing 3 intensive regimen did not know whether it's T-cell lymphoma or a B-cell lymphoma. They had all aggressive non-Hodgkin's lymphoma. And from there, the CHOP became standard of care. But if you look at the International T-cell lymphoma project data, anthracyclines do not result in better outcome, more so if you're talking about AITL. So do we really need to use this? So there are a lot of retrospective studies which have been done looking at the use of anthracycline, and this is a systematic review and meta-analysis. What it sums up that if you have anaplastic large cell lymphoma, whether it's ALK positive or ALK negative, anthracycline's gives a good complete response rate and good progression-free survival. But if you have PTCL, AITL, or EATL, the possibility of getting a complete response and durable response is much lesser. So what should we do? Can we change to other regimens? Probably answer is no, because there are a lot of non-anthracycline-based regimens which have been tried and they have failed to show any improvement in responses. So we are stuck with CHOP. What is next? Do we need etoposide? That's another question which comes in. And this is the first genesis of use of etoposide and support for the use of etoposide. This was the German high-grade non-Hodgkin's lymphoma study group data, retrospective analysis. Where did etoposide make difference? Patients who were less than 60 years with normal LDH, and if they have anaplastic large cell lymphoma, ALK positive. For other peripheral T-cell lymphoma, there was a trend towards improvement in PFS. So yes, if you have young ALK positive ALCL and with normal LDH, that does make difference. But there is a suggestion from the Swedish data, this is Swedish Lymphoma Registry, that for all the PTCLs, if they are young, you can use etoposide because it results in improvement of PFS. But there is no difference in overall survival. So answer is that if you have a young patient, you can think in terms of using CHOEP-like therapy, except when we are talking about NK T-cell lymphoma. Why? Because you have high P glycoprotein expression and MDR-mediated resistance, so you don't want to use CHOP or CHOP-like chemotherapy there. So, that's the summary of CHOP and CHOEP. Then came the brentuximab. We heard about brentuximab yesterday evening in Hodgkin's lymphoma. This is a phase 3 trial in peripheral T-cell lymphomas. Criteria was CD30 positive, more than 10% expression, ALCL 70%, both ALK positive and ALK negative, largely ALK negative. Some numbers, roughly around 14% to 12% were PTCL NOS and the AITLs. It did result in improvement in PFS and OS, and the 5-year mature data again confirms that there is improvement in OS. So where should we use brentuximab? If you look at the subgroup analysis, though the numbers were very small for AITL and PTCL, can't make much sense out of it, but the difference, you can see that the lines are crossing the unity. So we don't know whether it really works there or not. So what's the final verdict or approval? FDA says any CD30 positive, though the trial had more than 10%, so any CD30 positive peripheral T-cell lymphoma, whether it's ALCL, PTCL NOS, or AITL, you can use brentuximab with CHP, whereas EMA has restricted its approval mainly to ALCL. So I have, looking at these small numbers, it looks difficult to convince that there is a benefit of brentuximab in the AITL more so, and so much so if the PTCL with low CD30 expression. However, there are other phase 2 studies which have come up, and they have looked at even CD30 expression of more than 1%, and it shows that there is advantage of adding brentuximab. But it is phase 2, no OS data there. So many people out of desperation consider using brentuximab because you know that these are the patients who are not going to respond well first, and even if they respond, they relapse pretty fast. So that's where the brentuximab information is as of now. Can we do better? Because we have started understanding the biology a bit better, and we know that many of these nodal TFH, T follicular helper cell lymphoma, they have TET2, they have DNMT3A, they have ROA mutations, and whether we can use any of these agents and can result in better outcomes. So as you can see that the best agents amongst all this were HDAC inhibitors, the azacitidine, the pralatrexate. And they have been tried in subsequent trial in combination with chemotherapy after the data from the relapsed refractory setting showing a reasonable response rate and little longer duration of response. So that has been tried, and this is a phase 2 study of combining azacitidine with CHOP. We saw in the earlier data that CHOP resulted in CR rates of anywhere between 30 to 56%, depending on what kind of PTCL you are looking at. In this study, again, small numbers, but you can see that if they combine all the PTCLs, not nodal TFH only, then the responses, complete responses were in the tune of 75%. When they just took the nodal TFH, the complete response rates were around 88%. So it looks promising. There is some increase in toxicity. The way you give azacitidine is different here. You use it as a sensitizer in the first cycle for 7 days, and in the second cycle onwards for 14 days, starting from day 7. So looks promising. And if they have done the analysis, those who had TET2 positive, they did much better with oral aza and CHOP combination. Small data. But many times what we get to see in early phase trials doesn't last in the phase 3 trials, and that is what has happened with romidepsin. So romidepsin showed significant responses in both AITLs and PTCL in the relapse setting, but it did not succeed when they tried in the phase 3 trials, and there was more toxicity. But one reason could be that they took unselected population. This was not nodal TFH alone. It was an unselected population, which may be the reason for failure, and therefore we need to have smarter trial designs as we go forward. So once we get the disease under control, we do need to maintain it for long. So what do we need to do? Because we know that they relapse very early, and therefore the role of transplant comes in. So idea is that if you get chemosensitive disease, in the sense that you get complete response or partial response, you want to consolidate so that these patients have a longer progression-free and the longer overall survival. And whether we need to do auto and allo. Largely the data is limited to retrospective studies, the registry data which has come in. The summary is that if you have anaplastic large cell lymphoma ALK positive, majority of these studies have excluded them, and you get into CRPR, you don't really need to think of doing transplant if you have ALK positive ALCL, more so if it is not in high IPI ALCL. If you're looking at ALK negative ALCL, you need to be a little more careful here, because when you have ALK negative ALCL, it's not one disease. you have multiple diseases there. If you have DUS22 rearranged ALK negative ALCL, they do as good as ALK positive ALCL, so you can avoid doing transplant there. If you have TP63 rearranged ALK negative ALCL, they do really poorly, and that's a subset you may need to think in terms of auto, and some people suggest even allotransplant. The others, which are triple negative, should be considered for autologous stem cell transplant based on these retrospective and one prospective study. What should we do when we have brentuximab, given as frontline therapy as induction along with CHP? So this is the data which, as you can see here, is there from the study which was done, the Echelon-1. Those who achieved complete response and had received brentuximab earlier did better in terms of progression-free survival if consolidation with autologous stem cell transplant was done. However, the similar benefit was not seen in the CHOP arm. Small number, let's not read it into too much, but it's important to know that even after brentuximab, transplant makes a difference. This is the only prospective study which looked at patients where the intention to transplant was there at the time of enrollment. And those who were transplanted, they did better both in terms of PFS and OS. So this Nordic data gives the suggestion that there is benefit of autologous stem cell transplant. However, we lack prospective randomized control trial to clearly answer the question. So as of now, people who achieve CR/PR, whether you've given them CHOEP, whether you have given them CHOP, if they are fit, answer is yes, you should think in terms of consolidating with transplant, unless they are ALK positive large cell lymphoma, anaplastic large cell lymphoma. What about allogenic stem cell transplant? This is the only randomized control trial comparing auto and allo, but it was stopped early because they realized that it's going to be a futile exercise to continue because they're not going to see the difference. So allo did not do better than auto. There is one important point here that, though we know that there is graft versus lymphoma effect, which is important in T-cell lymphoma, allogenic stem cell transplant in frontline therapy seems to have not much gain as compared to auto because of its own challenges. However, diseases like hepatosplenic T-cell lymphoma, if you get into CRP, a complete response, it's a good idea to consolidate them with allogenic transplant based on the limited data, given the rarity of disease. In other, if you look at diffuse large B-cell lymphoma, you use radiation. Can we use that same theory and treat the peripheral T-cell lymphoma? So this is again the data which suggests that if you have an early stage disease and if you have given limited courses of chemotherapy, giving radiation helps in improvement of PFS. But if you've given 6 cycles of chemotherapy, probably radiation doesn't have much role there. Again, no prospective studies, so people tend to continue giving radiation more so because of the fear that you are going to have very short-term disease control if you just stop at chemotherapy. If you are talking of limited stage disease, the data is even more suboptimal if you talk about advanced stage peripheral T-cell lymphoma and consolidative RT. We'll move quickly to NKT cell lymphomas. So few important points which I want to highlight as opposed to other T-cell lymphoma or B-cell lymphoma, the staging system. We stage typically with Ann Arbor. There was an attempt that Ann Arbor doesn't give you an information on local invasion, which is an important prognostic factor if you talk about NKT cell lymphoma. And that's where people started suggesting that TNM probably works better. And therefore, you should use TNM in NKT cell lymphoma. However, TNM does not give good information about non-nasal sites. And whether we can apply same TNM to non-nasal site is not clear. And that's where this Chinese Southwest Oncology Group and Asia Lymphoma Study Group, what we call as CA, they proposed an extranodal nasal NKT cell lymphoma staging system. What it differs is basically it talks about the local extent of disease, the invasion, the regional lymph node involvement, the dissemination and presence of non-nasal disease. So this supposedly captures better prognostic information and treatment decision planning. And it has been validated in the elasparaginase-based therapy as we are using now in NKT cell lymphoma. Same challenge here as we saw in PTCL, a lot of prognostic systems. Nothing is better than other, but more and more people use PINC and the NRI, which has been both validated in L-asparaginase setting. The PINC uses non-nasal disease as one of the components, which is an important factor. We know that non-nasal extranodal NK T-cell lymphomas do poorly as compared to the nasal subtype. There is an additional, increment which has come on PINC, which is PINC-E, where they took EBV viral load and added that to give a better delineation between the low risk and the high risk groups. So just a summary of how we treat NKT cell lymphoma. When we talk about NKT cell lymphoma, this is one group where there is high MDR expression, so no CHOP. What we are looking at is L-asparaginase-based therapy because there is in vivo data which says that there is L-asparaginase induces apoptosis in NK cells, and therefore L-asparaginase is an important component. If you have limited stage disease, you can combine smaller number of cycles of chemotherapy, L-asparaginase-based chemotherapy followed by RT. Patients who have really low risk disease, there you can only do radiation. This is early phase 2 data from the Asian, mainly from the China, but we tend to do chemotherapy and radiation. You can combine, meaning give concurrent chemoradiation, or you can give sequential. Most people prefer giving sequential because it's much easier to do that, because imagine you give first radiation and then bring in chemotherapy, all the mucositis, etc. will result in a lot of interruption. So we prefer giving sequential, where chemo is first followed by radiation. We do not practice the sandwich or the first radiation followed by chemotherapy. You have other, regimens like Pgi-Hem-Onc, again Pegi-asparaginase-based, DDGP, which is again, which has been shown to be better than SMILE, but the trial data is a bit questionable. So practically all the L-asparaginase-based regimen, whatever you can deliver, we prefer using SMILE. If you're talking of advanced stage disease, SMILE or any L-asparaginase-based chemotherapy. If you have contraindications to SMILE, then in that case you can use regimens like LVP, or you can use Pgi-Hem-Onc. Role of consolidative RT here is a consolidative autologous stem cell transplant. Many centers practice, however, the data is even more limited here as what we saw with the other peripheral T-cell lymphoma. So we do not suggest transplantation for patients who have advanced stage disease and have achieved CR at the end of the chemotherapy. So to summarize, this is not the only disease where we should have close discussion with pathologists. All lymphomas require close discussion with pathologists, but definitely T-cell lymphoma, many times the diagnosis changes completely. Subtyping does make a difference, and we know that now more and more of that for nodal T follicular helper cell lymphomas. We need to think in terms of targeted therapies based on the biomarkers, and maybe even the trials need to be designed in that manner. Thank you.
Thank you, Dr. Senger, for a very nice presentation and completing it well within time. And you've simplified the management very well. And topic is open for questions or comments from the audience.
Very helpful talk, ma'am. My question is regarding the use of etoposide. I personally feel we use it because that's the easiest escalation we do in this setting. Because there is no randomized data which has shown that either EPOC or CHOIP is better than CHOP. A recent meta-analysis 2 years ago showed there is no benefit. So do you think in our setting we still be using it?
So to answer your question, if you look at the data, I'm quite convinced with regards to ALK-positive anaplastic large cell lymphoma, because that's been clear both in the German as well as in the Swedish registry, and you're right, there is no prospective data to suggest that. So anaplastic large cell lymphoma, ALK-positive, yes. Anaplastic large cell lymphoma, ALK negative, yes. But if you look at the PTCL and AITL, you're right. It's more out of frustration that we consider using CHOAP rather than giving CHOP alone. But if you look at even with brentuximab, when they've combined with CHOAP, meaning minus CVCR, the responses seem to be a little better as compared to brentuximab plus CHP. But again, it's a phase 2, two different studies, difficult to compare. So if you look at, for the newly diagnosed newly diagnosed peripheral T-cell lymphoma who fall in that category of CD30 positive, more than 10% expression, there is no data for maintenance. The data for maintenance has come from brentuximab earlier studies which are used in relapse refractory setting, where they saw that if you use maintenance, they had, there were durable responses, and in fact almost close to 15% of patients were disease-free for 5 years. So that's the data from the relapse setting. But if you talk about upfront, there is, as of now, there is no evidence. Thank you. Oh, sorry.
An excellent talk. So my question as a pathologist, other than your ALK negative ALCLs, you definitely need to tell you, like if you are planning for a transplant, like a TP53 and the rearrangement. Anywhere else, like in PT cell, do you really need like the sequencing data prior to therapy you are planning for?
So as of now, answer is no. But once we are saying, and it's more from the point of view of when we are using these targeted therapies. So though it's a phase 2 data, but we are so frustrated with the outcomes of T-cell lymphoma that we have started using azacitidine with CHOP, at least in the nodal TFH lymphomas. So if you give that data, we are more confident that we are talking about the same nodal TFH. But it's not that if we don't have the data, we are not going to look at.
We are kind of gathering the data, and I mean, I had that question to oncologists, like most of the time. Like what you do with the data, because if it is an ALK negative setting, I do understand you need more genomic players to stratify those entities, but if it is in a regular setting, so is it helping? And everybody's...
Yeah, so you're right, we are not making clinical decision, but yes, if you, as I shown for the oral AZA plus CHOP, if you have TET2 mutations, we know that it's going to do better, but nothing more than that. Yeah, thank you.
Yeah, okay, if no more questions, thank you, Dr. Sanger.
So now we will invite Dr. Anil Kamath. He's a head CDMA Immunotherapeutics, Bangalore, and his areas of interest are cell and gene therapy. We'll be talking about transplant and CRT cells for relapsed leukemias and lymphomas.
Firstly, thank you very much, Chair, for the kind introduction. Thank you, Dr. Pankaj and the organizing committee. It's been a fabulous meeting. Really enjoyed all the sessions. So my remit today is transplant and the CAR T-cell therapy for relapsed leukemia, lymphoma in India, when to and when not to. So we obviously had two excellent discussions on T-cell lymphoma. So for this purpose, we are going to remit our discussion to B-cell malignancies. So let's start off with CAR-T first. So why are we even talking about CAR-Ts? Because obviously we know that there is a huge unmet need. As we can see from the landmark study, the Scholar 1 and the UCAL study for BALL and BNHL, you have patients who really do not respond well. And you have ORR for this relapse refractory setting in the range of around 20%. And when we talk about CAR-Ts, this is not something new. You have seen CAR-Ts being used since 2010. For India, of course, it's a novel therapy. The first CAR-T infusions occurred under UPenn, under Carl June and Bruce Levin's team, going back to 13 years ago. And this is the data that I'm showing you on the right side panel, which is Eliana and Juliet, is data which has stood the test of time. And we know that response is upward of 80% at day 90, and cure rates going up to 40 to 50% of these patients who would not have been alive. So this is a highly disruptive treatment, and it has stood the test of time. So we have seen that there is tripling of overall responses, doubling of survival, not just in ALL and BNHL, we also have data for multiple myeloma. For this talk, I'm going to restrict myself to BALL and BNHL. So what are we talking about in CAR T cells? Now, essentially CAR T is genetically modification of T lymphocytes to express a chimeric antigen for the cancer antigen. So the most common ones that are in use is CD19. And we have two different types, so the CD28 and 41BB. The one which I'm going to talk about in little bit more in detail is Warnin Captation Autoleucel, which is a 41BB, and it is not the FMC63, it's a A3B1, so it's a different type of a binder compared to the 4 CAR T-cell therapies that are approved in the West. So how do CAR-Ts knock out the cancer? Because by binding to the cancer antigen by direct cell killing, as well as creating a hostile microenvironment such as release of cytokines that causes tumor cell apoptosis.
And why CD19? As you are all aware, and this is a very informed audience, we can see that CD19 is uniformly expressed except for the early stem cells and the mature plasma cells. From mature plasma cells, we have got a different antigen, which is the BCMA. Again, I'm not covering that. So CD19 is a very good universal antigen for targeting B-cell malignancies. And this is what I mentioned a few minutes ago regarding the approved treatments in the West. So you got tisagenlecleucel, exicaptogen, lisocaptogen, brexocaptogen. These are all targeting CD19. And you got a couple of BCMA. The one which I would like to point out in little bit more is the ARI-000 from Spain, Hospital Clinic Barcelona, approved locally in Spain for treatment of CD19 B-cell malignancies. This is the ICMR data. As we all know, sadly, the ICMR data is a little bit of underestimate. We know that the unmet need is much more than what has been reported for BLL and BNHL. So, talking about guanine captogen autoleucel, that is the INN name for the CD19 CAR-T, IMN003A. This is the first in India industry study phase 2. And a little bit about Immunil. Now, this is a company essentially set up based in Bangalore, completely focused on cell and gene therapy. The founders, as mentioned, Kiran Mazumdar-Shaw, Siddharth Mukherjee, Kush Parmar, and it has got a stellar advisory board, including the founders of cell therapy, I would say, Carl June, Bruce Levin, Purajit. So this is a glimpse of the facilities in Bangalore, the QC lab, R&D lab, manufacturing hub, and this is where the products are manufactured and then sent across to the different parts of the country. So coming to the phase 1. So guanine captogen autoleucel was studied in Spain in a multi-center study, and the data suggested a response of 71.1%. And what was more important, and I would mention this specifically, is the use of fractionated infusion protocol. So if you recollect, and some of you may be aware of the data for the 4 approved treatments, these are all single infusion, while this one is a fractionated infusion, wherein the investigator or the clinician can spread out the infusion in 3 different doses from day 0 to day +9. And this is found to significantly reduce toxicity, in that sense, the cytokine release syndrome and of course ICANS, which I'll come to that in a moment. But I want to point out 2 figures here. One is the significant toxicity for CRS was less than 5% and ICANS was 0%. Now this is something which is standing out, excellent, and it puts it apart, this particular drug, guanine captogen autoleucel, in a different league in terms of its safety profile compared to the 4 approved treatments in the West. So this study was done at 3 centers, Bangalore, Narayana Rudale, Chennai, and of course PGI, where Dr. Pankaj Malhotra and his team have been playing a sterile role. And we have some data over here, which I'm going to show you from EHA 2023, which was in June. We also have some updated data which we have sent to the regulator and to ASH, which will be released sometime in December. So this is the layout of the IMAGINE study, the guanine captogen autoleucel study. This follows a standard trial design where you have consenting leukapheresis, which we are interested in the T cells, followed by lymphodepletion once the product is ready, followed by infusion. The protocol also allows reinfusion if needed, guided by PI preference, and follow-up till 12 months. Of course, the primary endpoint is day 90, wherein we look at safety. So those are the 7 steps as we describe in treatment: registration screening, apheresis, manufacturing, lymphodepletion, hospitalization, infusion, post-infusion monitoring, followed by follow-up. So what was the main inclusion-exclusion criteria? These were pretty standard, but what really stands out is we allowed patients who were MRD positive, and also we also allowed patients who had after first line of treatment for BNHL. So the age range was above 3 for BLL, and for BNHL was above 18. The ECOG score also has to be good, 0 to 1, and main contraindication was allogenic transplantation in BNHL. Autologous transplant was allowed. So this is the data as we had in June 2023. What the ORR was 76.5% at day 90. At day 28, it was 90.4%, as you can see. And most importantly, I would like to point out the CRS grade 4 toxicity was 4.3, again less than 5%. ICANS was 0. And we had, sadly, one mortality due to grade 5 CRS, and that's the one which I was pointing out over here. Other than that, most of the CRS we had was all grade 1. So this is something which completely stands it out. And I also want to clearly mention that the data that we are seeing and has been given to the regulator would show that the ORR is much higher, northward of 80%. The death data would be released in December. So as I mentioned, excellent efficacy in the range of 80% with more than 90% response at day 28. And this is a glimpse of the persistence of the data. Of course, this is evolving, and we had persistence ranging from 21 days to not reached. These are the median copies of the Valium captogen in the blood, and the B-cell aplasia duration also not reached. This is a swimmer plot. As you can see from the swimmer plot, green is good. The more green you have, the more patients who are in remission. And again, as mentioned, the safety data stands it out. It is the grade 3 plus CRS being less than 5%, mortality less than 5%, and 0% ICANS, which is the neurotoxicity. And that is reflected in the Kaplan-Meier curves for PFS and OS. So what I would like to really point out is this figure, a reduction of 59% in the risk of death. Now we've got a global data set going beyond 4 years. No time in the history of cancer, since the last 30 years for BALL and BNHL, since the advent of autologous transplant, has any cure reduce the mortality to this significant extent. So you are likely to save patients using this treatment by comparing to any other standard of care which exists. So this is the first treatment in India to have demonstrated this improvement in overall survival, and the manufacturing was 100% successful, and it was infused to 96% of the patients enrolled in the study. Now I'll go change tack. I'll look at the BNHL a little bit more in detail. Now obviously this is a session and I need to mention some of the options. In addition to Valium captogen, you have got monoclonal antibodies, some of which are not available locally in India, and they have their own toxicity profile. For example, tafasitamab and loncastuximab, and I would like to end this debate over here on that particular score is these are short-lived, these are antibodies, they have got half-life, and the remissions, if at all, are short, and they can be used as a bridge, but they are not curative. And same exists for CD20. Monoclonal antibodies, all of us have used rituximab, ofatumumab, and obinutuzumab. We know they're fantastic as a main anchor for chemotherapy, but again, the shortcomings are obvious. There is a lot of interest in the teams, which is also called as BITES, 20x3. You've got glofitamab, epcoritamab, and odronextamab. Some of these obviously are not available. Glofitamab, there is a program for a compassionate use, but again, these are used as bridge, and for bridging, you can achieve remission, but not a cure. So essentially, you're looking at responses, and when you took off responses for a patient perspective, you are achieving, you want a very high ORR, and you also want potentially a cure. And this is the data for Axi-cell and Tisa-cell. This is now coming to the real-world data, where you can see that the curves are now plateauing, going beyond 18 months. And what's those curves properly? They are in the range of 40 to 50%. And that is also reflected. And of course, the performance status and LDH do make an impact. A good performance status carries a better outcome. So again, the timing of CAR T-cell therapy is very important, and selection of patients also helps in improving the outcomes for your patients. Now, coming to the timing in terms of algorithm. We already seen the data for third line. What's the data for second line? So there were 3 landmark papers. One was the transform data. Then of course there was this landmark paper which was the ZUMA-7, and then there was a Belinda study. Now the Belinda study was a negative study, and there has been a very good editorial in NEGM which looked at the patient selection for Tisa-genletrocel for Belinda and why it did not show a better outcome. As regards to ZUMA-7 and Transform, we have seen significant improvements that was been reported very well in the literature and published in NEGM, and to the range of the percentage being 40% and the standard of care being less than 20%, which we already know about. Same thing was reflected for the Transform data. And what is more important, is the responses were not just in the chemo patients who had relapsed within 12 months or beyond 12 months, but also in the refractory setting. As you can see, it was 85% for refractory, and for relapse been 92%. And the CR rates were pretty deep in the sense of 70%. Now, we have seen the same with the Pgi-Hem-Onc, where you have CR rates upwards of 60%, and that is a good indicator of potential long-term cure rate. Now, this particular data is from Lysocell. Now, what is the advantage of using CAR-T compared to transplant? Obviously, there are certain subtle differences in terms of age. You have got a more dynamic range in terms of going up to 70s and 80s. You also have, you can look at the creatinine clearance. You can compromise on the creatinine clearance up to 30 ml. Cardiac function, ECOG score, though the trials are looking at ECOG score of 0 to 1, coming to the real world, clinicians may have to take a decision on including some patients, maybe as the experience grows, whose ECOG score may not be that good. And that, of course, depends on the center experience and individual treatment experience, and of course looking at the lung function. But the real world data showed that ORR was again upward of 80% with CRs, very deep CRs going beyond 50%. So this is the algorithm, and we know that the NCCN has approved CAR T-cell therapy in the West, in the global north, for second-line DLBCL, and that's reflected in the choice of options that clinicians have. So what's the role in BCLL? We had a fantastic session, just the previous one, where we had looked at the multiple options. And today, the era, and one of the questions was asked was, are we all switching over to BTK and venetoclax? And I know India is on that journey now. A lot of the algorithms are changing, and it's a question of time when most of the patients would be on BTKI plus minus venetoclax. And however, I would like to point out that that is not going to be curative for all patients. This is the data already existing from the West, where there is a response rate of less than 0 to 5% in patients who have failed BTK inhibitors and venetoclax. And look at the overall survival, it's only 5.5 months. And this is the EBMT. EBMT clearly mentions, consider allogeneic transplant for high-risk CLL, and those who undergo allogeneic transplant enjoy a lower risk of relapse. So there is a role for allogeneic transplant for CLL patients who are refractory, and this is the data for Lysocell in CLL. And as you can see, doing a CAR T-cell therapy in patients who have got minimal MRD or ideally CR carries a much better response rate. So the message that I want to give is, yes, BTKI venetoclax is the way ahead, but for those patients who do not respond, you are likely to use a CAR T-cell therapy, which will probably give you much better and longer response rate for BCLL. Coming to 1-encapsid autoleucin in BALL. Now, we cannot discuss BALL without discussing the role of MRD, because MRD is everything in terms of how you approach this patient. And we know that most of the very good centers can give a reporting of MRD up to as low as 10⁻⁵. Lower the MRD, directly the correlation with outcome. And MRD interpretation can be based on leukemia-associated immunophenotype or the difference from normal. I'm not going to go into details of that. I'm not sure Professor Manubdesh Singh is here, but he does a fabulous work, and I'm sure there were separate sessions on MRD. We know that survival in MRD positive patients is lower than those who are in CR, and that's been reflected both in adult and pediatric population. And there is data which showed that the responses and overall survival with minimal disease is much higher and better for those with higher disease burden. Now, this is especially true for B non-Hodgkin's lymphoma, but this is also true for BALL. But in addition to the disease burden in BALL, it is important to note the disease biology. So as you can see, high disease burden, low disease burden. So the question is, should you do transplant for a patient or CAR T-cell therapy for a patient with full-blown relapse? And this is what we had done in the study as well. We advise for the patient's safety to debulk these patients, and I'm going to consider and discuss some of the chemo-free options in reducing the disease bulk and then going on to CAR T-cell therapy for improved outcomes. Now, this is the data looking at the role of MRD, and this has been published in 2021, and it clearly shows that deeper the MRD, lower the risk of relapse. In the West, blinatumomab is the only drug which has been approved to treat MRD, and hopefully once the regulator has reviewed our file, you will have an option of one-name captopril autoleucel to treat MRD positive patients with BALL as well. Now, looking at the EBMT recommendation, I would like to point about the transplant recommendation. One is obviously the high-risk ALLs, and as once you've completed induction, consolidating with allogenic transplant, also those with adverse cytogenetics, but most importantly, it is achieving CR at day 28 or day 33. I think that is on its own the most important parameter when you treat BALL. What is the remission status at day 28 or day 33, depending on the individual practice. Now, this is the data of allogenic transplant, looking at CRBMT data from 2009 to 2019. So this is a pretty updated data. And you can see that those patients who were never in CR still have a poor outcome despite allogenic transplant. Yep. And this is the trend of transplant in the US. As you can see, there is a dip coming, and this dip will continue because as the role of CAR T cells pick up. Now, there is a separate problem in the West, the global North, where CAR T cells are available. However, there is an issue of waiting time and production and scale up. So, access availability is one thing, but making sure that these are scaled up to meet the needs of your population is also important. But once the manufacturing and scale up happens, you would find that many of these shifts in terms of treatment options will happen, and the traditional role of allogenic transplant for BALL would come down. Of course, financial aspects is a separate topic which I'll not cover in this particular discussion. So where are we with BALL? We know that BALL, the CAR T cell therapy, one-name captopril, and other CAR T cell therapies can be used for relapse refractory setting. Moreover, there is data for BALL using CAR T cell for MRD positive disease. Now, as I mentioned earlier, what are the options going forward for chemo-free or chemo-light induction strategies? Many of you have already started using rituximab, though we know that only about 20% patients of BALL have CD20 positive blasts, but that has shown improvement in terms of induction. This is the data which was published a few years ago, the D-ALBA study, looking at a TKI and blinatumomab. So there is a very good data combining a TKI, be it imatinib, dasatinib, or ponatinib, plus minus blinatumomab for BALL, and producing excellent induction remissions. Now, it is only a question of time where, as I said, if you use blinatumomab before a CD19 CAR T cell therapy, there is some data, but it will impact on the outcome. So the recommendation would be, if you're planning CAR T cell therapy, that's not the way to go ahead, and it's only a question of time. You're going to replace blina with a CD19 CAR T. So what are we there with immunotherapy? So there is a role for rituximab in about 20% patients who express BALL. There is an evolving role of changing strategy in terms of chemo-free or chemo-light options using TKI steroids for pH positive or steroids for blina / as we go along, the data for CAR T cell therapy pretty upfront, and I'll show you that in a few slides from down. Also, inotuzumab in combination with reduced intensity chemotherapy has demonstrated efficacy. And the point I would like to make is that early referral to CAR T cell therapy is very, very important in terms of improving outcomes. Now, what I'd shown you until now was that about 80% patients respond to treatment. Of these, 40 to 50% patients over a period of 18 months to 4.5 years are potentially 60% are cured, but about 40 to 50% patients may need further treatment. So what are the options for these patients? One is, of course, allogenic transplant, but I would like to mention offering allogenic transplant to all patients following CD19, as what is done in China, is not clinically sound. Why? Because 60% of these patients you'd be exposing to life-threatening complications such as GVHD, infections, impact on quality of life, fertility, economic productivity, financial burden, and of course procedure-related mortality. So the standard regimen as used in China was they used a consolidation with as a bridging for CAR T-cell therapy and followed up with allogeneic. I think that way you're going to over-treat 60% of the patients where it's not needed, because 60% of your patients are treated, cured with CAR T-cell therapy. So some of the other options include using reinfusion with CAR T-cell therapy, and that is abstract is sent to ASH. Fingers crossed, we'll get you the data out in December. And of course, in those patients who still do not respond, there is an option for allogeneic transplant. Depends on the CD19 positive or CD19 negative disease. There's an option of CAR T-cell therapy using a different antigen, which is again a different discussion altogether. So there is data for allogeneic transplant to non-responders post-CAR, and this has been studied in UPenn and various other papers, and has shown that about 30 to 40% patients can proceed and can show some durable responses. So where are we in terms of Varnim, Captisone, Autoleucel? So it's a one-shot treatment. It's a global standard. It's a broad indication, short treatment and rapid recovery, long-term remissions with a cure potential, manageable safety profile, and excellent, better quality of life. So what I'm looking at is Varnim Captisone being a global standard of care as a one-shot cure for long-term safety and efficacy with improved QOL. So this is where the algorithm is looking like. We already mentioned with BALL in relapse refractory setting. We are now looking at chemo-free options for strategies, which will be discussed in a further discussion in a few months' time, and consolidating the MRD positive patients with Varnim, Captisone, Autoleucel. And the potential projected benefit is like you're converting a 2 to 3 year long treatment, a conventional treatment, to 3 months. And the benefits of this is not just restricted to in terms of productivity, intellectual capacity, in terms of intellect and scholastic performance for children, but also preserving fertility for those who are in the adolescent age. So it has a completely disruptive potential, and how we use it, it depends on the clinicians within the centers as we go along. And looking at the BNHL, you're looking at Varnim Captisone for patients after first relapse. But there would be some patients, for example, who have got very high-risk disease, who are progressing after, let's say, 3 or 4 cycles of R-CHOP, then certainly you would not want to continue using the same regimen for clearly a refractory patient. So you might as well change tack after your first line in a refractory patient and go on to CAR T-cell therapy. These are some of the peer-reviewed publications. So there are up to 9 publications of Varnim Captisone Autoleucel. These are global publications presented at ASH and EHA. This will be joined by some more abstracts later this year. We also have about 13 publications from the phase 1 study of Varnim Captisone in Spain, which are there in various prominent journals, as well as seminars which were across the world. And I would like to conclude with acknowledgements at all the sites, at Narayana, Apollo, and of course at PGI, Dr. Pankaj Malhotra and his team, and the team from Immunil. So many thanks to all the patients, families, friends, study site coordinators, and all those involved in the IMAGINE study for producing this data. Thank you. Thank you.
Thank you, sir, for the wonderful talk. Now the session is open for any comments.
If you don't mind, let's do it the other way around. I would like to ask the audience, is there anybody in the audience who has doubts on the safety or efficacy of CAR-T in 2023? It's 13 years since the first CAR-T. Is there anybody in the audience who has any doubt that, I think there's no raised hand. So I think the issue of CAR-T cell as a treatment algorithm is settled. Now the question is, Manju. No, that's
very nice data. Congratulations on this brilliant presentation. I just wanted to understand what was the disease burden in ALL, in terms of the disease before the CAR T cell. They were included in CAR T cell trial, not before infusion. And same way for lymphoma.
Yeah.
What were the number of lines of therapy and what was the response?
Sure. You're talking about the Varnim study, right? Yeah. So coming to Varnim Captisone study, the median lines of treatment was 1 to 5, with the median being 2. The blast percentage for BALL ranged from 0.1 right up to 40%. So we had that range. We had a deliberate policy, as I mentioned to you earlier, on a strategy to debulk a patient. I don't think it is, I would never advise a physician with 90% blast going straight for CAR-T. That is invitation for trouble. You need to have strategies to debulk the patient, get the disease burden down, though that will be, you'll get a small window of opportunity. You'll get a tiny window of opportunity. Let's say, I'm not going to mention drugs, but inotuzumab is a good drug, 1 or 2 shots, get the blast burden down, get the manufacturing done. You got this 2-week window, get your Pgi-Hem-Onc, get your CD19 CAR-T. So with the, what I wanted to mention is that if you reduce your disease bulk, you're going to improve the patient experience. We did not have any patient going to ICU, not a single patient, except that one patient who died. And I think, of course, looking back, the mortality rate will become almost zero as clinicians become more proactive with the CRS management. Sorry, go ahead. You had another.
No. The reason why I just wanted to understand this, because a lot depends on, in terms of toxicity, what your disease burden, as you highlighted. The second challenge in ALL is, what is which debulking therapy we are going to use. More so if we are talking about patients who are in second relapse and beyond. One, because in our setting, most of these patients are prone for infection. So if you use a lot of, bridging therapy, then in that case, you are, they may get more infections, and by the time you are infusing them with CAR T-cell therapy, they may be quite sick and they may not make it because of those infections, because the neutropenia is prolonged. The third thing is that if you're using bridging therapy like inotuzumab, and if the patient has not been exposed, what is the contribution of inotuzumab in terms of improvement in outcome as opposed to the CAR T-cell therapy? So that becomes, because if you look at all the other bridging therapy data which is there in other ALL trial, from the CAR T-cell ALL trial, they haven't used newer agents to which patient has not been exposed, because then you are compounding your efficacy assessment.
Yeah. No, I think, Manju, all the questions that you asked were particularly relevant, but I would like to point out with 2 or 3 things. Number one, no patient in MRD positive disease gets cured with be a BiTE or be it inotuzumab, CD20 monoclonal. There is no cure. Even if you look at a monotherapy for inotuzumab, the data for licensing approval, the median PFS was 3 months. And then they all relapsed. There is no documented cure to date. So that is number one. Number two, why in India we are proactive? Because we don't have the capacity to take the luxury of 3rd line, 4th line. Our attrition rate is so high, very few tiny patients reach 3rd line. By the time you have your 1st line and 2nd line, the game is over for all the patients. So it is very, very important that we preserve the quality of our patients going into CAR-T. Because we don't want, the costs go very high as soon as the patient lands up in ICU. So we have to be really smart. That is why I spend a lot of time on trying to get a consensus in terms of going forward for BALL, chemo-free options. Do not hesitate to use inotuzumab if required. I'm not saying, I'm not pushing for that. I'm not advertising inotuzumab, but I'm using that as an argument for reducing the disease burden, and then go to CAR-T. I will not recommend that going for CAR-T or Pgi-Hem-Onc directly with a high disease burden. And I know, Dr. Pankaj, you also want to make your point, we'll give you in a moment, but this is one. Number two, you mentioned what is the strategy. So there are various options. Inotuzumab is one. You have to look at the patient history here, because each patient is different. We don't know what all treatments they've had in the past. If they had the conventional treatment, then most of them would not have had inotuzumab. Most of them would not have it. So that is one option. And of course, pH positive has their own, there are various ways you can debulk. Only steroids can also work. But I agree with you on the point of infections. But there is very good data which shows that the risk of infection is directly correlates with disease burden. And we have seen this in transplant, we have seen this chemotherapy, and we are also seeing this in CAR-T. We got an abstract we're saying to ASH. The disease, which is interesting, because if your patient is in remission and there is no active disease, they tend to do better, and the infection burden is also low. There is a direct correlation. If you look at all your patients in your own practice and you find the amount of infections, you'll find that most of that correlates with lack of response. So there is, I know we can discuss this, but and in fact we had one patient, I don't want to go into specifics, we had one patient who would have probably filled half the page of all infection adverse events. After CAR-T, 0 infections. because that patient is in remission. So all that infection is actually a reflection of disease burden. So I take your point, but that again is the same argument that you need to debulk, get to CD19 CAR-T, get into remissions. Pankaj, I'm sure you have some views. Please share.
So,
that will be the last comment.
Yeah, the ALL obviously is a heterogeneous disease. Even if you talk of B lineage ALL, even that is a heterogeneous disease. And so, you know, I personally feel that if you have the availability of options, then that is very good. And I would actually leave on to the clinician what best therapy he feels is best for the given patient. You know, in some patients, definitely it will be CAR-T. But for some patient, even Blina is, I think, good. And I would slightly differ from your, you know, assessment that at least, you know, some patients who were MRD positive and were given Blina and they did not go for a transplant, some of them actually are cured. So this is, you know, the...
We have to watch the data. We have to watch that data because...
So at least up to 3 years. And we believe that, you know, some ALL who has not relapsed in 2 years' time, generally I would think that, you know, most of them are kind of cured. So this is, you know, those patients who are, you know, they were supposed to go for undergo transplant. Because of some reason they did not undergo transplant. And they were given only Blina. So they are doing one. So this is there.
But what is on that Blina?
We'll have to keep it short now.
Yeah. So the convenience of giving Blina in terms of how the regimen is given.
So we should, you know, we should take it as like, you know, if somebody is a cricket batsman. So if he has all the, you know, how to put a stroke. So I have CAR-T, I can, you know, put a sixer, I can have inotuzumab, I have blinatuzumab. And then, you know, we know many of the ALL patients have CNS disease. Now, what do you do for those patients? Somebody had a testicular relapse. So, you know, so if all these facilities are available, so then obviously the clinician can choose which one would possibly work best for the given patient.
So I agree. So individualized options, individualized treatment options.
I think we will
Manju, you are saying something?
We will have to now cut short
Thank you very much. Thank you.
Over lunch, definitely the discussion will continue, but we've had a fantastic session. Thank you so much, Dr. Anil Kamath, Dr. Manju Sengar, and Sambit Mohanty for wonderful talks and a wonderful session overall. And it's over to the organizers. Thanks from all of us here.
I thank our chairpersons and the speakers for their valuable insights. The next session on oral presentation starts sharp at 2:30 p.m. I request all the delegates to kindly proceed for lunch.
GDP have been used for chemomobilization. So the advantage of using this salvage chemotherapy as chemomobilizing agent is that while maintaining the dose density and intensity, simultaneously we will be able to collect the stem cells. So in this retrospective study, we try to study different mobilization patterns of different chemotherapy regimens and factors influencing it, and also GCSF with and without pleroxifer. So the study design, it's a single center retrospective analysis. Study population included transplant eligible Hodgkin's and non-Hodgkin's lymphoma patients of all age groups who underwent peripheral blood stem cell harvest attempts. So the study duration was from December 2008 to June 2022. So the primary endpoints, coming to the primary endpoints, we try to descriptively characterize different chemotherapy regimens in terms of percentage of successful harvest, that is being able to collect more than 2 million cells, median day to harvest, median peripheral blood CD34 on day 1, number of days of harvest, median CD34 collected on day 1 of harvest, median total CD34 collected, and number of patients in each group needing pleroxifer. Secondary endpoints were to identify different factors influencing successful mobilization in respect to gender, age at harvest, number of chemotherapy lines received before harvest, history of any radiation treatment, steady state platelet count, status of disease at harvest. So coming to the results, we have done, it was 287 peripheral blood stem cell harvest attempts were made in 272 patients, of which 174 attempts were in patients with Hodgkin's lymphoma and 113 attempts were in patients with non-Hodgkin's lymphoma. Median age of the population was 29, ranging from 5 to 78. Harvest was attempted post first line in 11% of the patients, post second line in 71% of the patients, post third line and fourth line in 15 and 1% respectively. Over 15 years, different mobilization strategies were used. GDP constituted the majority with up to 50%, followed by GCSF with or without Plerixafor in 15% patients, and mine in 12%, ICE in 6% of the patients. Different other strategies were used like cyclophosphamide, IGVD, DAB, DECA, etc., but they were used in small numbers. So coming to the baseline characteristics, for the sake of convenience, we have divided the population into 4 groups. Group 1, GDP mobilization. Group 2, ifosfamide-based mobilizations, ifosfamide-based regimens were used. Group 3, cytarabine-based regimens were used. Group 4, GCSF was used. Among all the 4 groups, the median age was in the young age. All of them had age groups of around 20 to 30. And males constituted the majority in all the 4 groups. Coming to the group 1, group 2 and group 4 had majority of Hodgkin's lymphoma patients, whereas cytarabine-based regimens were used majority in non-Hodgkin's lymphoma patients. All of the majority of the patients harvest was attempted before or when post less than or equal to 2 chemotherapy lines, and majority of the patients in all the 4 groups did not receive RT. Platelet count, which acts as a surrogate marker for bone marrow reserve, was found to be adequate in all the 4 groups. Coming to the success rates, we can see that cytarabine was found to be the most successful regimen with around 100% success rate, but we can see that it was attempted in very less numbers. Whereas coming to the GDP, which was attempted in 140 patients, that is nearly 50% of the patients, the success rate was around 95%. And mine had the lowest success rate with around 64%. And coming to the median day to harvest, we can see median day to harvest was highest with ICE and lowest with IGVD and cyclophosphamide. The median number of days with days of harvest was highest with ICE and DAP. Median CD34 cells collected on day 1 and total CD34 cells collected were highest with cytarabine. On grouping efficacy, ifosfamide-based regimens had the highest mobilization failures, approximately around 30%. Chemo mobilization success with GDP was significantly better than ifosfamide and GCSF-based regimens. Those patients who have received radiation to mediastinum, spine or pelvis followed by ifosfamide-based mobilization had a failure rate of approximately 48%. Odds ratio of 15.6 compared to GDP regimen without RT. Other clinical parameters like age, gender, platelet count, number of lines of therapy did not have any impact on harvest result. So coming to the conclusion, GDP chemo mobilization is significantly better than ifosfamide and GCSF mobilization. Cytarabine-based regimens were also found to have good success rate. Though it was numerically successful, it was not proven statistically. In patients receiving mediastinal, spinal and pelvic irradiation, ifosfamide-based chemo mobilization is best avoided due to high risk of mobilization failure. Thank you.
So thank you, that was really good. Are you confident that the cytarabine you feel was a very good mobilizer? Because I think it was only in 7 patients.
Yes, but cytarabine based, if you see other regimens like which included cytarabine were also doing well, but coming to cytarabine alone, when it was used, it also had 100% success rate, ma'am. But we couldn't prove it statistically because of the less numbers, ma'am. Otherwise, if you see numerically, the success rate was pretty good.
Was there any difference in the toxicity that you saw amongst the regimens? Because one is, of course, the efficacy, that's good, but was there any toxicity that you found more in one regimen versus another?
Actually, we didn't look for toxicity in this one. We were actually looking for the efficacy. We were evaluating the efficacy over 15 years, which was the better mobilizing agent we were looking at, but we didn't look into the toxicity sources.
Okay.
So are there any factors other than what you studied which are responsible for variable mobilization kinetics? Even in normal people, these have been studied. And you know that even in normal people, the kinetics are not same.
Yes.
And they are dependent upon certain factors.
Yeah.
So would you consider that to be one of the limiting factors of your study?
Definitely that would be a limiting factor, sir, but this being a retrospective study, I think.
Yeah. Any other reasons that you would say that we need to actually have a prospective data before we really make this sweeping statement that you are making? So your retrospective data suggests that GDP is better than ifosfamide.
Yes, GDP, yes, it's
right,
definitely
for mobilization. That's what you are telling us.
Yes, sir.
But then majority of your patients were actually on GDP.
Yes.
So is it the basic disease and control of the disease that actually dictated your mobilization regimen? Supposing today you had a patient of non-Hodgkin's lymphoma versus a patient with Hodgkin's disease, and if you were to use a mobilization strategy, which one would you use? Which one do you use in Tata Memorial as of today?
We prefer using GDP, sir, because it has been tested, because it has been used in majority of most of the patients. We have more experience that it is doing well. That is the reason we have been using GDP, sir.
So also this was a 15-year retrospective data.
Yes, sir.
So
nearly
could
15
other things have changed in 15 years? What about your apheresis machine, some other techniques? I mean, a lot of things change in 15 years.
Maybe the introduction of Clarexfer has become, we have been using Clarexfer more often. In the last 4 years, we have been using it.
Also, the prior chemotherapies might have been different. I mean, a lot of things.
Yes.
Okay.
Yes.
So thank you. It was very good.
Thank you, very good. But all retrospective data generally give us an idea as to what should we do in future, but not really give you a conclusive proof more often than not. Thank you.
Thank you.
Thank you.
Next in the category, I would like to call Dr. Keshav Garg from Tata Memorial Hospital, Mumbai.
A very good evening all. Myself Dr. Keshav Garg, third year resident, Tata Memorial Hospital, Medical Oncology Department. I would like to present my topic today, pattern of sensitivity and resistance of stool surveillance over 13 years in a tertiary care center and impact of stool surveillance guided selection of antibiotics during neutropenic sepsis in patients undergoing allogenic hematopoietic stem cell transplantation. So as we all know, allogenic hematopoietic stem cell transplant recipients are at high risk of life-threatening bacterial infections. Our center has a policy of doing stool surveillance cultures weekly at the time of admission and till discharge to guide antibiotic selection during febrile episodes. So in this study, we aim to compare the impact of empirical versus stool surveillance guided use of antibiotics during febrile episodes and change in stool sensitivity pattern over a 13-year period. So this is a single center retrospective analysis of patient undergoing allogenic hematopoietic stem cell transplant between January 2008 to December 2020. So stool surveillance culture were collected at admission, then weekly till discharge, and also during febrile episodes if patient was readmitted due to fever till day plus 100. So patients were divided at baseline into 4 groups based upon the stool surveillance culture. So group 1 was pan-sensitive patients, and group 2 was extended spectrum beta-lactamase patient and carbapenem resistant organisms group, and group 4 was vancomycin resistant enterococcus group. So all pan-sensitive patients received antibiotics cefoperazone sulbactam or cefepime-tazobactam as first line in first episode of febrile neutropenia. In the 3 resistant group, that was ESBL, CRO and VRE, first line antibiotics were given as either empirical or stool surveillance culture guided. Empirical included cefoperazone sulbactam or cefepime-tazobactam. Stool surveillance culture guided were either meropenem amikacin or meropenem colistin. So change in stool surveillance culture sensitivity pattern was also analyzed analyzed in 2 different time periods, which was divided into 2 cohorts. Cohort 1 included patients from January 2008 to 31st December 2014, and cohort 2 included patients from 1st January 2015 to 31st December 2020. So primary endpoint of the study was defervescence to first-line antibiotics in all groups, and defervescence according to empirical versus stool surveillance culture guided use of first-line antibiotics. So baseline characteristics captured here were age, which was median age was 27 in all the patients, and predominantly they were males. 73.46 were males, and most common diagnosis was acute leukemia, and match-related donor transplant was done in 75%, and in rest haplo or mud transplantation was done. And at the baseline, for 64.8% patients had pan-sensitive stool, and 21.78% had ESBL in their stool culture, and 10.3% had carbapenem-resistant organism at baseline, and 3% had VRE. So out of the total 358 patients, 97.2% patient had febrile neutropenia during bone marrow transplantation, and in the 3 resistant group, which included ESBL, CRO, and VRE, total were 123 patients, and empirical antibiotic was used in 72 patients, and stool surveillance culture guided antibiotic was used in 51 patients. And EBMT score, HTCTI score, and DRE score was also captured at baseline. And so to summarize the results, there were total 358 patients, and febrile neutropenia occurred in 348 patients. And out of 348 patients who had febrile neutropenia, baseline stool surveillance was pan-sensitive in 225 patients and resistant in 123 patients. So out of 123, as I have already told, 71 patients received empirical antibiotics, and 52 received stool surveillance culture guided antibiotics. So with the use of first-line empirical antibiotics, defervescence occurred in 18% patients, and with the use of stool surveillance culture-guided antibiotic in 3 resistant groups, defervescence occurred in 78% patients with a significant p-value of 0.008, which was clearly higher in the statistically significant in the stool surveillance culture-guided use of antibiotics. Blood culture positivity was seen in 53 patients during febrile neutropenia episodes, and of the 53 patients who had blood culture positivity, 19 had baseline resistant stool. So blood culture positivity was higher in the patient where empirical antibiotic was used versus stool surveillance culture use of antibiotics, which was statistically significant with p-value of 0.05. And so this table depicts the change in sensitivity pattern in 2 cohorts. So cohort 1 included patient from 2008 to 2014, and cohort 2 from 2015 to 2020. So in cohort 1 there were 193 patients, in cohort 2 there was 165 patients. So we can see that at baseline pan-sensitive ESBL, CRO, and VRE percentage remains similar, with there was not much significant difference in the baseline stool culture in the 2 cohorts. And during the admission course, from the admission till discharge, weekly stool culture were also captured, and those who remained persistent pan-sensitive throughout the admission were 43% in the cohort 1, and they decreased to 27% in the cohort 2. So there was a decrease in the persistent pan-sensitive patients from cohort 1 to cohort 2 with p-value of 0.0028, and who changed from pan-sensitive to either ESBL or CRO significantly increased in percentage from cohort 1 to cohort 2 with p-value of 0.008. So these are the OS curves which we captured in match-related donor transplant and haplotransplant separately, and as we can see, at baseline stool culture, either pan-sensitive, ESBL, VRE, or CRO, it does not impact the overall survival in this from baseline stool culture, and change in stool surveillance sensitivity pattern also not impacting the overall survival in match-related donor or mud transplant patients. So to summarize the result, between cohort 1 and cohort 2, sensitivity pattern of baseline surveillance stool culture remained similar. More number of patients changed from sensitive to resistant strains in cohort 2. Baseline sensitive stool culture and change in stool sensitivity pattern did not have an impact on incidence of acute GvHD and overall survival in the match-related donor transplant patients. And to conclude, higher number of patients responded to first-line antibiotics if stool surveillance guided approach is used compared with empirical use of antibiotics, and it may reduce the use of more lines of antibiotics. However, there is no impact on overall survival. So incidence of resistant stool surveillance culture has increased over a period of 13 years, suggesting need to relook antibiotic stewardship in our center. Thank you.
So very interesting. That was a good study. So did your blood cultures that you got, I think you got about 10-15% blood culture positivity, did that correlate with what you were finding in the stool?
So ma'am, only in 12 patients we had similar organism and in the blood cultures and in the stool culture. They were very low in number. Concordance in blood cultures and stool culture at baseline was low in our study.
Okay, and this increase in resistance that you saw, so you had in the second cohort, was that only in the BMT unit patients, or did you see that in other other patients in other parts of your hospital?
So this was only in the BMT patients, ma'am, who underwent allogenic hematopoietic stem transplant.
So 18% of your patients who had resistance in the stool surveillance showed response to empirical treatment, right?
Yes.
So then, after change in treatment, how many of them actually had effervescence?
So we have not captured that data. Ki if empirical antibiotics was given and defervescence does not happen, we gave second line antibiotics, and we have not captured ki how many responded, but most of them responded to second line antibiotics.
So were these the same as the drugs that you were using for the resistant organisms?
For resistant organisms, if there is ESBL, we use meropenem and or amikacin plus minus, and if there is CRO, we tend to use meropenem or colistin, and we also use Ilorus, cefoperazone, sulbactam, and EDTA in most patients. We also looked at the sensitivity of sensitivity pattern of stool cultures with Ilorus. So most of the patients received Ilorus and meropenem colistin if they are CRO.
So what percentage of patients required antifungals?
We looked at that data, but I don't have that data yet, how many number of patients required.
So you would strongly suggest to do a stool surveillance in all patients who are undergoing a hematopoietic stem cell. No, that's what you were saying, isn't it?
Yes, sir. Looking at this results, what we got, there is clear benefit in the time to defervescence and use of second line of antibiotics who have responded when there is a resistant organism at the baseline.
Your current practice is now based upon stool surveillance?
Yes, sir.
And starting an appropriate antibiotic irrespective of what it turns out to be later on?
Yes.
Is that right?
No, first antibiotics we used based upon the baseline stem cell stool culture. If there is any change in the blood culture or then we change antibiotic according to the patient is responding.
Thank you.
Thank you.
We now go to the next category on benign diseases and clinical studies, for which I would like to call Dr. Pradeep Reddy from Pgi-Hem-Onc.
So, good afternoon. I would like to present our project, interim analysis of the project, which is going on still now. So this is done under collaboration of 4 departments, Department of Clinical Hematology, Medical Oncology, Hematology, Pediatric Hemato-Oncology, and Transfusion Medicine. So introduction, telomeres are, so title of my topic is to investigate relationship between telomere length and clinical outcomes in adolescent or adult onset aplastic anemia. This is a prospective observational study. So telomeres are specialized nucleoprotein tails at the ends of all chromosomes, and they maintain the integrity of chromosomes by preventing activation of DNA damage responses. Short telomeres are seen about 1/3 of the patients with apparently acquired aplastic anemia, and very short telomeres, which are less than 1 percentile, are characteristic of telomere biology disorders. There are a few patients where cryptic or atypical presentation of marrow failure syndromes will be there, which are difficult to diagnose, and recognition of this entity affects the treatment modality. So data on the telomere length from population and in the plastic anemia patients correlating with severity at presentation, hematological response, relapse, and clonal evolution, and response to the newer agents like L-Trombopag is limited from our South Asian population and particularly in the Indian population. There are few studies from South India, 1 or 2 studies from CMC Vellore, but in North India we aim to do this study because the data is lacking in our population. So aims of this study is to investigate the relationship between telomere length and clinical outcomes in adult onset aplastic anemia. Primary objective is to do a telomere length at diagnosis 3 and 6 months of therapy. The secondary objectives are to analyze the relationship between pre-treatment telomere length with hematological recovery, relapse, survival at 3 months and 6 months. And also to analyze the role of baseline telomere length as a biomarkers in patients with aplastic anemia and to correlate telomere length with severity. So materials and methods we used, inclusion criteria we kept it as patients with age more than 12 years and diagnosed as aplastic anemia were included, and also patients should be treatment naive or who were on treatment for less than 2 weeks. Exclusion criteria were pancytopenia with other causes like bone marrow fibrosis, significant dysplasia, malignant infiltration or myelophthisis, hypoplastic marrow post stem cell transplant, aplastic anemia secondary to cytotoxic therapy and radiation therapy, and patients already on treatment for more than 2 weeks and unwilling to give the informed consent. So definitions and diagnostic criteria, as per diagnostic criteria and severity, the standard modified Kemita criteria is used to classify patients into severe, very severe and non-severe aplastic anemia. PNH clone size is defined by International Clinical Cytometry Society guidelines. Clone more than 1% is considered as a major clone, and a clone of 0.1 to 1% is considered as a minor clone. As per telomere length, very short telomeres are those less than 1 percentile for age, and short telomeres are between 1 to 10 percentile, and normal telomeres are more than 10 percentile. So we included total 56 patients, but only baseline telomere length was done in 55 patients, and controls were included, age-matched controls were included, and the number was 137. The 3 ml EDTA blood sample was collected, and MNC's mononuclear cells were collected, and DNA was extracted using Pgi-Hem-Onc kit, and reverse transcriptase, real-time qPCR was performed. So the reagents in the table shown are used for the PCR, and the forward and reverse telomere sequences and single copy gene shown in the adjacent table are used. So for calculation of relative telomere length, real-time qPCR was utilized in the study, employing Cawthon's method of modification to calculate the relative telomere length. Individual samples were analyzed in triplicates, and only those with standard of deviation of cycle threshold values less than 1 were accepted. For each sample, either case or control, they were run in triplicates, and the mean CT value was calculated and taken as T, along with the mean CT values of the housekeeping genes taken as H. So the difference between these samples is delta CT, which is T minus H. In each run, the cycle threshold data for the age-matched controls were calculated, and this is taken as a reference sample. And from that, 2 delta CT was calculated and taken as a relative telomere length. So based on these values, we compared relative telomere length of cases to controls, and they were given percentiles using SPSS on a scale of 1 to 100. So statistical analysis, we performed demographical, clinical, laboratory characteristics were analyzed using descriptive statistics. Association of telomere length with other baseline characteristics were analyzed during chi-square test. Survival probabilities with log rank Mantel-Cox test. A two-sided p-value was considered significant. All statistical analysis were conducted in SPSS version 26. So 62 patients were screened for eligibility, 6 were excluded. 56 patients were enrolled in the study, and according to modified Kemita criteria, they were classified into severe, aplastic, non-severe, and very severe. At the baseline, we could do telomere analysis for 55 patients. At 3 months follow-up, around 9 patients died and 2 were lost to follow-up. And patients available for telomere length analysis were 36. And at 6 months, 25 patients' telomere length was analyzed. So coming to baseline characteristics, median age was 24 years. Sex is equal in...
So you will have to hurry up a bit, your time is over.
So we divided the treatment into two broad groups, androgen-based and IST-based, because there are very small heterogeneous groups in this cohort. So androgen-based group is taken as patients who receive danazol with CSA or danazol alone, which is 46, and ATG-based who received ATG with CSA with CSA with or without eltrombopag or romiplastim. So it is eight patients. At 3 months, 16 patients responded and all were PRs. At 6 months, one patient had a CR and rest 18 had a CR. Coming to telomere length, very short telomeres are seen at baseline in 15 patients. So comparing baseline characteristics with among patients who are PNH positive and negative, majority of the patients with PNH positive, PNH clone positive were severe aplastics, and there was significant response in patients with a PNH clone. Comparison of characteristics among patients with short and very short telomeres versus normal telomeres, it did not show any significant difference statistically in our study. So telomere kinetics in patients with IBMFS mutation positive group. So this is a 33 gene panel which we have used in the study, and among these, 4 patients had likely pathogenic and pathogenic mutations, 2 patients had Fanconi anemia, and 2 patients had dyskeratosis congenita. So out of 3 TERT positive patients, 2 had a very short telomere length. On follow-up, there was no statistically significant difference in telomere length at 3 months and 6 months on treatment. But there was a trend towards normalization in telomere length in these patients. So even in the androgen-based treatment groups, there was no statistically significant difference in the telomere length at follow-up, but there was a trend in normalization seen. So survival and mortality in the cohort, so this is a graph depicting survival in the study cohort. There was no relation, there was no survival difference in patients with normal, reduced and significantly shortened telomere lengths. So most of the patients died within 3 months of therapy. So as per severity, very severe
Can you summarize?
Yes. So our study established population-based controls in Northern India for estimation of relative loss of telomere length in patients with diagnosed with aplastic anemia. We found incidence of very short telomeres to be 27.3%, and overall incidence of short telomeres, which is less than 10 percentile in the current study, is 47.3%. There was no impact of baseline telomere length on short-term survival and response to therapy. However, we found a trend in normalization of telomere length post-therapy in patients available for follow-up. However, we found PNH positivity to be predictive of response. Also, significant proportion of patients with severe aplastic anemia are harboring a major PNH clone.
Thank you. So, how did you select your controls?
So,
you said that they were age matched, but how did you select them?
And they are normal voluntary blood donors, ma'am. CBC was normal for them.
Children were voluntary? What was your youngest age? The youngest was like 13 or something?
13, yes, ma'am.
Yes, 13 are not blood donors.
Yes, ma'am. We included wherever possible age-matched controls from the family.
No, but if they're from the same family, then, I mean, are they, that's what I want to know, that because a lot of times people, especially in these kind of studies, they don't put a lot of emphasis on the control, and you really need to know that your control is normal.
Even we collected samples from our hospital staff, age-matched controls, we have done that, yes.
Okay.
Any questions from the audience? None. I think Dr. Reddy, good body of work, but it should have been finished in time, right? That's another thing that we need to learn. So how does it compare with earlier work on the bone marrow failure syndromes from the department? without doing the telomere length. There were studies from the department which talked
Yes,
about.
sir, yes,
You
sir.
have NGS
There was
data
a study
and other
that danazol has increased T-rex.
No. So basically, we are talking about Fanconi and Fanconi-like syndromes in patients with adult aplastic anemia. Your data, how does it compare with that data? You are aware of the work? Okay. Okay, thank you.
Thank you.
Next, I would like to call Dr. Pavitra DS from Krishna Medical College, Ludhiana.
title was very misleading. He should have stuck to the telomere, but PNA, telomere was a delay. Otherwise, work up.
Good afternoon, everyone. I'm Dr. Pavitra. So I'll be presenting a session on optimizing hemophilia surgeries, a retrospective study of low-dose intermittent bolus factor infusions. It's a single-center study. Coming on to the background, all of us know that clotting factor concentrate replacement is a treatment of choice in people living with hemophilia. That's called PWH. More than 90% of the cost care in hemophilia is due to CFC therapy. These costs inflate dramatically during surgical procedures and due to increased need of CFCs. And there's always a continuous debate between whether to give continuous infusion or intermittent bolus. So we aimed at looking at the low-dose intermittent factor infusions, post-surgical prophylaxis, which we could offer a viable solution with restricted resources. Coming on to the objectives, it was to analyze the outcomes of surgeries in hemophilia patients in whom low-dose intermittent factor infusion was administered. We also looked at analyzing the factor utilizations and complications, including hospitalization days during the hemophilia surgeries. So it was a retrospective study conducted at Christian Medical College, Ludhiana from July 2008 to 2023. We included all patients with both hemophilia A and hemophilia B who were enrolled in our registry who underwent any kind of minor or major surgeries, and the factors were administered according to the World Federation of Hemophilia guidelines, which is the low intermittent dose administration. So we collected data including baseline demographic data, type of hemophilia, weight at the time of surgery, type of surgery, inhibitor status, total number of factors administered, and duration of hospitalization, along with the total factors administered over the hospitalization, complications and rebleeds, and blood products transfused. So data was analyzed in Microsoft Excel and entered in Microsoft Excel and analyzed using SPSS. So this was what we used for both hemophilia and hemophilia B as given by the WFH third edition. Coming on to the results. So we had 221 patients registered in our hemophilia registry from 2008 to 2023. The age group ranged between 1.8 years to 61 years with a median age of 28 years. All were males, and this was the distribution of mild, moderate and severe hemophilia amongst hemophilia A and B. So we had 57 major surgeries done. There were 66 patients, 53 hemophilia and 13 hemophilia B who underwent a total of 83 surgeries, meaning like one patient underwent one or more surgeries, 69 major surgeries and 14 minor surgeries. And these were the spectrum of surgical procedures which patients underwent. The most common was the orthopedic procedure, which contributed like 46%, because most of them have joint deformities and TKRs. This constituted the most of the percentage, followed by cholecystectomy and tooth extractions amongst the minor surgeries. Coming on to the factor utilization in hemophilia A, the factor utilization was 263 unit per kg, ranging between 48 to 1,235. The 1,235 is mainly because the patient had a complication and had a prolonged hospital stay. That's why he had the outlier there. In hemophilia B, it was 263 again, ranging between 136 to 708. In the minor surgeries in hemophilia A, it was 149 and 54.5 in hemophilia B. And these were the components which were used, like recombinant, plasma-derived, and long-acting, based on the availability at the center. So this is a box and whisker plot which is showing the median factor requirement, which is around 263 in both hemophilia A and B in major surgeries, and in minor surgeries it was 149 and 54.5 in A and B respectively. All our patients had a negative inhibitor status, also probably because of the inability of FIBA, where the patients were referred to other centers where they had FIBA for the surgery. The median duration of hospital stay was 10 for major surgeries and minor surgeries in both A and B, whereas in minor surgeries, if it was 4 and 2 days in A and B respectively. We didn't have many major complications. We noticed only 18% which had bleeding, and most of them were managed with top-up factors and blood product transfusions. The median blood unit transfusion which was received was 5.2 in the patients who had bleeding complications, and there was no mortality which was documented. So if we see this, we can see that according to the WFH, for low-dose practice, the median factor requirement is 355 and 345 in A and B, and in higher dose practice, it is 730 and 555. So in our study, we were actually using less, that is 263 and 263 in both for major surgeries, even lesser than the low-dose practice pattern suggested. In minor surgeries, again we found similar results. There is 149 and 54.5, which is much lesser compared to the low-dose practice pattern. So, and when we did the literature review, we showed that there's a variation in the factor levels which are targeted, and how there's a continuous debate going on where the factor utilization is more, whether it's in continuous or intermittent. In the previous studies, they have also shown us a much higher factor utilization during intermittent bolus factors, which was 733 and 861 in bolus factors, and in continuous it was less, showing 30 to 60% factor reduction with the continuous. But however, in our study, we saw that it was 41 to 51% lower than the continuous infusions which was mentioned in the above mentioned studies for the major surgeries. So even a retrospective analysis done at CMC Vellore also showed that continuous intermittent bolus factors does cause lesser factor infusion. So our study also had similar results. However, factor 9 consumption was lesser than factor 8 for minor surgeries. So I would like to conclude that low-dose factor by intermittent bolus replacement and surgeries is an effective and feasible option in patients with hemophilia. This strategy reduces the factor consumption significantly and can be utilized successfully in a resource-constrained setting. So more is not always merrier. Even less can suffice sometimes. Thank you so much.
So thank you. That was a very important study, I think, for our country, and I'm happy that you did that. Well, the timing of the bolus, was that, how did you do that? Because you didn't go into the detail about how you gave you gave intermittent boluses.
Yes, ma'am.
So what was the frequency, the timing, how did you?
Based on the factor availability, whether it was an extended factor or whether it was a short acting. So we give, like, say, all our surgeries are planned, ma'am, so we discussed with the team, and before the surgery we do all the inhibitor steroids, everything, and like say if the surgery is planned at 9 o'clock in the morning, so we give the factors at 8 o'clock or 7 o'clock, send the trough levels, peak levels, and see how much is the level, and based on that we decide on the top-up factors. So, and then the next day, for the next day, before giving the next dose, we send a trough level and see if we are at adequate.
Okay, so pretty much how we were doing. The only thing I was puzzled to see that your hospital stay seemed to be a little long. There was one patient who even stayed for 190 days.
Yes, ma'am. That was the one which also got a factor for 1,000 to 35.
One is the dose, so it's very good that we're using less factor. But what about complications? How did the hematoma, bleeding, infection, hospital stay, how does that compare to patients who are on higher dose? Because we tend to use higher doses and we never see long hospital stay.
The patient that was an outlier, ma'am, actually, that one patient, like 190 days and 1,235, he had a complication because he had a pseudotumor, and he already had a bad thing, so it just went on. That's why that, yeah.
Okay, thank you.
Thank you, ma'am.
So anybody would like to ask a question from the audience before I ask a question? So, very good data. But why do you say that it should be a strategy for resource constraint if you think that a less amount of factor actually works? I mean, why is your conclusion for resource constraint? Why is it not for everyone?
We can definitely do it for everyone, sir. I think we should stop
So how would you actually prove that from here? how would you go forward to convince people out of this country?
If we have to give a level 1 evidence, definitely we should do a randomized control study where we do both high dose and low dose. So that will be ideal. So if probably we get enough factors and probably we can go out with a randomized control study and prove that, sir.
Could there be, problems in the data itself about the kind of complications? When we do a retrospective analysis, we many times really do not note several things.
Yes, sir.
Right?
Retrospective studies do.
So before we really say that this is an effective strategy, this is born out of necessity, but before we really do that, maybe in India we should actually do a randomized control trial and then tell everybody why use more. We should be using less, isn't it?
Agree, sir. Agree, sir.
Okay, thank you.
Thank you, sir.
Very good.
Next, I would call Asha Fernandez from Christian Medical College and Hospital, Ludhiana. She is going to speak under the nursing sciences category.
It was a retrospective, unfortunately, the retrospective presenters are doing better than the prospective.
I want to begin with a brief disclaimer that while I have the privilege of working in a healthcare institution, I do not possess the clinical expertise of medical professionals. Today I have the privilege of addressing you on a topic that is crucial, not only within the walls of healthcare institution, but also in countless organizations and industries worldwide. Medicine is a science of uncertainty and an art of probability, said Sir William Osler, also known as the father of modern medicine. So clinical expertise includes multiple cognitive dimensions involving the integration of disease knowledge with verbal and visual cues from the patient and test interpretation. There is also a team effort of multiple individuals involved in the management of the patient and to deliver quality care. The common adage, stitch in time saves 9, aligns with the concept of being proactive rather than being reactive. There is a paucity of studies which examine the cognitive biases that lead to near misses and errors from the clinical unit. So this cross-sectional exploratory study in a real-world hematology-oncology unit is an attempt to categorize, the near misses and errors into phases and factors and to explore the possible cognitive biases that manifest in them. To err is human, but to forgive is divine. How many of us can honestly say that as doctors, nurses, or healthcare professionals, we have never made an error in our careers? When it comes to errors related to human life, forgiveness certainly has a role. However, prevention of those errors has a bigger role. Medical error is one of the most common causes of death. Therefore, disclosure of medical errors, near misses, in a blame-free environment promotes patient safety and forms the base to provide one of the strongest tools towards quality care. We often find repeated errors in our working environment. As part of our commitment to quality care and pursuit of NABH accreditation, near-miss reporting and incident reporting has been initiated to improve our efficiencies, accuracy, and to interact in a more transparent manner. Our department has been collecting near misses over the past 15 years. We often see that similar errors are committed by different individuals at different times, and therefore we sought to understand what shortcuts or problem-solving strategies known as heuristics are leading to these errors. While heuristics can be helpful in speeding up decision-making and problem-solving, they may also introduce cognitive biases. Daniel Kahneman and Amos Tversky analyzed that 95% of our activities are done at a subconscious level, which is called heuristics. Knowing these biases will help us to de-bias and be extra cautious in similar situations. So the objectives of this study was to analyze 105 near-miss reports to find out the factors that led to these errors, the types and the phases of errors, presence or absence of biases, and to classify these errors into the commonly reported cognitive biases. Our secondary objective was to group the correlated biases based on the findings and to describe the interventions planned for the near-miss and errors. The methodology that we used was cross-sectional. We had a total of 116 near-misses, from which we analyzed 105. The inclusion criteria were errors recorded from 1st of May 2019 to 15th April 2020. Exclusion criteria was near-miss errors prior to 2019 were excluded. There is a checklist of 180 cognitive biases by McKinsey, published in the Harvard Business Review. We looked at 20 common biases in medical practice, which contributed to our near misses, and we retrospectively analyzed the errors. We classified them into types of errors and biases, and these are our results. Active errors outnumbered latent errors, with execution phase errors exceeding planning phase errors. In execution phase, lapses accounted for 54%, while slips 46%. This is a summary of our finding. Active errors, we had 91 of them, and latent 14 in the 105 sample size. Phase of errors, execution phase, we have 81, and planning phase, we had 24 phases of errors. And execution, we had 44 lapses and 37 slips. The top corrective measures that we employed were discussion with the individuals, we made text checklists, and we provided education and training. These were the top types of top interventions that we provided for the staff. So what is our usual response when we face an error? Do we get depressed? Do we scold our colleagues? Do we blame somebody else? What we should not do. We must refrain from the above. Encouraging and reporting is essential for promoting a culture of safety and transparency. We wanted to understand the biases that contributed to our near misses, and we retrospectively analyzed them to remove the bias blind spots and to provide debiasing strategies. So why is near-miss error reporting so important? It helps us to not only look at the surface level, but dig deep inside to identify the root causes. It helped us to make policies and process improvements, to have systematic healthcare risk management, and to the continuous quality improvement, which is iterative in nature, where we receive feedback and data, and we provided better training opportunities. And the common errors that we encountered were these. These were the top common biases that we encountered, mostly confirmatory, responsibility diffusion, and availability biases. The algorithmic approach that we used to analyze the errors were stating the problem, identifying the content, root cause analysis, classification of the near-miss errors, identifying the possible cognitive biases which led to the error, and determining the preventive course of action. Typically, we have every Wednesday we have the consultants, nurses, physician assistants, lab technicians, and administrative staff meeting to have a discussion around the near misses. We encourage anonymous reporting. We take a non-punitive approach. We facilitate understanding of the bias. We do a root cause analysis. We involve multidisciplinary teams, and we continuously refine our reporting. This is the root cause analysis tool that we use to audit our near misses. We also use the DOMAIC data-driven problem-solving technique to identify the root causes. This is the near-miss form that we use to capture the near-misses. I have a few forms if you're interested to take a look. The steps taken to minimize the errors: orientation classes, regular tests, in-house education, weekly meetings, establishing new protocols and minimizing label-related errors, lookalike medicine, stopping of the lookalike medicines. And in conclusion, yes, it is our job to try and make less mistakes, but can we also celebrate that precious moment when someone makes one and shares it with a colleague, and it avoids a major catastrophe? That's the fundamental change that transforms our institutions on a journey of continuous improvement. All that it does, we need to move on from this negative culture of perceiving mistakes as bad, deserving of punishment, and stop building systems to reform and compensate for it. All that it does is resist what's natural and bury valuable opportunities for improvement. So let's aspire for an open, engaging culture at work instead of an unrealistic vision of future where everyone behaves like flawless robots. That's an impossible fantasy. Kahneman and Tversky knew it, and now you do too. Thank you for your attention.
So that was a very original and very important study. I mean, we are all afraid of mistakes and errors and the near misses. So just a question. So you found more mistakes in the executive phase rather than the planning phase. So does that mean people plan better? I just thought that was an interesting finding. So they're good at planning, but their execution is wrong.
Yeah, so they're working at a surface level, at a spinal level, where they don't really think much, and they probably
But I would have thought that that would mean that the planning is not good, because they're not planning, they're just acting. I mean, maybe we can discuss this later. That sounds interesting.
Yes.
Can occur in either of the two phases. That's not an issue. I think the important thing is that you are talking of self-reporting more than an auditing.
That's right.
Right? Is that correct?
That's right.
Yeah.
We encourage people
So
to self-report.
the question that I have for you is, how do you know that this self-reporting is not less than the errors that have actually occurred?
It's definitely not 100%, but what is important is that we permeate that culture across the institution, having these open conversations, encouraging people to, share their flaws and share their mistakes. Once you give them that environment, when they know there's no punitive action following it, it encourages them to be honest.
So you think over the time, self-reporting has actually increased?
Absolutely, it has increased.
Is that right?
Yes, it
okay.
does.
So that's one way to say that more people are now coming up with the mistakes that they made. Otherwise, it would be difficult, isn't it?
Yes. At the near-miss discussion, we do not mention any names. No names are mentioned. It's just the error that is discussed.
Okay, thank you.
Any questions from the audience? Yes. Yeah. It's a new topic for all of us.
Yes. I'm just curious, do you communicate even the near misses ever to the patient or their family?
No, we don't. Thank you. Thank you, sir. Thank you, madam.
Sorry.
Next, we'll begin with a category on malignant diseases of laboratory studies, for which I would like to call Dr. Shelly Singla from PGI Chandigarh.
He thinks a lot. I don't know how he has the time to think.
Good afternoon, everyone. Topic of my study is the impact of TP53 deletions and mutations in the outcome of newly diagnosed multiple myeloma. This study is done in Department of Hematology along with the Department of Clinical Hematology and Medical Oncology, PGI Chandigarh. Multiple myeloma, as we know that it's the second most frequent hematological malignancy, and the genetic landscape in myeloma is complex, which includes various numerical and structural abnormalities. And there are various risk stratification systems. Most of important are RISS, which has been upgraded to R2ISS, and the M-SMART classification. Both of these stratification system includes the TP53 aberrations. And there is a big study which was done by Walker et al. They have also defined the biallelic TP53 inactivations as a very poor prognostic marker. So it is increasing evidence to suggest that TP53 mutation testing in myeloma, but however it is not done routinely in the most centers of India. Rationale of our study was to detect the TP53 deletion and mutations in myeloma, but the true biallelic nature of the mutation in patients with multiple variants is difficult as to determine whether they are on the same allele or the mutation and deletion are on the different allele. So as the international consensus of classification has used the term monohit and multihit rather for the biallelic TP53 aberrations, we have also used the term monohit and multihit. Monohit includes the monoallelic deletion or TP53 mutation, and the multi-hit includes presence of more than one TP53 mutation regardless of VAF, one or more mutation accompanied by the deletion or monosomy 17, or VAF more than 55%. Aim of our study was to determine the frequency and outcome of mono-hit and multi-hit aberrations in the Indian cohort of the newly diagnosed myeloma samples on the plasma-enriched samples employing FISH and targeted NGS. It was a prospective and retrospective observational study done on 457 myeloma cases over a period of 47 months. And the FISH analysis was performed on the immunomagnetically separated plasma cells, and the probe for TP53 deletion was used, which included 17p13 and centromere 17. And the mutation testing targeted NGS was used. In-house AMPLISEQ for Illumina custom panel was designed, which included 24 amplicons covering all the exons and exon introjections of the TP53, and variants were identified in the various TP53 mutation databases. And the amplicon mean coverage less than 250, alternate allele depth less than 10, and VAF less than 3%, and variants in the area with the strand bias were excluded from further analysis. And the stats were performed using SPSS, and various appropriate statistical tools were used, and the patients were followed up for minimum of 6 months, and progression-free survival and overall survival were estimated using Kaplan-Meier methods. And in the results, the patients were, the mean age was 60 years, and the 39.6% were female, and 32 to 8.8% patients presented with circulating plasma cells in the peripheral blood, and 7.9% patients had plasma cell leukemia. And when we re-stratified these patients, maximum patients presented in ISS 3 category, R ISS 2 or R2 ISS 3 category. And coming to the deletion part of the 17P, 12.9%, 59 cases were identified with TP53 deletion, out of which 9 cases had the monosomy of chromosome 17, and the 5 and 2 cases had the tetrasomy or trisomy of chromosome 17 with TP53 deletion. And the percentage of cells with TP53 deletion varied from 14 to 95%, and in 44 cases, deletion was present in 60% or more than these cells. When we compared this TP53 deletion with other studies, it was found that it correlates well. It ranges from 8.9% to maximum 18.6% in other studies, and our study has reported 12.9%. And coming to the mutation part, we had done mutation testing on 244 cases, and the median uniformity of coverage was 95.8%, and the mean amplicon coverage was 1,319, and the mutation pathogenic or likely pathogenic mutation were found in 10.2% of the cases. As we can see that 2 variants, we have the 21 variants, 21 cases which has only 1 variant, and 3 cases had 2 variants, and 1 cases has 3 variants. So 2 and 3 variants patients were classified in the multi-hit TP53 abrasion, and more than 50% VAF was seen in the 11 cases, which amounted to 36%. This is a heat map distribution of the various cases with a TP53 mutation positivity. 13 cases had the VAF more than 45%. It was explained by that almost 11 of these cases has along with TP53 deletion, so VAF was more. 7 cases had the deletion, and aneuploidy was seen in the 2 cases, which has 1 case with trisomy and 1 with tetrasomy, and 2 patients exhibited both deletion and tetrasomy of chromosome 17, indicating a relative loss of TP53. This is a lollipop chart for displaying the mutations, and most of the mutations were seen in the DNA binding domain, which is from the exon 3 to 5, and maximum mutations were missense variant mutations seen in the gene. Now coming to the mono-hit and multi-hit TP53 abrasions, we had 244 cases which were on which we have done both FISH and NGS data, and 18% had 1 or more abrasion, and 10.2% has mono-hit abrasions, which included 7.8% with only deletion and only mutation in 2.4 cases, and multi-hit were seen in 7.8% cases. Our study helped NGS testing aided in identifying 10 patients that would have been missed by FISH testing alone, and among the cases with TP53 deletion, 44% cases exhibited mutation, and 60% cases with mutation had coexisting deletion. This is a comparison of characteristics of the patients with abrasion and without abrasion, and in this thrombocytopenia and the circulating plasma cells, 1Q to 1K and high-risk translocation was significantly present in the patients with TP53. And while comparing the studies with the other studies which had done the TP53 deletion and biallelic activation, we saw that our study has a comparable data. And coming to the survival and outcome, we have the survival and outcome for 309 patients, and multiple drug therapies were given to these patients, and patients with deletion had significantly lower survival, and but in these patients 44% cases had along mutations, and in the similarly it was seen in the mutation patients had poor survival, but in these 60% cases had deletion. So it was not clear that whether mutation is affecting the survival or deletion, as most of the studies studies have overlapping data. So we compared the mono-hit, multi-hit and the wild type. We saw that mono-hit and multi-hit has a poor survival rather than the wild type, and the mutation has significantly lower OS and PFS. So our study was concordance with the study reported by Lord et al. But one possible reason for disparity among the mono-hit and multi-hit in our study was that in our study most of the cytogenetic abnormality 1q21 gain was seen in 48% of cases, which affected the prognosis. And our study was done during the COVID time, during which the patients were recruited. And on the univariate analysis, we found that hazard ratio for mutation and deletion was significant in the TP53 in the both progression-free survival and overall survival. And when we compared the deletion with the RISS, it was significant. So we tried to compare the mutation with the multivariate analysis through the RISS stages, and we found that mutation retained its significance even in the presence of RSS 2 and 3 for overall survival. To conclude, this is a single center study from India which reports the frequency and outcome of mono-hit and multi-hit aberrations in the large cohort of NDMM cases. We documented significantly poor OS and PFS associated with mono-hit and multi-hit aberrations, which is worse compared to data from other centers in the world. OS and PFS was significantly poor in patients even with TP53 mutation without the deletion. So to detect the additional cases with aberration as well as with poor survival associated with the presence of mutation alone, we support the routine mutation testing in NDMM cases. Thank you.
Okay, good data.
Thank you, sir.
Any questions from the audience before I ask something? So you would suggest that all patients with multiple myeloma should undergo NGS testing?
Yes, because only when we see the deletion part, there are many cases which in deletion was not there and mutation was there. So when we risk stratify them according to the M-SMART classification, they will come into the poor prognosis, and our patients also came into the poor prognosis. And in our study, mutation has even more poor prognosis than the deletion.
So, but is it feasible for us to actually do it? And can we actually think of an alternate strategy?
So
you do a FISH, those who are negative only, then you take for NGS. Would you do an NGS upfront?
So if we'll do FISH, we'll only get the TP53 mutation and they can be labeled as mono-hit. But if we'll do the mutation testing, we will come to know that as mono-hit or bi-hit, and bi-hit has a more poor prognosis, so it should be done.
No. So the question is basically that if you get it on FISH, do you need to go to an NGS?
Yes, so we need to go because most of times then we can differentiate between the mono-hit and the multi-hit. On the FISH testing only, we can't determine whether a mutation is present or not.
Would you then advise not to do FISH?
No, we advise FISH is important, but along with that mutation is important, mutation testing.
You know, you have limited resources. Even in PGI, it would be difficult for you to offer an NGS to everyone.
So we
or offer both FISH and NGS to everyone. So would you actually consider certain subset of patients in whom you must do it? Because ultimate idea is to help the patients, isn't it? I mean, apart from a study, it's a good idea for us to know what is the landscape. But if you were in a hospital which is getting about 500 patients of multiple myeloma, your strategy would be what? What would you tell me to do? I'm sitting in a hospital outside PGI, no NGS available. Should I send everyone for an NGS now?
So we have to see like the other risk factors of the patient, like age and other cytogenetic abnormalities.
So maybe, you go back to your data, you see who are the patients who are more likely to have this, and say that if you have these, you must go for NGS. We'll miss some, but that's the only way to go about it. We can't, I mean, in a scientific environment, it's absolutely fine to say this. In a practical environment, sometimes you need to change, isn't it?
Yes.
Thank you.
Thank you, sir.
Next, I would like to call Dr. Sonali Mishra from All India Institute of Medical Sciences, Rishikesh.
It's her work is important.
Good afternoon, everyone. I am Dr. Sonali Mishra, Junior Resident, Department of Pathology and Lab Medicine, and I come from All India Institute of Medical Sciences, Rishikesh. And the topic of my presentation today is estimation of measurable residual disease in multiple myeloma patients by Euroflow-based next-generation flow cytometric assay. So first to begin with, as we know, multiple myeloma is characterized by neoplastic proliferation of the plasma cells, wherein the plasma cells secrete abnormal amount of abnormal immunoglobulins that get deposited and produce signs symptoms in the patients. Measurable residual disease is the lowest level of the disease that is detected post-remission by using a high sensitivity technique. In case of multiple myeloma, the IMWG criteria for negativity of MRD is defined as the absence of even a single number of clonal plasma cell or a neoplastic cell when 10 to the power 5 number of cells are, surveillance of 10 to the power 5 number of cells are done. Flow cytometric estimation of MRD is based on differentiating the monoclonal plasma cells in a background of polyclonal plasma cells by using a panel of surface markers and few cytoplasmic markers. The main objective, as I said, of our study was to estimate the measurable residual disease by using the Euroflow-based next-generation flow cytometric approach. The materials and methods were, we had quite a small sample size, only 20 newly diagnosed multiple myeloma cases were enrolled. Baseline investigations as recommended by the IMWG were done, which are listed above. That included the CBC, RFT, serum electrolytes, imaging studies, serum protein electrophoresis, serum-free light chain assay, and the fluorescence in situ hybridization. After this, the patients received first 4 cycles of induction chemotherapy of anti-myeloma drugs, and then MRD was performed on this patient. Flow cytometric MRD was performed on these patients. The results are as follows. Amongst the CRAB features, hypercalcemia was seen in 30% of the patients. Most of the patients, as we see, presented with anemia and bone lytic lesions. The percentage of patients presenting with bone lytic lesions is 95%. On immunofixation, IgG kappa cases were the maximum, that is 45%, and IgG lambda 20%, IgG A subtype myeloma 20%, and light chain only myeloma 15% of the patients. On performing FISH, the most common cytogenetic abnormality that we found were the deletion 13q14 in 20% of the patients, and one patient, that is only 5% of the patients, showed deletion 17p, gain 1q, and translocation 1114. The flow cytometric estimation of MRD was done, and in 60% of the cases, that is a total of 12 out of 20 cases, MRD was positive. The panel of antibody that we had used, as I said before, was the 8-color 2-tube Euroflow-based flow cytometric approach, wherein tube 1 contained the surface antibodies and tube 2 contained 6 surface antibodies and 2 cytoplasmic antibodies, namely cytoplasmic IgG lambda and cytoplasmic IgG kappa. Now, the backbone of our study, the main antibodies used for gating were the CD38, 138, and CD45, as I will explain further. So this is one of the charts of one of the most representative cases of our study. As we can see in tube 1, for gating, we have used CD38 and CD138 to gate the number of the entire plasma cell population. Then we have used CD45. We have done a backgate and used CD45 to differentiate the leukocytes from the plasma cells. The most important antibodies, as here we can see over here, are also CD56 and CD19, wherein CD56 shows bright positivity and is present in the monoclonal plasma cells, and CD19 is negative. Also, CD81 shows very dim expression as opposed to the normal polyclonal plasma cells. And in this shot also we can see the CD56 is bright positive. Now, to further subcategorize the restriction of the cases, lambda, kappa and lambda plots are depicted over here. In this case we can see that most of the cases, the red cluster over here that is marked as P1 is the lambda restricted cases. So this is the tabulated version of the same antibodies that we have used, and here actually I have put it here to show the most significant antibodies that were deterministic in our study. CD56 and CD19 were the most significant antibodies, as CD19 gave us helpful results in 92% of the cases, and CD56 showing aberrant expression positivity was positive in 66% of the cases. So basically in discussion, the advantages of flow cytometry is that it is applicable in almost 100% of the cases. It has a very low turnaround time and no baseline profile for malignant plasma cells is required. The same antibody panel can be used for diagnosis of MGUS and smoldering multiple myeloma as well. Detecting the MRD helps us to predict the treatment-free survival and the overall survival of the patient. And then it also helps in risk stratification and identifying the candidates for autologous stem cell transplantation. Basically to conclude it again, CD19 and 56 are the most important antibodies, with 19 showing positivity in 95% of the cases and 56 showing positivity in 67% of the cases. And also CD68-1 was also substantially helpful, and it was underexpressed in 33% of the cases. So these are my acknowledgements. I would like to thank Dr. Shubhajit Hajra, who is a DM candidate in our hospital, who has given a part of his thesis to me to present over here, and also the respected faculties of our department. And also, I have a little time left, so it would be wrong for me to not thank the organizing committee over here for promoting my oral poster into an oral presentation. Thank you.
So, good data, but how many of your patients went into CR at after four courses of treatment?
Yes, sir. Actually, because of the time constraint, I have not included that data over here. But on our study, 67% of the patients who had gone into CR and stringent CR were positive for MRD, sir.
So you had a very small number of patients, right, to begin with?
Sorry, sir?
Your total number of patients was 20-something.
Just 20, yes, sir, 20. We are continuing.
How many of them were in CR at the end of 4 courses of treatment? And what was the treatment? Triplet?
So the technique was the IMWG criteria.
No, the chemotherapy.
The chemotherapy was triplet, it was standard for everyone?
Sorry, sir? Yes, sir. The baseline of standard was followed for every patient. And as I said...
Same treatment was used for all these 25 patients?
All the patients did not receive the same treatment. Most of the patients, they received the KRD and the CRD regime.
KRD as a first line?
Sorry, sir?
KRD as a first line?
Yes, sir.
Okay.
VRD was the first and then the KRD later. Most of the patients received VRD.
VRD, okay.
Yes, sir.
And at end of VRD, at 4 weeks, how many were in complete remission, CR?
So that data actually I have not included over here because it was outside of scope.
So then why would you, actually my question is basically, why would you do an MRD if you have not actually achieved a CR? You would do an MRD if a CR has been achieved.
Yes, sir, of course. We did the MRD after the CR was achieved, but because of the time constraints, I have not included that data over here.
You know, achieving CR at 4 courses with a usual triplet is difficult. So anyway, that's okay. Thank you very much.
Thank you, sir. Thank you.
So now we come to the last session, and that is on benign diseases laboratory studies, for which I would like to call Namrata Singh from PGI, Chandigarh.
Good afternoon, everyone. Today I am presenting my work on NGS-based analysis of the genomic landscapes of beta-globin gene cluster, the beta LCR, and the HbF modifiers that yields new phenotype regulators and diagnostic data on the symptomatic beta thalassemias. So it is an attempt to generate, to identify new molecular identities which can differentiate the beta thalassemias, severity of the beta thalassemia, as it is an enigmatic disorder. So I'll be presenting. I'll be presenting my results one by one. So in the first objective, we compare the genomic landscapes of transfusion-dependent versus non-dependent beta thalassemics with similar primary genotypes. These groups consist of the 52 cases which were homozygous for IVS-15, and rest of the remaining 50 cases were compound heterozygous for IVS-15 with other mutations with beta plus or beta not mutation. The patients in which the clinical phenotype was milder, which was explained by the co-inheritance of alpha thalassemia, or XMN1 polymorphism was excluded from this study, and the selected samples were then subjected to custom NGS using Haloplex HS target enrichment kit. The NGS panel was designed using the extensive literature search, which included the beta globin gene cluster, primary, secondary, and tertiary modifiers which are known to regulate the fetal hemoglobin levels. So for data analysis, we use softwares like HaploView and Plink. The Plink showed the association of SNPs with the clinical phenotype of TDT and NTDT, and we found these four polymorphisms the most significant, which is located on the chromosome number 11, as we can see on this Manhattan plot. So further we look into that if these RSIDs or SNPs are present at any putative transcription factor binding sites which are involved in the fetal hemoglobin switch or erythropoiesis. So we found that all the four RSIDs are present in the transcription factor binding sites which are involved in erythropoiesis, immune responses, or stress responses. This and a part of the analysis was done using in silico tools like FootprintDB, PromoAlgen, and Jasper. So for validation part, we genotyped all the four SNPs in a cohort of 300 phenotypically well-characterized patients. And for the genotyping, we used two techniques, that is CASP and PCR-RFLP. Out of the four polymorphism, the top hit of the Plink data was on both genotype as well as allele frequency-based comparison. These two polymorphism varied significantly between both TDT and NDT groups. Next, we did the validation approach using electrophoretic mobility shift assay to validate our that in silico data, where we found that the DNA and transcription factor binding site get hinders in the presence of these polymorphism. For this, we use the first Plink output using the transcription factor POOF1 or OCT1. And here we can see that in the presence and the absence of the polymorphism, we can see there's a slight difference between the mobility of the band or the DNA and transcription factor site is DNA and transcription factor complex. So this suggests that it is likely a mechanism of action in increasing the HbF levels. In addition to this, we also compared the TDT and NDTs on the basis of the first transfusion and clinical phenotype. Nearly 2,500 markers were generated. Out of these, 71 were significant on significant hazard ratio and probability values, and 17 markers, the most significant was present in the BCL11 with the highest hazard ratio of 103. Next, we did the haplotype analysis using HaploView of the characterization, the beta globin gene cluster. And in this data, we found a strong LD was found in TDT due to homogeneous genotype. And in case of NDTs, a diverse haplotype and was found in mild entity, and a strong linkage was present in moderate entities. So on comparison, 3 tag SNPs were common in both the cohorts. The second polymorphism which is highlighted is also the first significant polymorphism which we got in a Plink data, which is located in the downstream of the HBB gene, hence corroborating its significance as a key differentiator of mild, moderate, NTT, and TDT. In objective 3, we studied the role of HbF modifiers in 30 cases which remain unexplained by conventional molecular assay. So summarizing the results of the objective 3, out of our 30 NTT cases, 20 beta thaltrate had TI presentation due to alpha globin triplication, 1 case with thrombocytopenia had BTT with GATA1 mutation, 1 case each was solved using MLP, and 7 cases remain unexplained, and just helped in provide diagnosis in only 1 case. Next, we did studied the beta thaltrates with high HbF, and we studied the allelic frequency of the known QTLs in this cohort, and we found that the highlighted 4 QTLs had significant higher ratio of the allele, which is known to be associated with the elevated fetal hemoglobin levels. So the most salient conclusions on comparing targeted NGS results from TD versus NTT thalassemics with similar primary genotypes, Plink revealed 4 significant differentially inherited SNPs. Of these, 2 validate on testing a further cohort of 148 TDT and 152 NTT cases. HaploView analysis revealed multiple LD patterns and tag SNPs in TDT and moderate and mild NTT patients of northern ancestry. So the take-home messages are: our application of NGS to Indian beta thalassemia patients reveal novel genetic loci that regulate HbF, unique linkage disequilibrium blocks that distinguish patterns of varying severity and multiple tag SNPs that help identify these blocks. And our next step is to generate predictive polygenic score using the 71 significant SNPs in phenotypically well-characterized thalassemic cohort in PGI. So I'd like to thank the patients and their families and DBT and CSR for funding, clinical and nursing staff, and CSIC for providing the NGS facility, and thank you.
So Pure Lab, anybody would like to comment from the audience first? So good data, I must say. The only thing that we as clinicians would like to know later on is the differences between so-called non-transfusion dependent and transfusion dependent, and which would be the factors that are responsible, isn't it?
Yes, sir.
So it would be important for us to categorize those.
So this is a basic research study which can be further utilized for clinical translation. So these are the 4 SNPs which we got from the Plink data. We studied.
I agree with you there. I am only saying that how do we utilize this information? So Prashant, we have patients with a hemoglobin of around 12 and a high RBC count. So what do you think about these individuals? Microcytosis, a near normal hemoglobin and high RBC counts. How would you analyze them?
And a normal HPLC, I presume.
Yeah.
So they most likely have alpha thalassemia, sir. Mostly we do nothing, except sometimes we like to exclude latent iron deficiency, because that can happen even, I'm guessing that's also been excluded. In India, alpha thalassemia is the alpha plus type. No further actions usually needed, not even the molecular confirmation of alpha. I know in private they get it done a lot because patients may be anxious, or sometimes they need medical clearances, and those indices have to be explained. But
so, okay, the thing is that we don't even do an HPLC many times when patients have normal hemoglobin. So I am putting it forth that if you have high TLC, microcytosis and a near normal hemoglobin, maybe it's time for us to look at these individuals and see whether they are a slightly different phenotype.
And HPLC would be mandatory because finding beta thal trait would be of genetic importance. We'd need to then screen their partners.
Thank you. Thank you very much.
Thank you.
Now for the last talk of the session, I would like to invite Dr. Nitya Parvati from PGI Chandigarh.
A very good evening, everyone. So our prospective study tells about how APTT clot waveform analysis is helpful in differentiating LA positive samples from hemophilia A samples. So we know that coagulation pathway is comprising of intrinsic and the extrinsic pathway, which then activates the common pathway, and APTT tells any aberrations in the intrinsic pathway and
Some technical problem.
They are operating. So intrinsic and extrinsic pathway will in turn activate the common pathway, and APTT tells any aberrations in the intrinsic pathway and the common pathway. So clot waveform analysis. So in a simplified version, when a light passes through a sample, a slope is getting generated inside an optical coagulation analyzer. So the clot waveform is a slope generated by the optical detection system using the coagulation test. So there are 2 different types of curves which is possible by using an optical coagulation analyzer. One is the absorbance curve and another one is the transmittance curves. So when light passes through a sample, the absorbance of the sample will reduce, whereas absorbance of the sample will increase, whereas the transmittance will reduce. So in our coagulation analyzer, we tested the transmittance samples, and 3 waves are generated. One is the clot signature curve and the 2 derivative curves that are first and the second
derivative curves. So the first derivative curve tells about the velocity of clot formation, and the second derivative curve tells about the acceleration of clot formation. In this study, we have used ACL top 500 and 550 coagulation analyzers. So the patients are categorized into antiphospholipid antibody syndrome based on the Sydney criteria. The patients are supposed to fulfill one of the clinical criteria and one of the laboratory criteria. So the laboratory criteria included here presence of any one of the lupus anticoagulant, that is LA, anti-cardiolipin antibody. It can be anti-beta-2 glycoprotein antibody, and the test has to be performed twice at an interval of 12 weeks. And so in a nutshell, presence of any lupus anticoagulant will prolong the APTT, and further we can see the APTT changes in the clot waveform. So while initiating the study, the questions in our mind were, can we able to differentiate a LA positive sample from a hemophilia sample with and without inhibitor? In literature, there are sparse evidences to support our study. This is the first Indian-based study to study the relationship between LA positive samples and hemophilia A samples. So our aim was to assess whether this APTT clot waveform analysis quantitative parameters can differentiate LA positive samples from the hemophilia A category with and without inhibitors. And the other part of the study also included the qualitative parameter. For a time constraint, I am going to explain only about the quantitative parameters in the study. So this is a prospective study conducted over a period of 1.5 years, and 136 samples were recruited. In addition, for comparison, we have included 36 hemophilia A samples without the presence of inhibitors, and 16 hemophilia A samples with presence of inhibitors were also recruited. So the APTT and LA testing were performed using the fully automated coagulation analyzer ACL top. So the quantitative parameters which we studied are 10 totally. They are 1A, 1B, 1C, and here the computer will display only the graph, that is the three graph. One is the fibrin formation curve, first derivative curve, and the second derivative curve. By moving the cursor, we then analyze all the 10 parameters manually. Statistical analysis were carried out using SPSS software, and the groups were compared using chi-square test. Moving on to the results. So a total of 136 LA positive samples were included, and they were further classified into LA positive and LA negative category. The LA positive were further subdivided into APTT prolonged and APTT normal. So we have included 52 samples in our study, and further they were compared with the comparison group. So on comparing the LA positive samples with hemophilia A group without any presence of inhibitor, we found that these 4 parameters, which I have told 10 parameters we can see, these 4 parameters can differentiate these two groups, and we can see that that is 1A, 1B, 1C and 2B. These 4 parameters were significantly prolonged in the HANI group, that is our hemophilia A without inhibitor group. They have significant prolongation of these 4 parameters. On comparing LA positive samples with the hemophilia A with inhibitor group, we found that there are 7 parameters which could differentiate these two categories. Those are parameters like 1A, 1B, 1C, 2B, 2D, 3B and 3C. These 7 parameters are significantly prolonged in our hemophilia A samples with inhibitor. So we went one step ahead and did a multivariate analysis where we tried comparing all the 3 groups together. So these are the parameters in the fibrin formation curve 1C and 2D, which were significantly prolonged in the HAVI samples. And similarly in the first and second derivative curve, these are the parameters like 1B and 3C, 1A, 2B were significantly prolonged in the HAVI samples, then the HANI samples, than the LA positive samples. As I said already, the part of study also included qualitative parameters. In order to differentiate these 3 groups, a shoulder in the first derivative curve, which we can appreciate here, and a biphasic pattern is significantly seen in the HANI samples. So, APLA patient present with either moderate to marked prolongation of APTT, and similarly HAVI and HANI also causes APTT prolongation. However, routine coagulation analyzer fails to differentiate this. So, while starting the study, we had two questions in our mind. Can we differentiate LA positive samples from HAVI and HANI group? Yes, by using 4 parameters, we can differentiate LA from HANI group, and by using 7 parameters, we can differentiate LA positive samples from the HAVI group. These are my references. Thank you so much.
So can you have patients who have hemophilia A and a prolonged APTT due to the APLA? Did you have any patients who had both, or you only had like?
No, ma'am. We exclusively selected separately APLA patients and hemophilia A patients.
Okay. If you had both, would you be able to differentiate?
We didn't have any patient included under this study. We haven't categorized them. Only the patients exclusive of having hemophilia A and APLA are segregated.
Okay.
So very good data. How frequently would you need to do this in the lab?
APLA testing, sir?
No, distinction between APLA and hemophilia using this test.
See, because we have other tests also.
It's a good idea, but what I'm trying to say is the utility of this data in day-to-day practice.
Yeah.
So if you are practicing laboratory hematology, if you had a prolonged APTT, would you first ask for a patient's history and then decide whether you want to do something, or would you just do this test and say this is either of the two?
So this APTT is generated on a routine coagulation assay. When a sample has been fed into the analyzer, APTT waveform is generated. So if we see a waveform like this altered parameters, we can suspect that this sample might be a LA positive or it might be a hemophilia A sample. But we can suspect.
What I'm trying to say is that basically clinical presentation is so different, you know.
No, but
APLA is generally a disease of the females, and hemophilia is generally a disease of the males. So you will start distinguishing from there. So need for this particular test would be fairly limited. That's the only thing that
So that was why I was asking that question, because sometimes, especially in children, you can have lupus anticoagulant after viral or other infections, and they can be transient, and the difficulty arises in trying to find out if this hemophilia A patient has inhibitors, true inhibitors, or whether this is just a transient lupus anticoagulant that we are dealing with. So that's where sometimes you can get the combination, and that's where we have had problems in our center to identify, is this an inhibitor patient or is this just some viral thing, and this may go away after some time, but at that particular point, if the child is bleeding, you don't have the luxury of waiting, for a few weeks. So there are different scenarios. So you should know the utility of your test and also the limitations of your test.
In a multivariate analysis, we found that inhibitor samples have significantly prolonged while comparing to the without inhibitor group, ma'am, in hemophilia A.
much. Very interesting data. I think we need to generate more data on the clinical application of this particular test. Thank you.
Thank you. So with this, we come to an end of the session. I would like to thank our eminent Professor Tulika Seth and renowned Professor Subhash Verma for judging the session. Thank you with your valuable presence, ma'am and sir. I express my sincere thanks to all the speakers for the truly enriching session. Next, we will start the zonal level round quiz that will be sponsored by Zydus.
Good evening, everyone. So hopefully we'll have an interesting quiz session starting in next 5 minutes. Just give us 5 to 10 minutes to do the arrangements and make the teams seated comfortably, and then we'll start with the quiz. Thank you.
पिक्चर कौन है इधर ले
ऑन कर दे सारे
कहाँ जाएगा
ये क्यों नहीं चल रहा
सब रेडी है प्लेस है इनको चिट्स वगैरह सब लिख ली एक का माइक नहीं आया अच्छा एक बार ही टेस्ट करने दें हाँ हाँ इनके चिट्स इनके हाथ में ठीक है बी रिलैक्स्ड ठीक है इधर ही हो जाते हैं दोनों मिल के ठीक है ना सो ये वाला तुम पकड़ लो तो काम करो इसको पकड़ लेना ये रख लेंगे ये वाला एक काट लेंगे ये तुम्हारे दोनों राउंड में आएंगे अच्छा इधर से ही कर लो वापस क्लिक माउस है वो ठीक है ना ये ऐसे ठीक है ना इसको नहीं मैं यूज़ कर रहा इधर से करना अरे मैं तो इसी से कर दूँगा वो क्लिक All the teams have got their mic, so just test it and just see you're fine with the working of it. So just keep a hand over it before you are going to answer the, when one of you should answer the, question.
We can have the team introduction and
Yeah, just relax. So I think things are in place and we can start with the quiz without much delay. So we'll start with the team A. Each one of you please get up and give your introduction brief. And we can have a round of applause as they give the introduction. So team A is from GMC Srinagar. So please stand up and give your introduction, please.
Hello, I'm Dr. Insha from Department of Medicine, GMC Srinagar.
Hello, I'm Dr. Zafar Hamdani. I'm from the Department of Pathology, GMC Srinagar.
Hello everyone, I'm Dr. Sana Qureshi from Department of Medicine, GMC Srinagar.
Move on to team B, who's from GMC Amritsar. So one by one, you're.
Hello, I'm Dr. Navjot Singh from Department of Medicine, GMC Amritsar.
Good evening, everyone. I am Dr. Tanya from Department of Pediatrics, GMC Amritsar.
Good evening, everyone. I am Dr. Parampal Singh from Department of Pathology, GMC Amritsar.
Thank you. Next, move on to the team from...
Good afternoon, everyone. I am Dr. Piyush from Department of Medicine, Pgi-Hem-Onc Fest.
The Rohtak team, team number C, yes.
Good afternoon, everyone. Myself, Dr. Nitin, from Department of Internal Medicine, Pgi-Hem-Onc Rohtak.
Good afternoon, everybody. Myself, Dr. Preeti Punia, Department of Pathology, Pgi-Hem-Onc Rohtak.
Next, we have a team from Tanda, Himachal Pradesh. Yes.
Good afternoon, everyone. I am Dr. Naveen, Junior Resident Pediatrics, Dr. RPGMC Tanda.
Good afternoon. Myself, Dr. Nandita, Department of Pathology, Dr. RPGMC Tanda.
Good evening, everyone. I am Dr. Tanya Thakur from Department of Medicine, Dr. RPGMC Tanda. Thank you.
And team E is from AIMS Rishikesh. Yes.
Hello, I am Dr. Samiksha Thapa, Department of Pathology, AIMS Rishikesh.
Myself, Dr. Prabhat from Department of Internal Medicine, AIMS Rishikesh.
Myself, Dr. Gajendra, Department of Pathology and Medicine, Laboratory Medicine, AIMS Rishikesh.
We have our quiz scorers from Dr. Shelley and Dr. Shivani, and Parminder will be looking after the time. And we have the volunteers here, Minakshi, as well as Sharun and Sangeeta will be looking after the chit collection from the teams and the audience questions. And I'll request Professor Inadas ma'am and Professor Neelam Verma ma'am to be around for any discrepancies. They are the ones who are the experts. So we'll hand it over to them and their decision will be final for whatever questions, right? So we move on. I'd also like to thank the state coordinators because without their help and coordination, I think we wouldn't have reached here. From Jammu and Kashmir, my special thanks to Dr. Afaq Ahmed Khan, who was the state coordinator. From Punjab, Dr. Gargi Kaparia. From Haryana and UT Chandigarh, we had a team of Dr. Sudhir and Dr. Praveen, and was ably supported by Dr. Charan Preet, Srinivasan and Adya. And from Himachal Pradesh, Dr. Pooja, and from Uttarakhand, Dr. Priyavardhana. So thank you to all of them. Without their help, we wouldn't have come so far. So these are just the brief rules. I'll just go through them for the teams. So you keep your mics on mute, except for the team who is being asked the direct question. The respective team that is being asked the question should discuss amongst themselves, and a final answer should be given by a single member. Chorus will lead to no marks for the particular question. There shall be 6 rounds in total, with 2 direct questions in some of the rounds and 1 direct question in the next 3 rounds. The rounds would be as follows, and as I go through the rounds, I'll brief them. So there'll be rounds on histories and mysteries, hematology spots, clinical hematology, laboratory hematology, transfusion medicine, and rapid fire. So the details on marking of each round shall be briefed before the start of the round. And obviously the decisions of the seniors here will be the final one, and team numbers ABCD as we have already selected from the draw of lots. There are also brief rules for the audience, and I'll request them to keep their mobile phones on silent and avoid getting up or going out repeatedly and not speaking in between, at least for the answers for different direct questions for the teams. There are audience questions at the end, and you'll get a fair chance to give your answers. So, and keep up, guys, your claps after each correct answer for each of the teams to encourage them. And may the best prepared team win. So, if all is good and well settled, I think we start with the quiz. Yes, teams? I need your yes thumbs up. All good? Yes. And scorers? All fine? Yes. So, we begin with the zonal round, North Zone round of the quiz. And the first round would be on histories and mysteries. So there would be direct question to each team, and each question will have 3 clues. So if you get it right on the first clue, you'll get plus 30. So you can wait for 10 seconds or tell me to show the second clue, and I'll show the second clue if you are unable to answer within that time frame. If you answer on second clue, you get plus 20, and so on. If you get on the third clue, plus 10. If you are unable to answer within that time frame, there is no passing, no chits to be collected in this round, and there's no bonus question. So we'll move serially starting from the team A, and you have the following options to choose from. So we'll have 2 rounds of 5 questions each from each team. We'll start from team A to E, and then from E back to A, and each of you get to choose from each of these topics being displayed. but the topic which is once chosen will not be available for the next team. Right. So we'll start with the team A. So you have the options. Just let me know which one question would you like to have from. Yes.
We'll choose celebrities of films and hematology connection.
Okay. So we're going to celebrities and films. So your first clue for this is, one amongst this celebrity couple was diagnosed and treated for a hematological condition. Name that condition.
Multiple myeloma.
Excellent. So plus 30 for them. And you can tell us whom amongst them? So whom amongst them? Kiran. Yes. Absolutely. So plus 30 for team A for getting it right on the first clue. So these were the other clue. So you want the bonus question? So, okay, sorry, this round doesn't have the bonus, sorry. So we'll go back next to the team B. So celebrities is gone, you have rest of it. So which one would you like to have? Just speak out.
Hematological disease or condition.
So this one, hematological disease. Okay, so your first clue on this is, the disease was described as early as 370 BC by Hippocrates and was also called as vampire's disease in medieval period. If you need the second clue, you can say it to me. So the second clue is, this disease can have all patterns of inheritance from autosomal dominant to recessive to X-linked. Want the next clue? Still have a chance. Okay, so the last clue is, the condition hides its name in this color. Come on.
Porphyria.
Yes, so give them plus 10. So this is, I'm talking about porphyria. So also called as vampire's disease way back in 320 BC and has all sort of patterns of inheritance. So plus 10 for team B, and we move on to team C. So now two have, the celebrities as well as hematological disease condition is out. So what would you choose?
Fathers or doing hematology.
Okay, so we move on to fathers or doyens of hematology. So your first clue on this is, identify the surgeon credited with an important discovery related to a hematological malignancy. So you can have the next clue if you wish. Yeah, so second, he served Royal Army UK and during World War went to Kenya and Somaliland, later settled in Uganda and did medical research there. Okay, so last option, try on this. He wrote a book on his research, a sarcoma involving the jaws of African children. Any answer, please? Be a little louder.
Burkitt's.
So you know the full name? Should we give it to them on?
Full name should have been told.
Full name ideally should have been told, ma'am. Should we award 10 plus 10? Okay, so we give plus 10 to them. So this is Dennis Burkitt. So he was the one who, has found the association between EBV and Burkitt's lymphoma. Yeah. So, and we'll move to team D. So, which option?
Hematological disease condition.
So that has been done. So you can't take one which is gone.
Hematological investigation and historical connect.
Okay. So your first clue on this is, which basic and historical investigation is being performed here?
Sahli's hemoglobin. Sahli.
That's incorrect, so I think we'll not be able to take the rest of the clues for you. So anybody from audience? Yes, so that's the ESR, and you could have gone for the next of the clues and maybe you could have picked it up on the next clues easily, right? So never mind. So there's no negative marking for this. We'll go on to the team E. So which one would you like to choose?
Hematological archives historical.
Okay, so we go on to hematological archives historical. So your first clue is, what hematological disorder does this famous painting point out?
Pgi-Hem-Onc.
Excellent. So plus 30 for them. So this is the famous blue people of Kentucky, where this was inbred, and most of them were blue because of the defect methemoglobinemia. Excellent. So we move on back. We'll start it from team E, the second round of direct questions. So we are gone with hematological disease or conditions, celebrities, fathers, hematological archives, and investigations. So rest of the choices are left for you. Which one would you like to have?
Transfusion medicine history.
Okay. So we'll go with the transfusion medicine history. So your first clue is here. So what historical connection does All India Institute of Hygiene and Public Health or School of Tropical Medicine in Kolkata has with transfusion medicine? Next clue? Yeah, okay. So your second clue is the connection date backs to 1942 during the Second World War.
First blood bank.
Plus blood bank of, I'll give it to you, plus 20, first blood bank of India, and the second blood bank of world. So this was in 1942 due to the efforts of UN Brahmachari, who also invented the Kala-Azar medicine and was the founder of this blood bank in Kolkata. So well done, team E. So, and we'll move on to team D. Now your direct question from the remaining options.
Hematology inventions.
Metallurgical inventions. So we've not done this. Okay. So your first clue on this. What is this instrument in relation to hematology?
The clue.
Okay. So second clue is the inventor of this instrument is recognized person with more than 85 patents to his name.
The next clue.
Third clue is this. No prompting from audience, please.
Beckman Coulter.
So I'll give it to you plus 10. So this is a CBC counter or Coulter counter. So invented by Sir Wallace Coulter. So right. So we'll move on now to team C. So your option. So we just left with logos and hematology institute and drug history and hematology connections. Just three, not much to choose. So
logos and hematology.
Okay, logos and hematology. So your first option on this is which hematological organization supports this logo? Need the next clue? So times, yeah. So it was established in 1963 and has its headquarters in Montreal, Canada. It has a member organization in 147 countries and official recognition from WHO. So third clue, the hematological day is celebrated every year on 17th April.
Hemophilia.
So this logo, I want the complete answer for this. What is this logo? I don't want the name of the day. So this logo is for? So we'll give them half marks if everybody agrees. So plus 5 to them. This is World Hemophilia Federation. So their logo. So you need to be specific, but we'll give you plus 5 for that. Right. So we'll move on next to team B. So you have just two options. Nothing.
Drug history and hematology.
Okay, drug history and hematology. So your first clue on this wonder drug acquires its name from Greek word for liver.
Next clue.
Next clue. The first randomized trial for this drug in patients with PE was performed in 1960. Come on guys, now it's relative.
Heparin.
Yeah, so give them plus 20, this is heparin. So team B gets plus 20 and we move on to the last question for this round for team A. So you're not left with an option. So I think we've only left with institute and hematological condition. So I'll open that up for you. So first clue for this is This is St. Bartholomew's Hospital in London. A particular hematological discovery derives its name from this hospital where it was first characterized. Name it, what I'm talking about. So next clue, its presence is rarely compatible with life.
Bart's hemoglobin.
Excellent, give them plus 20. So I'm talking about hemoglobin Bart's. So this is it. So at the end of first round, may I have the scorers to just brief me on the scores for the teams?
Yeah, for in the end of first round, Team A scores 50, Team B 30, Team C 15, Team D 10, and Team E 50.
So great. So everybody has opened the account. That's well done. So we'll have an audience question or two, and then we'll move on to the next round. So the audience trivia. Now you can get energized and answer.
We have a gift for the audience.
So
First,
right.
it will be junior resident.
So this is Ozzy is a 5,300-year-old mummy found in Alps in Italy. The mummy is famous for what thing related to hematology? He is also known as the oldest mummy to have what relation with hematology? Louder? Not really. It's difficult to find myeloma is in his bones. Anybody more guesses? I was also amazed to just look at it. So this mummy has preserved red blood cells, still intact when it was found. So which is something very amazing, even after 5,300 years, has red blood cells in intact form. So if you go up and read the Wikipedia as well as the related articles related to it, so it's really been proved and shown that they were relatively intact for so much longer period. So next question for audience, I think this should be easier for the clinical residents. So 3D image guided series of TMI and TMLI images. So phase 1 trial, the TMI and TLMI in refractory acute leukemias. What is basically TMI or TMLI? Anybody from clinical or the residents who wish to answer? Yes, so give her a big round of applause for that. You get a pen for sale. Thank you. So that's okay. Right. So we'll move now to the round 2, which is a clinical hematology round related with pediatric and adult hematology. The rules for this round are, so there will be case scenario based questions. It could be an image or a clinical finding or a radiological. If you answer correctly on your direct question, you get plus 20 and you have a chance to play the bonus. Do play the bonus because there is no negative marking, and if you get the bonus correct, you get plus 30 for this round. And this round is also a pass round. So all the teams, when I ask the direct question, start writing or scribbling on the chits provided to you. Make it sure you have written your team number over it, and we'll collect the chits if the team fails to answer the direct question correctly, right? Or if they do not answer it within the allotted time. And then your chits will come into play, and whosoever will answer it correct will get plus 10 for that. And you'll get 15 seconds to answer it correctly, the direct question to whichever team it's put up. So we'll start with the team A again back from this round. So again, you have following choices to make, team A. So you can select either of the scenario from this, and I'll start with the question.
We'll start with adult case scenarios, malignant hematology.
So adult case, malignant hematology, so here we go. So this is the history. A 60 male known case of diabetes mellitus 2 for last 20 years and presently being treated for AML induction. Day 3 complains of weakness of legs and paralysis with derangement of sensorium. His CVCS diagnosis is following TLC 1.8 lakh, platelets 20,000. His RFTs are deranged with rising creatinine and uric acid. Name the medical condition responsible for his symptoms.
You are supposed to say the answer.
Be a little loud.
Tumor lysis.
So we'll give them plus 20 for tumor lysis syndrome. Absolutely correct. So you would like to play the bonus? There's no negative marking? Yeah. So I'll go ahead with the bonus question. Name the drug used to treat this condition.
allopurinol or hydroxyurea?
I wanted, no, so I'll have to, so they'll just get plus 20 for this. So it's basically, I was looking for raspberry case as the answer correctly. So anyhow, but you get plus 20 for it, no marks for the bonus. So we'll move on to now team B, your direct question. Which particular option?
Pediatric case scenario, malignant hematology.
Okay, pediatric malignant hematology. So here we go. A 4-year-old boy with complaints of bony pain and weakness with irritability and loss of appetite. CBC shows mild anemia, thrombocytopenia with hepatosplenomegaly. In clinical examination, X-ray reveals the following findings which are below. A PET scan is advised. So what is the clinical diagnosis? Yes, please come with an answer. This time is...
Thalassemia.
Sorry, so the chits, please guys collect the chits and let me know. Just collect it. So anybody from audience now, it's open to... Loudly? LCH, yes, Langerhans cell and histiocytosis. So anybody from audience for the bonus question, name the targeted drug that can be used to treat this condition? Vemurafenib, yes, okay. So I think team C, E and D also I'll give it. So team C, E and D will get plus 10. So they have got it correctly as Langerhans cell histiocytosis.
So again.
Sir, team C?
Team C, team D and team E.
Team D.
C, D and E.
Okay, sir.
So we move forward next to team C. So your options. Quick, please.
Adult case scenario, benign hematology.
Okay, adult case, benign hematology. So your clue for this is 22-year-old female has long-standing history of thrombocytopenia and lymphedema, right leg for 5 years being managed as ITP. Presently also recognized to have neutropenia. Family history is mother died of fulminant atypical mycobacterial infection and sister has recurrent papilloma warts on hands. Likely diagnosis. Come on guys, 15 seconds. Any answer?
Schwarzman-Diamond syndrome.
So chits, please guys collect from. Just a moment, let us collect the chits, then I'll open it up to the audience. No, you'll not get much time for it. You have to write initially, so I'll not take it next time. So you have to write as soon as I start asking them the questions. Otherwise, I'll not consider the chits. So audience, anybody? No. Who spoke back? So I think it was Navjeet, yeah, speaking of, yes, it is. So for development of what condition she is at higher risk of? The bonus part also? Yes, AML MDS, Tushar. Right, so we'll move on next to team D.
Some bonus marks.
Yeah, so team E and this is clear, no. So only team E has got it correct. So they'll get plus 10 for it. So we'll move now to team D. Your options, please.
Coagulation case scenario, pediatric.
Okay. So coagulation case scenario, pediatric, right. So your first clue, 9-year-old female child, left-sided abdominal mass and 2 days history of hematuria and nosebleeds. Workup for mass found to have Wilms tumor. Her CBC is as following. There's no family history or prior history of bleeding, and coagulation screen shows a deranged APTT with factor 8C level 28% with no inhibitors. And she received FFP and cryoprecipitate and underwent Wilms surgical treatment and chemotherapy. Now she has no bleeding episode. So what is the most likely reason for her bleeding? Team D, yes, any answers? Running out of time.
DIC.
Sorry, so can I have the chits, please? Immediately. Meenakshi, just take the chits soon. Yeah. So now it's open up to the audience. Any residents? Yes. Something else? Who said acquired? Yeah, so that's it. So acquired 1 Willebrand Rees. The history is very, very specific. I think we heard us out of there. Yeah. So you will get a chance for the bonus. Anybody? So
both of them.
So let the bonus question come. So what is the hypothesis for this abnormal coagulopathy in Wilms tumor? Now anyone? Any consultants now? So it's the secretion of hyaluronic acids in huge amounts by the tumor, which binds the ultra high or molecular weight 1 Willebrand and leads on to an acquired sort of 1 Willebrand disease in this particular case. So right. So next, let's move on to team E.
So bonus answers for this.
So bonus answers, I think, so no, none of them has got it correct really. So VWD, they mentioned team E, but they have not mentioned acquired, so I'll not give it to them. Yeah. So team E, your direct question. Yeah, but problem, any issues? Yes.
I have wrote 1 Willebrand disease type 2N, which is also a type of acquired hemophilia. Is it
No,
considered for
no, it's not. Sorry. Yes, team E, which options? Hematological toxicity case scenario, right? So
Switch on your mic.
So a 10-year-old boy on BALL maintenance therapy develops severe alopecia and neutropenia with the ANC of just 500, and PBF and marrow do not show any blasts. So what is the likely reason?
Cyclosporine.
So may I have the chits, please? So you have to think about BALL, if cyclosporine, why it's being given, or is it really being given in BALL therapy, and would that lead on to? So can I have anybody from the audience answering this? Any residents?
Excuse me, sir.
Yes.
Yeah. I was just about to explain why he has responded to like this. Like,
So it's not cyclosporine.
Okay.
It's not cyclosporine. Anybody from audience?
Anybody can raise their hand and tell.
Yeah, so it's 6 MP toxicity. So, and this is the bonus question. What is the genetics polymorphism responsible for same? So this is homozygous NUDT. So you encountered it rarely, but when you encounter alopecia, is something which is very striking along with severe myelotoxicity. So next we move on back to team E. Your direct question again, so which one you'll choose? And none of the teams got it correct in the chits.
Transfusion medicine.
Transfusion medicine, okay. So this should be interesting, right. So 20-year-old male develops acute respiratory distress 4 hours after receiving transfusion. He is also noted to have hypertension and raised GVP. Patient is given diuretics and recovers uneventfully. Clinical diagnosis.
TACO.
So tell me the full form also.
Transfusion associated circulatory overload.
So they get it plus 20, absolutely right. So we'll go for the bonus questions. Yes. So name any 2 risk factors for development of this condition. Should be easy.
Underlying cardiac disease or elderly patients.
So that's, give it them plus 30 also. So this is absolutely correct. So you have host of underlying risk factors for it. Elderly, small patients with impaired cardiac, renal, pulmonary function, or oncology patients. So well done, team E. So you get a total of plus 50 for this round. Great. So now a direct question for team D. So team D, which option?
Pediatric case scenario, a benign hematology.
Okay. Pediatric benign hematology case scenario, right? So 11-month-old boy from Maharashtra presents with incessant crying and swollen hands and feet with following CBC. Name the drug which can reduce severity of these episodes.
Hydroxyurea.
Absolutely right. So give them plus 20. So you go with the bonus question? Yes, yeah. Name a landmark trial in relevance to this case which led to use of this drug in children for treating this condition. Any guesses? Come. So we are over the time. I think anybody from audience? Yes, baby egg trial, absolutely right, or Pgi-Hem-Onc or baby egg trial, which led to use of this drug in pediatrics. So anyhow, they get plus 20 for the right answer, not for the bonus. So we move on now to team C, your direct question, your options.
Coagulation case scenario adult.
So coagulation case scenario adult, right. So here it is, a 53-year-old male post-cardiopulmonary bypass on day 7 develops leg pain and swelling. A Doppler confirms presence of DVT. CBC is following with RFT and LFT normal. Your clinical diagnosis. Come on, any answers?
Disseminated intravascular coagulation.
No, so can we have the chits, please? Fast. So now open to the audience. Any residents? Yes. Anybody else? So Narendra has answered it correctly. So it is HITT. So heparin-induced thrombocytopenia and thrombosis. Super. Yeah. So bonus question, a Gatroban used for HIT treatment. So these residents should answer mechanism of action. Yeah, so who said it from direct thrombin? So they're at the back, I think. There, one at the back also, she also spoke, yeah. Okay. So now we move on to direct question.
Bonus answers for this round.
Yeah, so so team B we can give +5, so they haven't mentioned team B. So just written HIT, so I wanted properly HITT as the correct answer. For that you would have got +10, but I'll give you +5 for it. So team B give +5, right? Okay, so team E also +5, so they've also mentioned. Team E and team B, both of them get +5 for this. So now team B, your direct question, you've just two options to choose from: adult case scenario radiology and pediatric case radiology.
Adult case scenario radiology.
Okay, so adult radiology here. So 23-year-old male, known case of severe aplastic anemia, referred to a tertiary center for hematopoiesis. Come on, team B, any answers?
Chits, please.
Chits, please. Fast, please. So I think we
Cardiac MRI to check for iron overload.
No, so it's gone. Your time is gone. You should have been answering it earlier. Anybody from the audience? So this is T2 star MRI, right? And the bonus question would like to answer: what value cutoff below which test is abnormal and suggests iron overload in heart? So anybody remembers the cutoffs for heart? So this is the cutoffs, exactly. So if you have more than 20, it's normal. So 10 to 20, mild to moderate, and less than 10, severe. Okay. So we move on to team A, the last for this round.
So bonus answer for this round.
Yeah, bonus answer is team C, and yeah, only team C +10. Right? Please keep on clapping. I mean, they should feel encouraged and move on to the next rounds. So the last question for this round, so you don't have any options, so I have to go to pediatric case radiology for you. So here is the case. So a 10-year-old male on BALL treatment develops fever, difficulty breathing and cough. CBC shows ANC of 300. A CECT chest is done sequentially over 2 weeks. What is the classical radiological finding due to?
So aspergillosis.
Yeah, so give them +20, very good. So this is what sign on radiology? Any idea? The sign seen here? The
Ball.
So this is a hello sign on radiology, so that's okay. So we move on to your bonus question. You still have plus 30 to get to. What is the treatment of choice? Fast, fast. Loud.
Antifungals caspofungin. Or amphotericin B. Amphotericin B.
So no. So the correct answer, audience, voriconazole is the correct answer I'm looking for. Anyhow, you get plus 20. So big round of applause. We'll give scorers some time for getting the scores right, and we'll move to the audience question. So audience trivia is here. So 50-year-old male presents with fever, weight loss, history of small and medium vessel vasculitis with CBCs following. And during course of investigation, he also develops erythema nodosum over legs. What is the likely diagnosis and what testing would you advise?
35 लिखे ना तूने?
Oh, everybody is so clear to pick up Vexas now. It's great. And what genetic? So it's UBA1 gene, so I think most of you know it now. So great. So whom should we give the... Okay.
We don't have that much.
So we don't have it, right. So can we have briefly the scores? So we have the team standings now.
Team B and C 35, Team D 40, Team A 90, Team E 125.
Okay, so Team E closely followed by Team A, and the rest of the teams also buck up. You still have 3 or 4 rounds to go. So we'll move on fast to the next round, which is recent advances. So here you will get a spot or picture, and it's a one-word type answer. If correct, you get plus 20, and you have a chance to play a bonus. But remember, here the bonus is minus 10 if you get it wrong, but plus 30 if you get it right. And this is also pass round, so all the teams, as soon as I ask the direct question again, it will be 15 seconds. If they fail to answer, the chits come into play, and if you get it correct, you get plus 10 for that. So we'll start one by one from Team E. So Team E, be ready. So here you don't have other options to choose from, direct questions coming to you. So your first question is this: name a recent drug for treatment of this RBC enzyme disorder. Team E. Rest of you can write, because if they fail to answer, then we come into picture.
Team E.
So, okay, no answers. So, okay, so chits come into play, just collect the chits, and then we'll open to the audience. Yeah.
They didn't know it.
No, they knew it. So, no answers from their end. So, anybody from audience? Yes? Yes, excellent. So, big round of applause for her with Abby Pat. She's right in this. And what is the route and mechanism of action of this drug? Sorry. Loud. So I didn't get it. Okay. So I think it's oral route. So excellent. So you could answer that drug. So that's great. So we move on next to Team A. Your direct question. So we're going from E to A and then D in this, right? So Team A, your question is, which entity replaces variant hairy cell leukemia in the new WHO 2022 classification? Any idea about the recent advance? Others can write. Yeah, chits first. Anybody with chits? Nobody. So that's okay. Audience, anybody? One of you. Yes, please stand up and say. Excellent. So just hand over. Very good. So the bonus question, anybody amongst you, name another lymphoma which has been replaced with the same category in new WHO 2022. So I'll give it to her. So you have again answered it correctly. So B pro lymphocytic leukemia as well as your hairy cell variant, both of them have been replaced with the splenic B cell lymphoma or leukemia with prominent nucleoli. So next we move up to Team B, your direct question. Ready? So a 30-year-old male with bicytopenia presents with idiopathic pulmonary fibrosis, and a genetic evaluation by NGS reveals a pathogenic mutation. The clinician labels the condition as TBD. What is TBDs? No prompting from audience, please. Any ideas? Okay, so any residents from, no chits, I think. Yes, so the bonus question, anybody would like to answer? One of you just stand, name the most common gene which is likely to be mutated in above cases. Who answered that? Yeah, you can give it to her. Here, one to Sudhanshi and one at back, both of them. So the common genes usually are the TERT or TERK genes which are related with TBDs. So team C, your direct question. A common issue with use of CAR T cells is development of CRS. What is the treatment of CRS? You can tell me even the mechanism of action, I'll take it, or even the drug name if you know, that would do.
Chits, please.
Chits. So only from one team. So anybody from audience, I think most of them would be knowing. So yes, and mechanism also? Anti-IL-6, yes. Right, so this is cytokine release syndrome. So none of them has got correct. So I think we'll move on to team D, your direct question. So recent advances, guys. So name the physiological erythroid regulator hormone which controls hepcidin secretion. So recently much in, pathophysiological mechanisms, studies on mice models, a lot of stuff going on.
Erythrospondin.
I can't give it to that, Chits. Anybody? So yes, audience. Who amongst the residents answered? You've already got it, I think. So anybody from yes? So team C has got it correct, and team A has got it correct, even team B. So team A, B and C, three of them, they'll get +10 for it. So it's erythroferon. And what's its relationship with hepcidin? It's an inverse relationship. So has erythroferon blocks the hepcidin secretion, right? And so we move on next to team A. So your direct question. PH-like BALL subtype was discovered in last decade based on GEP, similarity with PH-positive BALL. What is GEP? Come on, Timmy. No answers. So, Chits. Yeah. I think audience would like to first raise your hand. So they are there. Yes. Yes. Give it to her. Gene expression profiling there at the back. So team C has got it correct. So +10 for team C. Team C has got it correct. So +10. Great. So bonus question was name any one mutational genetic subclass. I think all of you must be knowing it. So ABL or JAK2, I'll leave it. So team B, your direct question now, right? So we were at team, this was asked to team A, yeah? No, we asked to team A, na? I think.
No, recent question was to team A.
Now it is to team B, your direct. So this is new technique to detect large structural genetic lesions.
Excuse me. This was for A it was, last question. Team A.
No, I think we asked it for just, we'll go. This was for
Team A.
A. That is what we asked. Yeah. So identify, name the technique.
Whole genome sequencing.
So, no. Chits, anybody wants to? So no, not to collect now. So they had to write as it was, being asked. Anybody from audience? So I think all the prizes will go back to those two ladies out there. So
No, we will save them.
Praveen is saying no, we will save them. Right, so what specific type, answer this one, nature of DNA is required for this technique.
Come on.
You can't use a routine extracted DNA for doing this. No. This is ultra high molecular weight DNA. So you need to have separate sort of extraction to get to the ultra high molecular weight DNA. Right. So this was optical genome mapping. So team C, your direct question. Bluebird biodrug, Zintaglo, approved by FDA last year for treatment of transfusion-dependent thalassemia. What form of treatment is it based on? You already have the clue there. Team C, any answers?
Iron chelation.
No, sorry. Chits, please. Again, anybody from audience? Gene therapy. So gene therapy based, that one guy behind Shrijesh, yeah. So what is the underlying vector to transfer the transgene into CD34, sir? Any vector? Yeah, very good. So this is lentiviral based autologous CD34 cell based gene therapy. And from teams, yeah, team E has got it correctly, so they get +10, team E, right? So move on to team D, your direct question. So this is a scatter plot from hematology analyzer. The area being highlighted represents a new CBC parameter, name it.
Dead cells.
So no, anybody chits, please, just 1, 2. So now any residents, hematopathology residents, anybody other than you two? No one? Okay, it goes back to you again. Would you like to answer now? Not really. No.
Any faculty members?
So you've seen above the RBCs and below something? Yes, so these are the fragmented red cells and obviously useful in HUS or TTP conditions. So this is being a very highly sensitive marker. So if it's below a cutoff of 0.5, so HUS and TTP is not there. But if it's less of a specific marker, you need to see a PBF to really be sure if it's there, if it's high. Right, so team E, your direct question.
So bonus answers, anyone?
So none of them. So, no, this is the last one. So last of this part to team E, your direct question. Fitusiran is an important recent breakthrough drug for prophylaxis and treatment in hemophilia. What form of treatment drug is this agent?
It's an antisense therapy, sir.
Yeah, absolutely right. So give them +20. So your bonus, yes. Name the target molecule of this drug. So pass. Anybody from here? So I think it was in antithrombin, so you've not been able to answer that. So I think +20 for them. So that is okay. So yeah. So big round of applause, and till they do the scores, question for the audience. So under what category of WHO classification of hematolymphoid conditions does the following entity appear? Severe mosquito bite allergy. Anybody would like to answer? Excellent. These guys have read everything about the 22 classification. So it's the EBV associated T or NK cell lymphoproliferative disorders. So please give them. So they are answering, so you can give it to them. Right. So any update on the scores?
Yes. So team D scored 40, team B 45, team C 55, team A 100, team E 155.
So it's still a fight between team A and team E. So keep going, team A and team E, and rest of the teams also. There's still 3 rounds to go, and I'll hand it over to my colleague Dr. Praveen here, so he'll take the rest of the 3 rounds. Praveen, please.
Thank you, sir. Thank you, sir. So we take a skydive, and we are going to the basics now. So the last 3 rounds, 2 rounds are of pathology, and 1 round is going to be the rapid fire round. So let's go into the basics, and so here the pathways will be shown to you, and you have to identify the missing links in the pathways. And each direct question has 15 seconds to answer. The correct one gets you 20 points, and if you do not answer or it is incorrect, chits are to be collected from the other teams, and the teams who have got the past answer to be correct get 10 plus marks. There is no negative marking. So we can start from team A. Team A, are you ready? And your direct question is, Identify the pathway and its hematological link. Okay, you have to see the pathway and identify. Your time starts now.
Just look carefully. It's there on the figure.
It's there, and you have to identify the link with hematology.
Come on, Anya.
Chits, please. Chits, please.
This isn't a negative.
Anybody? No negative.
So no negative marking, you should speak out.
Okay, so anybody from the audience, junior residents? Junior residents, anybody? Sorry? Louder, please. Senior residents? Yes, excellent. Neha, it's a link between DNA repair mechanisms and inherited bone marrow failure syndromes. So, so team C has given DNA repair mechanism. The hematological link is not mentioned, so we are not going to give to them. And team E has written checkpoint inhibitor, no. Okay, team B, your direct question. Identify the hidden protein, okay? Look at this cartoon and identify the hidden protein which is in black color. Yeah, this one. You can identify this protein. It's hidden here.
Ferroprotein.
Very good, excellent. Yeah, you get plus 20 for this answer. No chits. Team B.
Team B plus 20.
Okay. Now, direct question to Team C. Team C, what is the RBC membrane protein hidden here? Okay? Your time starts now. What is the RBC membrane protein hidden here? Other teams can write it on the chit, please.
Band 3.
Excellent, round, big applause for them. Yes, you get plus 20 for this. It's an easy round, isn't it? Okay. Everybody should be happy. Okay, question 4. Okay, what is the hidden hemoglobin here? Okay, question to Team D. Team D, are you ready? And the time starts now. Identify the hidden hemoglobin here.
Portland.
Excellent. Plus 20 for you. Team D has got 20 points. Finally, to Team E, this is your direct question. Question 5. Identify the molecule in orange box. You are going to see vitamin B12 absorption here. Identify the molecule in orange box. You can see this. Yeah, what is this protein? You can answer it.
Intrinsic factor of Castle.
Chits, please. Okay, anybody from the audience? Junior residents? Shiv Shankar Naik. Excellent. Haptocorin is the right answer. Anybody other name for haptocorin? Transcobalamin 1. Any other body? Another name for haptocorin? R binder. Excellent. Okay. Any other name? One more name for R binder? Cobalophyllin, okay? Okay. So
3 teams have got correct, A, C, D.
Okay. Teams A, C and D. Okay, all 3 teams get the right answer, A, C, D.
Plus 10.
And they get 10 marks. Okay? Okay, R binder is responsible for protecting the vitamin B12 and taking it from the acid from the stomach. Okay? So you said intrinsic factor, this one, it's written here. Its IF is this one, green. Okay. Okay, yes. So next we move on to the audience question. Okay, first it will go to the junior residents and accordingly. So you can see this is megakaryopoiesis here. The megakaryopoiesis goes from 2N to 64N. What is this happening here? The nucleus. Excellent, okay. Okay. Next question you are not going to answer, only if someone is not answering. Excellent. She mentioned it. It's endo-reduplication that is happening. You see the nucleus is dividing here, but the cytoplasm is not dividing here. Okay, and so that is one characteristic thing that we can see in megakaryopoiesis. Okay, scores please.
Team B 65, Team C 85, Team D 80, Team A 110, Team E 155.
Excellent.
The other team,
Okay.
pick it up. Very good. Pick up. You still have 2 rounds to go. And
2 rounds to go, lots of questions are there to pick up, and we are moving to this next round here now. The round 5 is laboratory hematology and hematopathology round. So here you have 15 seconds for a question, 20 seconds for a correct answer, and similarly as in previous rounds you can see the correct answer opens a bonus question and the bonus question gets 30 marks. If you choose to answer the bonus and you answer it wrongly, you get -10, you can skip to answer the bonus. And that will fetch you just the neutral marks. Pass for the direct question is there and you get 10 marks for the pass question. Okay, all teams ready, and we are going to start with Team E now. Team E, question 1. What is the special stain being performed here? Your time starts now. Can you be louder?
Reticulin stain.
Excellent. So this is the reticulin stain. Do you want to attempt the bonus or not? You're going to get 30 points.
-10.
-10 also.
Yeah.
Yeah, you're going to attend? Okay. Bonus question is, what is the enzyme parameter included in WHO criteria for primary myelofibrosis? What is the enzyme that is there in the WHO criteria? Pass? Okay, you don't get anybody from the audience, not Aishwarya, anybody else. In the minor criteria, it's there. LDH, excellent. Okay, lactate dehydrogenase is the right answer. So this is the enzyme parameter that is included in the WHO criteria. Okay, Team D.
So if
They get only 20. No -10.
they would have answered it incorrectly then.
So if they have answered incorrectly, they would have got -10. So 20 points for Team E then, okay? Team D. Team D, your direct question is, what is the diagnosis here after you see this? Look into the clinical picture and the slide.
Rosai Dorfman.
Excellent, you get 20 points. Okay.
Bonus.
You want to attempt the bonus, very good. Okay, the bonus question is here. Name one familial HLH syndrome.
Speak up, speak up.
Speak up, speak up.
You have it, speak up, you'll get +30.
Time? Okay, you are not going to get it. Anybody from the audience?
Only +50 for them.
Anybody from the audience? First the junior residents, not you two. Griscelli syndrome, excellent, okay. Okay, Griscelli syndrome, Chediak-Higashi syndrome, Hermansky-Pudlak syndrome, X-linked lymphoproliferative disorder, all these are the familial HLS syndromes. Okay, you get only 20 points for this, okay. Question 3 to Team C, are you ready? What is the test that is being performed here? Okay, identify the test performed here. Time starts now. Time starts now. Yeah, you have to say it.
Nestrov's.
Excellent, it's Neftroff's test. They get 20 points for this. Do you want to attempt the bonus question? Yes, okay. The bonus question is, name one condition in which this test is used for screening or diagnosis. Name one condition. If you get it right, it's 30 points. -10 for wrong answer. Excellent, it's hereditary spherocytosis. You get 30 points for this. So total of 50 points for this Team C. Question 4, this is a 45-year-old male. Team B, are you ready? This is a 45-year-old male. What is the diagnosis here? Okay, look at the picture or the microscopic images and you identify the diagnosis. What is the diagnosis?
Who have an accompanying bone marrow failure, who have
Other teams can write it down. Chits, please. Chits, please. Yes. Anybody from the audience? No. Junior. Okay, everybody got that. It's So you see the atypical cells within the blood vessels. Now these cells are highlighted on 20. You see all the B cells within the vessels, and this is 34, which is highlighting the blood vessels. It's intravascular B cell lymphoma. I think nobody has got it right. Okay? Yeah. Okay, the bonus, we are going to the bonus. The bonus is open for the audience. Again, it's junior residents first. Okay, see this 10-year female, liver spleen is present and CD3 is positive. What is this? And what organ is this? Junior residents, anybody? Senior residents? Senior residents? Come on. Excellent. Who said that? Okay, Dr. Tara, yes, it's hepatosplenic T-cell lymphoma. You see the hepatic architecture here, and within these are the cords of cells, cells which are arranged in cords, and all these cells are CD3 positive. So this is hepatosplenic T-cell lymphoma. Okay, I think Team B do not get any points for this. Okay. Question 5 to Team A, are you ready? Yes. What is the test being performed here? Time starts now. What is the test?
Flow cytometry.
You have to be more specific. Condition.
Seeing the markers, the condition.
What is the test being performed here? Which condition is being performed?
Paroxysmal nocturnal hemoglobinuria.
Excellent, excellent. All teams has got it right. Okay, 20 points for you already. You want to answer the bonus? Yes, okay. Bonus question. Look at this image. Urine from this patient is stained and shown here. What is the interpretation? What is the interpretation that you can see?
Link it, guys.
Link it.
Come on with the answer.
You can say it or you can skip it. You are skipping it. Okay, to the audience, please. Yes, so urine is stained for pearl stain here, and it shows hemosideruria. Okay. All right, a big round of applause for all the teams, and we get an A gets plus 20 for this. Okay. I think it's Team C who has got the full marks for this round. Yeah, very good. Okay. So audience question, is the audience ready? So anybody can identify the syndrome or what is happening here? Excellent. Okay. What is this? This is myelocathexis. You can see the abnormal chromatin bridges within this, the thin chromatin bridges between two nucleus. And what is the syndrome? WHIM syndrome. What is WHIM? Very good. Big round of applause for Aishwarya. I think she is single-handedly answering all these questions. Very good. Okay. So at this end of this round, can we have the scores, please?
Team B scored 65, Team D 90, Team A 130, Team C 135, Team E 175.
Okay, so we are proceeding to the rapid fire round now. We'll start with Team A. We have 8 direct questions and 10 marks for each direct question. So I think teams can, lot of marks can be gained here, and yes, absolutely.
Be fast enough to answer.
There is no negative marking. You can pass the question and you can come back to the same question at a later time, but within 60 seconds, scorer to be note. Okay, can you kindly note it? So Team A, are you ready? Yes.
Pass when if you don't know a question, you can go on to next.
Okay.
Keep waiting.
Mic should be on. So we are starting. Birbeck granule is characteristic finding in which condition?
Pass.
The eponym Hempas is used for which condition?
It's congenital dysmegakaryocytic anemia, I guess CD8, erythropoietic.
Incorrect. Another name for CD55. Yes, please. Excellent, correct. Name the CD19 bispecific T-cell engager approved for BALL.
Pass.
Treatment of choice for a patient with anemia with bone marrow showing MDS with 5q deletion on fish.
Pass.
Pass. Infection associated with primary effusion lymphoma.
HIV.
Incorrect. What is P in Pgi-Hem syndrome?
Polyneuropathy. Polyneuropathy.
Correct. Criteria used for assigning probability of cancer-associated VTE.
Khurana criteria.
Correct. Okay, excellent.
First question.
So your time is over. You got 3 correct answers out of 8 and you get 30 points. Okay, excellent team A. You got 30 points for this rapid fire round. Team B, are you ready? Your mic is on. Okay. Team B.
Please pass it on if you don't know and you can come back later.
Yes. Hallmark cells are seen in?
T-cell lymphoma.
You have to be more specific. Incorrect.
Anaplastic T-cell lymphoma.
Yes, correct. Non-lobated or hypolobated nuclei in megakaryocytes is frequently seen in MDS associated with cytogenical abnormality.
5Q.
Excellent. Immunoproliferative small intestinal disease is associated with which microbe?
H. pylori.
Incorrect. CD117 is also known as?
3C jejuni.
No. Name the CD20 bispecific T-cell engager approved for DLBCL.
Bilantuzumab.
No. What is R in Tafro syndrome?
Pass.
Pass. Initial treatment of choice for a patient with cytokine release syndrome post-CAR T-cell infusion.
Pass.
Criteria used for diagnosis for Apla syndrome.
Sydney criteria.
No, incorrect. So your time is over. Hallmark cells are seen in ALCL, non-lobated in 5Q, Ipsid Campylobacter jejuni. CD117 is c-KIT. CD20 directed cell is glofitamab or epcoritamab. Reticulin fibrosis, tocilizumab and Sapporo criteria. Okay?
You've got 2 correct, so plus 20 for you.
Plus 20 for you. Okay.
Sir, 3 का भी आंसर दिया था उसके बाद.
No, you gave it wrong, no? You said H. pylori. Answer is Campylobacter jejuni. Okay.
So big round of applause after this.
Yes, please.
Plus 20 for this.
Team C, are you ready? Yes, Team C. Annexin 5 is a marker of?
Hairy cell leukemia.
Incorrect. Which guidelines are used for stem cell enumeration?
Pass.
Gene mutation pathognomic of myeloid leukemia with Down syndrome. Incorrect. Ocular maltoma is associated with which microbe?
Chlamydia psittaci.
Yes, correct. Criteria used for tumor lysis syndrome.
Pass.
Name a CD19 directed monoclonal antibody used in the treatment of DLBCL.
Say pass if you don't have time. You can move on to the next.
Pass.
Treatment of choice for patient with anemia with MDS and ring sideroblast with FH3 beta1 mutation.
Lenalidomide.
Incorrect. Expand ALPS. I think we can skip it, okay? So, I think they have got...
One correct.
One correct. No, I think it's this one correct.
Fourth one, yes. Okay, they got 1 correct of all 8. The answers are Annexin 5 is apoptosis, I-Shades protocol, GATA1, Chlamydia psittaci, Cairo-Bishop criteria, tafasitamab, luspatasab, autoimmune lymphoproliferative syndrome. Okay. Team D, are you ready? Okay, Team D. Your direct questions are starting now. Drepanocytes are seen in?
Sickle cell disease.
Correct. Morus clefts are seen in?
Pass.
What is the genetic abnormality seen in hairy cell leukemia?
BRAF V600E.
Correct. Infection associated with gastric maltoma?
H. pylori.
Correct. Name a BCMA directed bispecific T-cell engager used in treatment of multiple myeloma.
Pass.
Treatment of choice for patient with portal vein thrombosis with major clone besides anticoagulation.
Pass.
Criteria used for assigning probability of TTP.
Pass.
Expand PTLD.
Post-transplant lymphoproliferative disease.
Yes, correct. Okay, do you want to attempt the past questions?
You had last three pass.
Last 3, 5, 6, 7 are past ones.
Any of those you wish to attempt?
Okay, so they got 4 correct answers. Very good. A round of applause for them. And the answers are sickle cell anemia, Plasmodium falciparum, BRAF V600E, H. pylori, teclistamab, eculizumab or ravulizumab, plasmic score, and PTLD. Okay. Yes. Final, Team E, are you ready? Okay. So the time starts now. Which coagulation factor is called a stable factor?
Factor 10.
Incorrect. What is the genetic abnormality in systemic mastocytosis?
KIT mutation.
Correct. Hereditary form of TTP is called as?
Upsa-Sullman syndrome.
Correct. Infection associated with cutaneous maltoma.
First.
Name a CD79B directed antibody. Correct. Treatment of choice for a patient with hemophilia A with inhibitors during acute bleeding episode.
Imicizumab.
Incorrect. Criteria used for assigning probability of hit score.
40 score.
Correct. Expand BPDCN.
Pass, sir.
Pass. Okay, you have some time if you want to. Okay. Fourth question was pass for you. Infection associated with cutaneous maltoma. Okay. Right. So the answers are...
Got 3 correct, I think. You got 3 correct.
This one was correct?
No, 4th correct.
4 correct answers for you. 4 correct answers, so you get 40 marks for it. The answers are factor 7, KIT mutation, Upsa-Sullman, Borrelia burgdorferi, polatuzumab, recombinant factor 7 or FIBA, 40 score, and blastic plasmacytoid dendritic cell neoplasm. Okay, with this I think we have completed the quiz, all 6 rounds of quiz. A big round of applause for all the team participants. They have come a long way from Srinagar, from Amritsar, from Tanda, and from Rohtak. So all places around the north zone, they have come here to play the quiz. A big round of applause for them and for our scorers and our timekeepers and our volunteers here who have all helped us for the quiz. And
my special thanks especially to Professor Inadas ma'am, Professor Pankaj Malhotra sir, both Sri Jayesh as well as Arihant for giving this quiz a platform, and this means encouragement for all the teams, and they've been, thank you for making their stay, their registration, looking after everything related to the quiz for them, and it's made a very enjoyable experience, I hope, for them, and it's being, a lot of responsibility load for us personally because it's been taken care by their team. So thanks a lot from National ISHBT from my end, and I think everybody here would have enjoyed this experience, including the teams. So I'll request the scorers if we can get the winners and the runners up for this quiz.
Winner is Team E with score 215. And first, 215. And first runner-up is Team A with score of 160. And second runner-up is Team C with score of 145.
What D and E?
And Team D scored 130 and Team B 85.
So everybody fought well. That's great. That's great. That's okay.
I thank you, sir, for being my mentor, and I thank everybody here for all the participants here who actively participated in the quiz and won many prizes. Okay, and now I hand over the stage for the valedictory function. Thank you. I request the quiz participants to stay here and receive the certificates on stage, and please leave. Thank you so much for coming.
Now we proceed for the much-awaited prize distribution ceremony. I would like to call Dr. Pulkit Rastogi on the stage for the same.
So I request everyone to please stay in the hall for the much awaited prize ceremony. In the various, so we got around 148 abstracts during this Pgi-Hem-Onc Fest. So it has provided a wonderful platform for the brightest mind to present their research, and we had a excellent oral presentation session post-lunch. So can I have the slides for the prize distribution list? So for prize distribution purposes and evaluation, so there were about 12 judges for evaluation of 148 abstracts, and we have shortlisted the winners in the various categories as highlighted here. So for prize distribution, I would like to call Verma sir and Verma ma'am and Reena ma'am to please come on the stage and do the honors. Welcome, sir. Welcome, ma'am. So we will start with distribution of prizes for the e-poster sessions. So we have split the prizes into the clinical and the laboratory field, and among further splits we have divided on the basis of benign and the malignant category abstracts. So among the, I will call first the clinical categories winner. So among the original study in benign clinical category, the first prize goes to Mansi Gupta from CMC Ludhiana. Please give a big round of applause. Her study was entitled Comparative Outcomes of Related and Unrelated Donor Transplants for Beta Thalassemia. It was a single center experience. She's not here? Okay. Then the second prize in the clinical, okay. Okay, so I request ma'am to collect on her behalf. Yeah. So ma'am is collecting on behalf of Mansi Gupta. Please give a big round of applause. The second prize in the benign clinical category goes to Urmimala Bhattacharjee from PGI, Department of Clinical Hematology and Medical Oncology, who did a study on the complications of splenectomy after transfusion-dependent thalassemia patients. The third in this category goes to Dr. Suvir Singh from DMC Ludhiana, who presented an interesting study on ChatGPT in Hem-Onc manuscript composition. So anyone from, is he here? Okay, he has left. Okay, so the next category was of clinical studies in malignant diseases, and the first prize goes to Disha Ann from PGI, Department of Pediatrics. She did her study on the evaluation of myelosuppression in childhood ALL. Is she there? Someone from the pediatrics? Prateek sir is here. The next in this category goes to Tanya Sidana from PGI, Department of Pharmacology, who did a study on the outpatient parenteral antimicrobial therapy, OPAT, using elastometric pump. Is she here? Okay. Alka ma'am is here? Yeah. Alka ma'am was one of the co-investigators in the study. The third in this category goes to Anu Kumari from Department of Pediatrics. Her study was interesting in studying the cell-free DNA levels and its correlation with pathological parameters in newly diagnosed DLBCL patients. Next, we have the laboratory categories, and in the benign diseases, Shilpa Matya from PGI, Department of Pediatrics, got the first prize on her study on evaluation of telomere length in pediatric bone marrow failure cases. Is Shilpa here? The second prize goes to Anita Giri from the Department of Pathology. Her study was on evaluation of unghosted cells in the CBC counter-derived RBC research parameter for its utility in the, as a diagnostic and its implication spectrum of pathological conditions. The third prize goes to Vasant Kumar from Department of Hematology from PGI in his study on determination of ADAMTS 13 levels in suspected TTP. Next, we have category of laboratory studies in malignant diseases, and the top scorer here is Tharageshwari from the Department of Hematology. She did the evaluation of CD4 as a marker in differentiating T-ALL blast from mature T cells and NK cell. The second in this category goes to Aishwarya Dash from Department of PGI Hematology. She did an interesting study depicting the association of TP53 aberrations in routine as a routine investigation patients of multiple myeloma. The third prize goes to Yukim Dong from Department of Pathology from PGI in her study for TRBC1 as a promising flow cytometry marker for clonality detection in mature T-cell lymphomas. Now we have the nursing prizes. So the top prize in the nursing category goes to Navdeep Kaur from PGI 9. She did an interesting study on impact of nurse initiative intervention package on the prevalence of selected complications among the patients of chemotherapy. So Navdeep Kaur is here. Dr. Arihant is here, so to collect on her behalf. The second prize in the nursing category goes to Sangeeta Samuel from Christian Medical College, Ludhiana. She did an interesting study on learning together for better patient care, a module development or interprofessional education. So we have ma'am on her behalf. We have certain posters from the technical category, and the top scorer here is Mrs. Praveen Latabose from PGI Chandigarh, Department of Hematology. She did an interesting study on FLAIR as a standalone reagent for detection of PNH clones. So among the other miscellaneous allied categories, we have Parul Kraft from Christian Medical College, Ludhiana. She did an interesting study on evaluation of medication error rates in clinical hematology. Then we have the case series, case reports, and reference establishment studies. The top scorer here is Sudhanshi Rena from Department of PGI Hematology. She did establishing reference range for relative telomere length in the normal Indian population. The best case report in clinical category goes to Kevin Soju from CMC Ludhiana. Someone from Ludhiana. This was the presentation of MPN with translocation 915. Second best case report in clinical category is from Department of CHMO PGI by Dr. Jaswinder Kaur Chilana. Is she here? Dr. Arihant, can you collect on her behalf, Dr. Jaswinder? Acquired hemophilia, rare bleeding disorder from the CHMO. Yeah, he was one of the co-authors for the same. And among the laboratory studies, the best case report award goes to Aishwarya Karthikeyan, where she presented 3 cases of hypereosinophilic syndrome with clonal T cells and with a different clinical course. The second best case report goes to Ranganath HS from Government Medical College, Chandigarh, 32. It was on Epstein-Barr virus associated HLH. The last category was on laboratory technical note or advances, and this award goes to Ankit Patlan from Plaksha University and IISER Mohali. He presented an interesting study on automated estimation of bone marrow cellularity using image analysis. So this finishes the e-poster categories, and now we have the oral presentation awards. So first, I would like to start from nursing science, and the award goes to Asha Fernandez from Christian Medical College and Hospital, Ludhiana. Everyone knows the interesting study by ma'am on the cognitive bias that lead to near misses and errors. It was a cross-sectional exploratory study. Among the clinical categories on malignant disorders, the first prize goes to, both the prize goes to Tata Memorial Hospital, the first one to the Keshav Garg. Anyone from TMH? Nishant or? So they have left. So the first prize went to Keshav Garg and the next prize went to Lakshmana Reddy Makila. So among the benign disorders in clinical categories, the first prize goes to Pavitra DS from Christian Medical College, Ludhiana. She presented her study on optimizing hemophilia surgeries. The second prize goes to Pradeep Reddy from PGI Chandigarh, where he investigated the role of telomere length and clinical outcomes in adolescent or adult onset aplastic anemias. And among the laboratory studies for the malignant disorders, the top prize goes to Shelly Singla for her study on impact of TP53 deletions and mutations in the outcome of newly diagnosed multiple myeloma, NDMM. The second prize in oral category for this goes to Sonali Mishra from AIMS Rishikesh, where she presented the role of next generation MRD Euroflow based study. Is Sonali? Yeah. The last category was of laboratory studies with benign disorders. So here we had a tie, and both have been given adjudged as the first prize, both Namrata Singh from PGI Chandigarh and E. Nitya Parvati from PGI Chandigarh. The one was on beta thalassemia angiography study, another one was clot waveform analysis in distinguishing LA from hemophilia A. So both please come together. So with this, we concluded the prize distribution ceremony for the posters and the oral. Now I hand over mic to Dr. Praveen Sharma for distribution of prize for the quiz. Sir, please, just for
So for the National Hematology Quiz North Zone, may I request Dr. Pratik Bhatia to be on the stage, please? Yeah. So Dr. Samisha Thapa, Dr. Prabhat Rijal, and Dr. Gajendra Yadav are the winners of North Zone, and they are proceeding to the National Hematology Quiz to be held at hotel in Bhubaneswar.
Please come.
They are from AIMS Rishikesh. Next, we have team from GMC Srinagar. A big round of applause for Sana, Zafra, and Insha to be the runner-up. Next, we have from PGI Rohtak, Preeti Punia, Piyush, and Dr. Nitish. I request the team to wait for a final group photograph. Next, we have GMC Amritsar, Dr. Navjot, Dr. Tania, and Dr. Parampal. We have RPGMC Tanda, Dr. Naveen, Dr. Nandita, and Dr. Tania. May I request all the teams to come on the stage. All teams, team A to E, please come on the stage to have a group photograph. All the volunteers of the quiz also, please come on the stage. Yes.
So, ma'am, with your permission, Dr. Joseph John is with us, and he's the person who first time actually conceptualized this idea of hematology quiz. So a big round of applause to him. And this is the 11th year we are conducting this quiz. So the history is that on 11th November at 11 a.m. in 2011, the first ISHBT quiz was there, held in this very hall.
a special announcement will be made. All the winners of the poster and oral papers will get free copy of PGI textbook. Now I would request Professor Reena Das ma'am to please give the final remarks.
So final remarks is a very big thank you for all the people who came here and made this a successful endeavor from us. Our team, which is in PGI, they have done a wonderful job. My faculty, my students, and all the departments, clinical medicine, all departments, pediatric, excellent. I think we are all dependent on the support system. And now I wish that we'll have, I hope next year again, a similar kind of a program. And I would like all of you to join us for a cup of tea before you all leave to your homes. Thank you.
Thank you so much.